Good morning, everyone. Today we are going to present a case presentation on oral cavity malignancy. Here is the 57-year-old male who is married, former by occupation, hailing from Kurinjipudi and belonging to low socio-economic status, presented with the complaints of ulcer over the right side of the tongue for 3 months. History of presenting illness: he was apparently well 3 months back when he noticed the ulcer on the right side of the tongue while brushing his teeth, which was insidious in onset, gradually progressive, initially small in size, gradually progressed to current size of approximately 2 into 2 centimeter, extending to the floor of mouth, which is not associated with pain. History of difficulty in chewing, speech due to restriction of the tongue movement, and history of excessive salivation, history of bad odor from the mouth. There is no history of sharp tooth trauma and dental intervention, no history of loosening of teeth, no history of loss of taste sensation, no history of bleeding or pus discharge, no history of loss of appetite or significant weight loss, no history of any other swelling in the body, and no history of high risk behaviors, and no history of ear, nose, throat related complaints, no history of suggestive of distance metastasis. Past history: he is a known diabetic and hypertensive for the past 6 years, and he is on tablet metformin 500 mg BD and amlodipine 5 mg OD respectively, and no history of chronic illness such as tuberculosis, asthma, seizure disorder, and no history of any medical and surgical or any dental intervention, and no history of any allergy, no history of drug intake. Personal history: patient used to take mixed diet, bowel and bladder habits are normal, and he is having a normal sleep pattern, consumes tobacco in the form of quid 8 to 10 times in a day for more than 15 years. He used to keep in the right lateral sulcus of the mouth, and there is no history of alcohol consumption by the patient. Family history: there is no significant family history and no history of head and neck malignancy in the family. And summary of the case: a 57-year-old gentleman, resident of Kurinjipudi and former by occupation, who is chronic tobacco abuser in the form of quid for more than 15 years, presented with painless ulceroproliferative lesion over the right side of tongue, which was extending to the floor of mouth and associated with excessive salivation. By this history, we can suspecting the case of carcinoma of tongue, which is extending to the floor of mouth. For the examination purpose, I will give it to Dr. Shobhi. We'll continue with the examination.
Coming to the general examination, the patient was examined in sitting position under broad daylight. He was conscious, alert, cooperative, and well-oriented to time, place, and person. His ECOG performance status was 1, and he was nutritionally well preserved with a BMI of 22.1. His pulse rate was 78 per minute, measured in the right radial artery, regular rhythm, normal volume and character. Blood pressure was 134/78, measured in the right arm in supine position. Respiratory rate was 18 breaths per minute, which is regular. There was no pallor, rectus, clubbing, cyanosis, or pedal edema, and no generalized lymphadenopathy. Coming to the systemic examination, his systemic examination was normal. And coming to the head and neck examination, starting with the inspection. Coming to the head and neck examination, starting with the inspection, facial symmetry was not distorted. No fullness was noted along the face. There was no skin erythema. Mouth opening was adequate, and there was no fullness in the neck. The tongue was not freely mobile. There was difficulty in protrusion of the tongue. There was loss of dentition, poor oral hygiene with nicotine staining of the teeth. There were dental caries and overcrowding of the teeth. There was an ulceroproliferative growth noted over the ventral surface of the tongue, extending to the floor of mouth, measuring 2 × 2 centimeters, with irregular margins, everted edges, and sloughed with necrotic material in the floor. The buccal mucosa was normal. Soft and hard palate was normal with uvula in the center. Right gingivo-buccal sulcus was free. Retromolar trigone was free. There was no leukoplakia or erythroplakia and no other synchronous lesions. Coming to the palpation, there was tenderness noted on palpation. Inspection findings were confirmed. No local rise of temperature. Mouth opening was adequate. There was an ulceroproliferative growth noted in the ventral aspect of the right side of tongue, extending to the floor of mouth, which was firm to hard in consistency, with irregular margins, everted edges, sloughed off base with necrotic material, non-mobile, fixed to the floor of the mouth, which does not bleed on touch. Coming to the examination of the neck, the trachea appeared to be central. Right level 1B discrete lymph node is palpable. Common carotid pulsations are felt bilaterally. Examination of the cervical spine was normal, and examination of the ENT and scalp was normal. Coming to the summary, a 57-year-old gentleman, a resident of Kurinjipadi, farmer by occupation, who is a chronic abuser of quid for more than 15 years, presented with a painless ulceroproliferative lesion over the right lateral aspect of the tongue, extending to the floor of the mouth with excessive salivation. The general examination was essentially normal. The local examination showed ulcer in the ventral aspect of the anterior two-third right lateral aspect of the tongue, measuring 2 x 2 centimeters with irregular margins, everted edges extending to the floor of mouth, which does not bleed on touch, with a palpable right cervical lymph node. Based on the history and the examination, my provisional diagnosis would be a case of ulcerative type of carcinoma tongue on the right lateral aspect of anterior two-third of the tongue, extending to the floor of mouth with metastasis to the right level 1B neck lymph node. Coming to the TNM staging, C T4A N1 MX would be my provisional TNM staging of this case.
That's a good presentation. Just want to ask a few questions. Like you asked for this higher risk of high risk behavior. What are the risk factors in oral cancer and why did you ask this?
Patient may be multiple sexual partners, or which is a precursor for the HPV. So human papilloma virus, which is a condition where the 60 to 80% of the cases who are already diagnosed with the carcinoma of tongue, they are already with HPV will be 60 to 80% is they are already risk factors, and IV drug abusers also.
Yeah. What are the other risk factors?
By for the carcinoma of oral cavity, the like lifestyle behavior of the patient, where the diet will be the one. In lifestyle, tobacco, alcohol, and patient might be having HPV high risk behavior, and dietary where vitamin A deficiency will be there. Yes, sir. Smoking, spices, spirit. Yes.
Basically, what are the carcinogens regarding smoking and quid use that is important? The most important is you say a quid, patient takes quid. What are the two important components?
Aricoline and tannins.
The components of the quid will be tobacco and the nut.
Betel nut.
Those are the most important. And so that's what you mean by smoking. So you must understand that smoking is not just smoking. Alcohol, spirit.
Alcohol, spirit, which acts as an which removes the defensive factor by removing the defense factor, and then whatever the nitrosamine which produced by nicotine, it will be very easy to enter this.
So smoking, spirit,
Spices.
So we'll come to that. That's probably last issue. The other is trauma. It's sharp tooth. That's what it is. So sharp tooth only means dental
Intervention.
You can have people who have ill-fitting dentures. That's one common thing that we see. They change the denture and then they get a lesion over the alveolus. Or a sharp tooth that can be exposed. Maybe it's maybe overdone, but in some cases you have no other factors. What is, you say sepsis? Is sepsis an issue?
Yes, sir. Sepsis is an issue.
What kind of sepsis? So you must understand when we say sepsis, what we mean is what you have covered, dental sepsis. You look for caries or not.
Yes.
The reason that they say is that the bacteria kind of convert protocarcinogens to carcinogens. So generally it's important to make sure that dental hygiene is optimal. We'll come to this in the follow-up. I'll ask you again. The other few things are like sunlight if it is regarding lip and sexually transmitted disease. Now, when I say that, we are no more talking about syphilis as we used to do before. Syphilis used to have this romanticizing. What are we talking about is HPV, pure HPV. But what is HPV cause? So in oral cavity, it's virtually way low down. In fact, if you look at the NCC guidelines, also we don't check for it here. In oropharyngeal, it's important. So when you say tongue, if it is a base of tongue lesion, yes,
Yes.
it is important to check for HPV. And it is related to a certain high risk sexual behavior that is that. So that's why oropharyngeal exists. But oral cavity almost almost no. It's very, I mean, it's almost not existent, or we don't usually check. So HPV 16 and 18, you can, when you come to manual, you also said something about lymph nodes. Okay, yeah. What family do you know?
Family history, because in the case of there is mutation of RAS and MYC, deletion of this chromosome 16 and 18. So Fanconi syndrome, which is risk factor for the Fanconi syndrome is one where the hereditary factors will be there. Like it will be hereditary. It can transfer to the other swelling, where we can mention the field cancerization, where the patient might be having a difficulty in swallowing, or which might be compressing the trachea also. These are field cancerization where the normal causative factor is already in a oropharyngeal airway, I mean oropharyngeal passage, where the causative factor is already is a risk factor for in like a field cancerization means like where the causative factor is all which has
The field cancerization is when the causative factors such as tobacco can be responsible for the other cancers in the
in the
primary
same
cancer in the body.
in the
In the oral
oropharyngeal.
cavities.
For the tobacco in any form. Here, the significant point is, it's big. That about 5-6 times a day. So the contact that it is involved in the floor of the mouth. What is the alpha dependent?
The palpatory findings, there was tenderness noted on palpation. There was no local rise of temperature. Mouth opening was adequate. There was ulceroproliferative growth noted in the ventral aspect of the right side of tongue, extending to the floor of the mouth, which is firm to hard in consistency, irregular margins, everted edges, sloughed off paste with necrotic material, and non-mobile, fixed to the floor of the mouth, which is not bleed on touch.
The window rate. You can see, so the palpate, you see the what is exactly the window rate to less than beyond the ulcer, which is visible. So that is very important. Actual size, what you see is the palpate. The both will by limit more larger than the actual size of the.
Yes.
What clinician is not expecting to impact in the infection carcinoma?
Sir, in case there is involvement of the branches of the facial nerve, sir, like the marginal mandibular, or if they might, we can ask the patient.
No, asking me the term, severe term, facial executive. Very careful from outside.
Where the tumor has involved the mandible and the maxillary sinus, where it might be a distortion of the facial symmetries. The extensive tumor.
No, I think that's unlikely. The facial nerve can only be involved if you have extranodal extension with a node that is there either in the level 2B or level 2A or 1A, 1D. So these nodes are, however, you not mention the size of these nodes. When do you call a node significant?
When
Yeah.
so it's more than 10 mm, sir,
Okay.
1 centimeter.
Anything else other than just size?
There is loss of fatty hilum.
So that's radiologically. Any fixity which would suggest extranodal extension, all right? And if it is hard, okay, or rounded, these are things that may be palpable, it's not very sure. So in level 1B up to 1.5 centimeter on short axis diameter, that's radiological definition, can be, considered as, insignificant. Coming to this palpation, there's one more thing that you can look at. This is a patient who's putting a quid in the sulcus, so you should palpate for submucous bands. Many of them will have fibrotic bands. You've said mouth opening is adequate, but sometimes even with this normal mouth opening, you may get bands that are palpable. And often more on the side where the patient keeps it. So you have covered all that. In your diagnosis, you've said it's a T4A lesion. Any reason to say T4A?
Sir, we on palpation, sir, we noted that there was a difficulty in the protrusion of the tongue and on inspection, as well as on palpation there was the tongue was
What we
fixed
are
to
waiting for another common report. Moment of the time to put hearing artery means just mouth opening is the lesion is in the tongue. The moment of the tongue and the other things also must need to be. How will you do Christmas?
Sir,
Any good value Christmas? Christmas reading. Don't know what opening the required.
yes.
What is how the reading.
Normal mouth opening will be 3 centimeter between the incisors.
You cannot measure 3-4 centimeters. So
Like we usually we use 3 fingers or 4 fingers between the incisors.
maybe like that 3, 2, 1 like that.
I think we go ahead. Can you go on to the management? What would you like to do next? I'll come back to this T4. What would you like to do first?
First, I will get a imaging, sir. First, I will proceed with the CCT, and I will
First we'll basic investigations of blood investigations. Along with we'll take biopsy from the incisional biopsy from the ulcer, and then we have a palpable node, so we can take a FNAC from the to confirm the diagnosis. And next we go through CCT, which will get the picture of the extension of the ulcer or the tumor, and if any suspicion of soft tissue, we can get MRIs.
What perhaps you take, it's not one perhaps what else you put.
will proceed with the incisional biopsy.
Take it to
Like carcinoma tongue, we can get from the edge of, we can get the biopsy. Yeah, then to involvement of the soft tissue, which extension of the tumor into the facial.
Okay, so you've done your biopsy. What are you expecting as a report in this patient?
We expected the squamous cell carcinoma based on the uvata edges.
That's true.
Is
So 95% of malignancies in the oral cavity are squamous cell, and with the presentation and the risk factors that you have mentioned, that's what you would expect. Now, in your imaging, what would you prefer, CT or MRI, and how do you make the choice? Here, this for this patient, let's talk about. You got a lesion infiltrating probably the floor of the mouth
yes.
and the probably wound. What would you choose between CT and MRI?
A CT is
Okay, so you can choose an MRI because here you're not looking for bony involvement. Whenever you have doubt of bony involvement and you want to plan your surgery, you would prefer CT. Again, in bony involvement, there are certain reasons why you will look at MRI. It depends on the extent of bone dissection. If you want to look at, for example, the mandibular canal and its involvement, whether it's how far you have to dissect the bone. Again, MRI would come into picture there. So mostly bony erosion, CT. If it's annulus, buccal because of generally we prefer CT because many of them have bony erosions. And if you still want to look at the extent of soft tissue within the bone or outside of it, you will require MRI.
Yeah.
So in this patient, MRI is fairly good enough to tell you. What would you like to see in the MRI? You're doing an MRI. Can you give me 3 things that you're looking for? Broad areas there.
Sir, we would like to look for adjacent soft tissue involvement like the muscles of the tongue, if there is involvement of the muscles of the tongue.
is there.
There's
So I'll just say broadly what you look at. See, there are 3 things that you must look at. One is the local lesion. Are you looking for signs of inoperability? Okay. Secondly, you look at nodes. It's a way of evaluating nodes. And thirdly, because this is oral malignancy with tobacco being used, you are looking for a second primary. Obviously, second primary needs a little more detailed evaluation data. So this is what you're looking at. So what would make tongue inoperable? It's difficult to say, what is inoperable to one is operable to another. But what would generally be looked for?
So if the lesion is extending involving the masticated space, involving the skull base and
This lesion, this is not going to retromolar trigon, so it's going deep. So what would you look for? That is one concern. What you said is correct. But in this lesion, when it goes deep, where do you want, what are you worried about? So if it goes down to the larynx, basically. So it's not like you can't remove the larynx, but most patients won't accept the mobility of having their tongue and larynx. Most patients will not. And we have to accept that it's fairly advanced at that stage and trying to do a heroic surgery may not be the best interest of the patient.
You told masticated space in one time. Where is the masticated space? Where is that one?
So that's signs of inoperability in the lesion. In the node, if you get a node, what are the things that you're looking for? That would change your management here. According to your clinical examination, you're holding one node that is in the right side. So important things are to look if a node is inoperable. The only reason why a node becomes inoperable is if it's very large, involves extensive skin or pre-vertebral. Very unlikely here. What you are looking for is contralateral nodes. And if they are suspicious of radiology, you may have to address them. For a lesion that does not cross midline, ideally we don't have to address the opposite nodes. But if they are suspicious of radiology, then we may address them. We may address the contralateral nodes as that is upstage the disease. Then, like I said, you look for a second primary. Better the CT in those cases, not MRI, because of the motion artifact that you get, which is higher on MRI. CT is better to look for a second primary. I think with that you've covered imaging. So if you've done your imaging and you find there's just this node and you have lesion in the tongue not infiltrating into the larynx, what would be next?
counseling the patient regarding the next.
So the next step is you need to do your distant imaging. All right. So what is in the way of distant imaging? What do you do?
For the metastasis purpose.
Yeah, medical. Sorry.
So thorax abdomen will take, mostly in the oral cavity cancer, that will be, first pulmonary will be involved. So we have to take CT thorax We have to rule out the pulmonary.
Do a PET CT first.
Yeah, okay, so regional, but it's not required. The incidence of distant meds in, ovarian cancer is usually 5 to 10%. We often do a chest X-ray or a low-dose CT is what is recommended. So you may do any of that. So you must do that before you go ahead with the next steps. So if this is done, then what do you do next? You have low metastasis, you have a local regional disease. What next?
So T1 and T2,
Sorry.
this will based on the based on the imaging finding, it is not involving the floor of mouth. We can consider it a T2. So plan for excision. So margin, we will give a margin of 1
We
centimeter.
can plan for a wide local excision, sir, with a margin of 1 centimeter.
Yeah, I think it's pointed out to here that your lesion is crossing the midline, right? Yeah, that's what it says on the imaging. Let's go by the findings here that you have lesion crossing the midline. And so floor of mouth involvement does not make it T2 or T4. With the latest incision staging, we go by depth.
Yes.
Okay, we used to look at extrinsic muscle involvement, but the problem was in pathology, it's impossible to say which muscle is which. You may have muscle involvement, you do not know if it is intrinsic or extrinsic. So how do you characterize? So the latest incisions have all changed to depth as the most important characteristic. If you have more than 1 centimeter depth of involvement, it may be T3, based on the size of the lesion. So that's all that we look at. No more do we talk about floor of mouth, extrinsic muscle, etc. So you have a lesion crossing the midline and no distant meds. What would be your plan of management?
So we can plan for a wide local restriction with wide local excision with the 1 centimeter margin along with the bilateral modified radical angle decision.
What precaution do we were doing the right side and left side? Most important for the reconstruction. In the artery or what is the artery of vein?
IG, we have.
Education result for the reconstruction. Because the latter part of the time for the reconstruction purpose will be the radial artery for further we will get to preserve the facial artificial vessels in the neck for the anatomosis purpose. Fine. Next is actually unilateral bilateral.
Bilateral one, sir, since the lesion is crossing the midline.
Of turnovers. All right. There will be non-critical.
Yes, sir.
Yes, sir.
Yeah, so you do the side which has a node that is suspicious gets the modified radical neck dissection. The opposite side, if it does not have any suspicious nodes, just because it crosses the midline, we do a
Selective lymph node dissection.
1 to 3.
So, like you said, so this recon, I'm not going to go into it, like up to 1/3, generally they say you can close primarily wherever possible. But 1/3 to 2/3, you use certain flaps, and more than 2/3, or if you use a total possibly use certain flaps for recon, which is okay. That's a few questions. Like, for example, if this node is not significant, is there any other management alternative? In the neck dissection part, yeah. Other than neck dissection, is there any way of escaping that?
Sir, like in the US, they were explaining that you can give a trial of bilocal excision with sentinel lymph node biopsy.
Yeah.
Or you can do an intra-frozen section. Sir.
No, frozen become mandatory nowadays for all the cases. In JIPMER, what we are not doing sentinel for the we are not doing. And what you do? One thing is the doubtful, and what you do.
Mm.
They would be central for the positive woman about it. If not, going to selective reception.
Okay.
Okay, so central lymph node biopsy has not taken off very well in cancer for various reasons. One is the morbidity of an elective neck dissection in the N0 neck is quite okay, acceptable. And there are multiple studies that have looked at the false negative rate of an SNP. It's not in routine practice yet. That said, you need all evaluation for nodes before you can do a SNP, and you have various other issues. Now coming to this surgery, suppose you have finished the surgery, what are the high-risk features you look for to give adjuvant? What are the indications for the adjuvant?
Adjuvant positive lymph nodes.
What adjuvant do you want to give? Radiotherapy or chemotherapy?
Like I would want to give radiotherapy, sir. Adjuvant
Radiotherapy for adjuvant. In both of this, what do you think? To give adjuvant.
So there are things in the tumor and node. Okay, just divide it like that: tumor and node. So PT3, PT4.
T4 requires radiotherapy. Sir?
In the tumor itself, PT3, PT4, that's the stage. Then you have close margins or positive margins. Close margins are defined as less than 5 mm.
Yes.
Or positive margins. Okay. Then, if you have lymphovascular invasion or periodontal invasion,
extranodal extension.
then when you come to nodes, you have N2 or N3. That is more than a single node. N2, N3 is definite. N1 you may consider. N2, N3 and extranodal extension are all indications for giving radiotherapy. Again, there are some other things that are mentioned, like if the node is in a very low location, that is below the cricoid, that is level 4 or low level 5, then also you must think that these patients are having a very high chance for an aggressive disease, and you may give radiotherapy.
You're taking most of chemo
And stage 3, stage 4.
Sir, like as I said, if there is positive margins or if there is external extension, then we can give positive.
No, chemotherapy, when you add the chemotherapy along with the radiotherapy.
Sir,
Indication.
sir, if there is positive margins less than 5 mm,
Post starting degree, doesn't have parameter. In possible, real positive or positive degree post starting. When you got chemotherapy,
sir, if there is also extranodal extension,
fine. How much dose you need for the post radiotherapy?
60 to 65 degrees.
70. Fine.
Okay.
When do you palliate to the dose of palliative? So this is not for the palliative for the dose of palliative.
No.
That's a 50.
Yeah, so chemo is extranodal extension or positive margins only. Those are two indications where you give chemo. Again, you have to look at the functional status of the patient, because remember, you've done a surgery where swallowing is probably inhibited. So you have to look at that. How do you follow up these patients? You've done the surgery, chemo, adjuvant, everything's done. What follow up? So here is where, some people do advise a baseline PET scan so that you can, that's again, at least 3 months after radiation. Nothing before that. Okay? You get 2 false positives. So anything after 3 months, you may do a baseline PET, especially in a patient who has a pathologically higher stage disease. If you feel it's high stage, it's just a baseline to look at other findings that come later on. That may be done. But important thing that you must advise the patient is modifiable risk factors. Remember we said that? Yeah. So what are the modifiable risk
The
factors?
speech therapy, if patient needed speech therapy.
Okay, those are rehabilitative measures. That's also correct. You have to do rehabilitative measures. And modifiable risk factors are smoking, alcohol. Yeah, all right. And dental hygiene is something that must be stressed to patients, because these are things that lead up to cancers. Then the regular follow-up, you have monthly and yearly all the way till 5 years.
Pathology was number, all points are good. Grading of the tumor always gives very good response. Because the tumor is very poorly or undepleted, your response to other modalities also may not be as good as protein or any reason or not? RCM, the journals. Wherever it's one of the different. Because of some people, but pickup rate is very. And again, the human partners get a little. Alpha and alpha. Also nowadays, they are using it. I mean, clubbed with artificial intelligence. The screening, helps more detection of cases in the early stage. Because of this,
Thank you, sir.
Thank you, sir. Okay.
Thank you, sir. I now request the examiners to award the certificate of accreditation.
You wanted to keep it connected, sir?
I don't know the speed.
That's what I thought, like if you transfer it, it would be fast. You can delete it.
I now request the examiners to award the certificate of presentation to Dr. Shivanand. Dr. Shobhan. May I now request Dr.
Mouse color, this pointer color can be changed.
No, I said.
No, this okay.
Slide changer we have, sir.
Dr.
Which is a this light changing. Hmm?
And Dr. Sheena GSM. Thank you, sir. Next, we have a video. Next up, we have a video lecture on minimally invasive management of gastric cancer by Dr. Vaidishwaran V. I welcome sir to the dais.
Good morning. Since we are already running late, I'll go straight to the presentation. Good morning to my esteemed teachers and the rest of you. So my talk will be on gastrectomy, laparoscopic gastrectomy. It's not playing. Yes. So it will be a total gastrectomy video. The main aim is for the postgraduate is to know the anatomy of a D2 resection. So basics of laparoscopy. Yes.
May I now invite the chairpersons for this session onto the dais, Dr. Robinson Smile, Dr. Fani Krishna Ravula, and Dr. Rajkumar Rao.
Good morning, chairpersons.
Is going to be from the school days.
It is cutting.
Was even my
Elevate the
son's
laptop.
classmate in the school after that in JIPMER, Indian college. I'm very proud to say one of our best products of JIPMER. He specialized in minimal invasive surgery. And he comes out for later. And he's well known minimal invasive surgeon in Chennai and around. And many VIP people about him. The last one was former. Oh, yes, back to most of the time, we spend a lot of time attending conferences, giving programs, workshops. And they always attend any program in top. He has many honors. And
I feel nervous to present in front of my teacher and more nervous if they give me introduction. I'll present, sir. You know, I don't know whether you students feel tense when you present in front of your teachers. I am just feeling like I am presenting on the afternoon seminar every day in surgery department in Blalock Theatre. So I made sure I came exactly on time because my teacher, I should be before my teachers today. I got up at 5 and I made sure I was here before them. Good, that is surgical discipline that they have instilled in us, and for what all we have achieved, I am sure all of us owe it to our teachers who are here. And quickly I'll go to the presentation. So the aim of this presentation is for the postgraduates to know exactly what is a D2 lymphadenectomy. So some of the parts I've edited such that you will know the anatomy well. Then shortly about the case, it is a poorly differentiated adenocarcinoma. We gave 4 cycles of FLOT. It is a proximal growth OG junction type 3 actually. The total gastrectomy was the plan. So these are the port position. See, I'm not able to, the slide is not moving in this, so I cannot point anything. These are the standard upper GI ports. So the camera port will be above the umbilicus so that you can see the hiatus also. Basically, you have to reach the hiatus also during the section. The right hand working port will be in the mid clavicular line. The left hand working port will be in the left hand working port will be in the mid clavicular line again on the right side of the patient. Then one retraction port will be there for the liver and one retraction port for the stomach. That retraction port will be anterior axillary line. So this is standard upper GI port. Any upper GI surgery, if you can understand this port, you'll be perfect triangulation will be there. So we stand between the leg of the patient, but the Koreans and the Japanese will be standing on the right side of the patient. If you have to stand on the right side of the patient, the port orientation will be slightly different. Then you can also operate from the left side of the patient. You can operate from the left of the side of the patient in this port orientation also. So what are the lymph nodes? You would have read about that. So station 1 to 12A is the standard D2 lymphadenectomy for total gastrectomy. Station 1 to 12A will be the standard lymph node dissection for total gastrectomy. So if it is a distal gastrectomy, there are three groups of nodes we will not be dissecting. That is station 1, station 2, and station 10. So these three nodes will not be dissecting in distal gastrectomy. Sometimes the distal splenic nodes also we don't dissect. And the prognostic, the complete dissection of the lymph nodes is absolutely essential for good prognosis. And one more thing we do is by a thorough lymphadenectomy, we are avoiding radiation in the post-operative, adjuvant radiation in case the patient is lymph node positive. So first is the survey, then second is you have to give a wash, and cytology is absolutely essential. Then we do exposure of the stomach. So minimally invasive is maximally exposure. Maximal exposure is needed. So what we do, different techniques are there. You can do retractors are there, Nathanson's retractor, or needle holder, or a fan blade retractor. Here, because the left lobe is very huge, I am using a hanging technique. So first step is I'm checking the operability, that is the crus. So this is the right crus, and I'm checking the operability because it was a distal, reasonably fairly advanced post-neoadjuvant case. So I want to show that it is operable. Once I am sure that it is operable, next step is station 6 nodes, that is the infrapyloric nodes I want to remove. So what I do, remove the right colon away from the gastroepiploic. So traction, the stomach is capillary traction is there. My left hand will give the traction. So the transverse mesocolon, I separate the transverse mesocolon away. So the transverse mesocolon will go away. The gastroepiploic and the lymph nodes will go. This is the midcolic vein, gastrocolic trunk. So all the fat on the transverse mesocolon will go this side, and slowly I will dissect the vein. That's the left gastroepiploic vein. Sorry, right gastroepiploic vein. So all the named vessels we have to double clip in open also. All the named vessels you have to double tie. So once that is done, then the artery I isolate. So this is the surface of the pancreas. This is the or take off of the right gastroepiploic from the gastroduodenal. So then after that, once the station 6 nodes are pushed towards the pylorus, then next is the station 5 nodes I have to push towards the specimen. So station 5 means right gastric. So all the right gastric nodes will come towards the right gastric I isolate. Then at its origin from the gastroduodenal or the proper hepatic, I have to completely move towards the specimen. Then D1 I separate. Once that is, you see the surface of the pancreas. This the gastroduodenal will be there. Then this will be the gastroepiploic which I have ligated. D1, D2 junction I have to staple. So you can use a blue stapler or a white stapler. Generally, duodenum I use blue stapler. If the duodenum is very thin, you can use a white stapler also. So when it is a distal growth, you're very particular that you take adequate margin. Since it is a proximal growth, I'm not too bothered, and I just stapled it off. So next step that I have to do is, so next step I have to do is upper border of the pancreas. I have to define and go towards the lymphadenectomy of the celiac, proper hepatic. Nice. To start the screen sharing, my screen goes off. We'll sort it out later. Okay, now can you show me my presentation?
Yes, sir.
Hmm. This one minutes. One back. Hmm? Want to share? Yes. Yes.
I think all five of course, right? So how you are going to upscale the board?
I'll upscale the port for the stapler. So usually for the door num, we will see the orientation, the body profile. Either one of the ports I change into the 12 port, the left hand working port.
Predetermine which board.
I don't
So usually
predetermine.
it's upscale.
So upscaling depending on the angle. Where it will load.
Presentation is not responding.
Yes, it is hung.
No.
It is hung. Yes.
So I think on. So in our field, for all of the years, we started. Like almost similar, but one at the umbilicus and make it from that 6 o'clock. And then at 7, 8 o'clock on this side, and one more. And we got so the lower field, we have.
The forward பண்ண முடியல.
We have one of the major, right?
I have to forward, no? Where I stopped.
They're almost. Is it not here? And it's certainly wider.
இல்ல பண்ண forward பண்ணணும்.
At the side.
Sorry for the.
Very obvious.
Yes, tell me.
Also, all your patients, are you looking at laparoscopic, gastrectomy or any particular preoperative criteria in which say.
See all.
The tumor, penetration, you say I'll go open.
See, most of the decision is pre-operative only. Once we decide it is laparoscopic, it is laparoscopic. If I have doubt about epitoduodenal ligament involvement, distal stomach, more chance of intraoperative change of plan than proximal stomach. Proximal stomach is fairly straightforward. If we decide that it is laparoscopic, it is going to be laparoscopic. But distal stomach, when we are not sure of the CBD pancreatic hit, in thin patients, we cannot make out on CT. It is due to loss of fat or it is directly infiltrating that area. So when I'm not able to assess the epitoduodenal ligament extension or the pancreatic infiltration, then I would convert to open surgery. But most of the proximal is a preoperative decision. So all cancers in corporate usually it is affordability. The open gastrectomy is much half the cost of a laparoscopic gastrectomy. So totally financial status also decide which patient will go for laparoscopic and which patient will go for open gastrectomy.
And for the benefit, can you give your thoughts on vasectomy? Why is it not done nowadays?
See, there is enough evidence that shows that vasectomy does not add to survival. Japanese have extensively studied that it does not show any advantage in the survival. But still we do a omentectomy, but we do not remove the pancreatic capsule or the vessels completely. So this I've already shown the right gastric division. See, once the division is done, we concentrate on the other lymph nodes. That is 7, 8, 9, 10, 11, and 12. So, upper border of pancreas we have to define. Once we define the upper border of the pancreas, just above it will be the celiac axis, hepatic artery, celiac axis, that complex. So we identify the hepatic artery, then carefully we have to dissect along the adventitia of the hepatic artery. The easiest plane to dissect either in open or in laparoscopy is extra adventitial. If you leave some fat, then you will not know the vessel and you will force up the vessel and injure. That is the coronary vein or the left gastric vein that goes and drains into the left border of the portal vein. So we remove everything. Then the left, once you dissect the celiac axis off the celiac nodes are completely dissected off into the specimen, then the left gastric will be completely isolated. So your dissection is on the celiac axis, not near the stomach. So the trifurcation you saw, so hepatic and the left gastric and the splenic also you will be visible now. So once that is done, you detach it from the pancreas, the stomach. So upper border of the pancreas, as you define, you will identify the splenic artery. So these are the proximal splenic node. You are seeing the celiac, then the proximal splenic you remove along with the specimen. After that, before we go to the distal splenic and the hilar nodes, we want the stomach out of the way. So we have the luxury in a total gastrectomy, you can do that. The short gastrics are ligated. The gastrocolic ligament is completely cut along with the omentectomy you can do off. The counter traction, you see the counter traction by the assistant. So once you have a good counter traction, you can see the border and then you can dissect way till the hepatic flexure. So we completely dissect the stomach away. So this is posterior to the stomach. The complete splenic artery is seen. So once the stomach is completely mobilized, the proximal division. Since it is OG junction growth, I may bear the crust. This we do not do usually. Then 110, 111, and 112 lymph nodes, the paraesophageal, the supradiaphragmatic, and the parietic also, lower parietic also, you remove in the OG junction growth. So completely you dissect at least 5 to 7 centimeter into the thorax, so that when you fix before you divide, because if you don't fix, it will retract into the thorax, then it will be difficult to dissect. So you anteriorly as well as posteriorly, you have to fix. Once that is fixed, adequate margin 3 to 4 centimeter margin we give, and then we divide. Always it is mandatory to send a frozen section because we cannot revise the margin later on. So if we have to revise, it is during intraoperative only we have to do. So mandatory to send a frozen section. So once the stomach is out of the way, now the distal splenic is very easily exposed and the hilar nodes can be done. So 11P and 10 node lymphadenectomy can be done. As I told you, be on the care should be taken. You do not injure the pancreas. You're on the upper border of the pancreas, then the splenic vein. So this is the bipolar instrument that I'm using, RB bipolar. So it will cut as coagulate as well as cut. So it's very useful for lymphadenectomy and reusable. So it is very cost effective compared to harmonic or a ligation. So completely superior pole of the spleen, completely all the lymph nodes are removed. Inferior pole is left. I have devascularized a part of the spleen also you have seen. So the inferior pole. What is anterior to the, you need not skeletonize the splenic artery and the branches in the hilum. You just have whatever is anterior, you have to remove. That is the last part of the. That is complete hilar node, splenic nodes removed. So once this is only the easier part of the surgery, the more difficult part is the reconstruction. So there are different ways of reconstructing. One we do with the specimen is inserted through a small suprapubic incision. So wound protector we use, the whole specimen will come out. J pouch, I used to do a extracorporeal J pouch is done. So now again analysis have shown that J pouch does not alter the course, the functional outcome of the surgery in the long run. Only initially the intake volume is more, but later on it is not found to be beneficial. So nowadays I stopped doing J pouch, but just for you to know. So what we do enterotomy on the esophagus, then we do enterotomy on the small bowel, the posterior wall of the esophagus to the anterior wall of the pouch, then we make a anastomosis. Now this will hold the thing in position. Now we have to intracorporeally complete the anastomosis. This is technically challenging, especially because you'll be pricking the liver multiple times. So this requires a lot of skill and effort. So you can do a continuous suture or interrupted. Either you can use. Single layer is enough. PDS is usually the preferred suture. 3O is better because the needle is small, so that you will not be pricking the liver again and again. If you 20, you might be prick the liver many times. So nasojejunal tube, we don't do FJ nowadays. We just pass a nasojejunal tube and feed for 3 or 4 days. Then we do a contrast study. Contrast, if it is negative, then we can start negative for leak. Then we start oral. So one more reconstruction is useful. So sometimes it is very difficult to technically difficult for this anastomosis. So if you find it difficult, then you have to use a Orville, Covidian as a stapler. You have to pass the anvil through the nose. It's like passing a rails tube. You have to explain to your show the parts of the stapler and explain the procedure to your anesthetist. Then he passes it like a rails tube. Then after that, I remove the tube. So that is the anvil that is there. Then through the specimen extraction only, we pass the circular stapler. Then this difficult challenge in this is maintaining the pneumoperitoneum. Pneumoperitoneum through this porter, you have to rotate the porter so that it snugly fits the stapler. Then the rest of it is like a circular stapler in the rectum only. So everything should be done under vision so that you don't poke the liver or the heart. All these are sharp instruments. Very carefully you have to do. So I understand for the PGs, it is you're not going to do a gastrectomy immediately, minimally invasive. But you have to understand the anatomy. Learning the anatomy is the most important thing. And exposure. Nowadays, excellent retractors are available. During our days, the total gastrectomy used to be a nightmare. So we used to be the retractor people. I remember Dr. Vishnu Prasad doing a total gastrectomy and I was retracting. It is very difficult to expose and show. But nowadays, we have Thompson's retractor. So very beautifully you can retract. Once the circular stapler is fired, then the blind loop is removed. Again, the contrast is done, and if the contrast is negative, then we start oral. We follow ERAS, and of late I find that I don't know whether Funny will agree. I find hardly any difference in recovery between laparoscopy and open. After many years, 15 years, I found that there is hardly any difference in outcome, including short-term outcomes, discharge time in GI, upper GI, especially gastrectomy and laparoscopic ripples. I find the same number of days for laparoscopy and open because the anesthesia, post-operative care, epidural, ERAS, everything has improved the post-operative outcome in open surgery. In colorectal, definitely we find a difference. Yes. See, though we follow ERAS, I follow tube feeding early. So oral, I do not start early. So ERAS tube feeding, I start early. Nasojejunal Freca tube we do. And I think my teachers will remember my thesis. So we give the tube feeding. Then fourth day, I give the contrast and the screening CT. It's always a CT. Then if there is no leak, then start oral liquid diet. Discharge the patient on liquid diet. Then I call the patient back around fifth day discharge. Call the patient back after a week and then start with the semi-solid diet. Semi-solid diet for a week, then solid should be after 2 weeks.
The laparoscopic surgery still scores better because many institutions still they don't follow ERAS for open. So the institute where ERAS is not followed, complete lap still scores.
It's easier to implement ERAS than to master the skill of laparoscopic gastrectomy. So
It's not the probably the thinking still.
see why I am telling this is after see when we start early, there are so many postgraduates. When something is in fashion, then immediately everybody wants to learn it. But they have to go back thinking that first they have to learn proper anatomy, open surgical dissection, and it is enough to do surgery open in current day because of the excellent post-operative pain with thoracic epidural and so. So if you know laparoscopy, it's not like robot. See, day before yesterday, we saw article in newspaper that robotic breast surgery is the thing. So we do not need a robot to do a breast surgery. So the surgeon had given an interview that it gives magnification. You can wear a loop also. So we should not convey wrong things to the students. So I want to tell the aim is to learn proper open surgery, then extrapolate it as along your career as and when you get a chance. But open, it's more important is the D2. The complete lymphadenectomy and the margins are more important. Avoiding morbidity is more important. Avoiding mortality is more important than whether it is minimally invasive or open.
Any difference in the leak rates or open versus
No, absolutely no difference in leak rate. Almost I don't touch wood, we don't come across leak rate nowadays, maybe because of the staples. If it is open, mostly I'm doing it because it is to be cost effective. Then I do Ansun interrupted single layer esophageal anastomosis with the PDS. Then 2 drains on either side of the anastomosis. The same thing will be followed, and we hardly have any leak. Even if there is a leak, if you continue with the tube feeding, because the tube is far away, it is self-limiting. As long as there is a drain. Thank you so much. Thanks. Yes, Rajkumar. He does better D2 lymphadenectomy. Tell me. Not able to bring the loop for esophageal anastomosis. Yes. Yes. See, again, that's why I tell pre-operative planning is so important. If we think that it will not reach the esophageal margin is more, you're better off with the Ivor Lewis surgery. One, preserve the distal stomach and take it to the middle of the thorax and do it off. If you're doing a total gastrectomy, there are maneuvers to increase the length of the jejunum. One is to you have to go take it retrocolic. You go through the transverse mesocolon. Once we divide the momentum, mostly there is not much difference between the retrocolic approach and the anticolic approach. But in a very bulky colon, then definitely that makes a difference. Then you dissect the small bowel route of mesentery away from the colonic mesentery. Separate it a bit. Then you'll get more extra length. Then if still you are not getting, one more maneuver is to divide the proximal jejunal, preserving the arcade. Then you will be able to mostly, with these 3 maneuvers, you will be mostly.
So the last one you talking about the jejunal based on the fourth jejunal.
Yes, that Kalai had shown one video in the last conference, the same. Then fourth thing that you do is divide the crust completely. Divide both the crust completely. then you will have very good, especially if you're having a Thompson, then you will have a very good exposure. Only disadvantage with that, if you're using a Thompson, you'll be retracting the heart. Anesthetist will be asking you to release it very often. So you have to release the retractor periodically. But using a Thompson with both the crust divided, you will get a very good exposure. Even up to Carena, you can go on anastomose if you have a Orville. If you have a Orville, you can do.
How do you manage post-operative leaks after this?
See, one patient we had a leak last year, very emaciated patient. So two drains were there. So both the drains, we leave it in position. The nasojejunal feeding you continue. You stop for some time, give TPN. Then after that, once your the drain output comes, you continue the nasojejunal feed. Just sit on him for 2 weeks, everything heals. The advantage is you don't have anything. You do a ruin by. So once you do a ruin by, there is no major issues. It's basically saliva and empty jejunal secretion. He'll get away.
You will pass a feed to the stomatus and start. In this case, where do you expect a leak or the asthma didn't go properly? Do you plan for an X-ray or?
No, we don't do. See, FJ, the problem is it also creates as many problems as it secures you. See, last month only we had a leak because of back pressure, kink in the FJ for Whipples. So, so we had to undo the FJ. So FJ once in a while, once in a year at least, if you are, funny will tell that every year one FJ related to complication we'll have. So now nasojejunal tubes are so good and well tolerated. We pass it far away, 25-30 centimeter away from the anastomosis. So no reflux is there. It's a bowel material. Only thing you have to use the infusion pump. If you use the infusion pump and give it at a slow rate, no problem will be there. If you give bolus, then reflux will be there, the leak will be aggravated.
When you decide for a G-junction tumor, whether you should go for a total gastrectomy?
Type 3 total gastrectomy. The distal extent of the tumor will decide either Lewis or total gastrectomy. Type 3 will always be total gastrectomy.
For anastomodic leaks, actually, some of the leaking in mediastinal chest, they have high morbidity. So we have things for the jumbo S removable stent is there, which we use in the sleeve gastrectomy. That is an option. It's very widely used in the West. In India also, if the patient is affordable, that's one way we can. It's covered them and it's fixed proximally, so it can be used to a good salvage.
Yes, that if only if you are not doing a roof. If you have a loop, if you're doing a roof, there's nothing that will leak there once you have a drain.
So, do you follow do proximal gastrectomy?
No, not at all. Not at all. I have zero experience on proximal gastrectomy.
Very high reflux rates, very morbid surgery. Compared to when you anastomose the stomach in the abdomen, chest and neck, the highest reflux rates are when you anastomose in the abdomen. As you come in chest, they become less, in the neck, they become even less. So proximal gastrectomy is not the immediately when we had terrible problems.
Thanks. Thank you so much.
Chairperson, Dr. Vatishan.
இதை வந்து கரெக்டா ஃபேஸ் கொஞ்சம் இதை கொஞ்சம் யூஸ் பண்ணா அப்புறம் ஃபேஸ்
இப்போ ஃபேஸ் வருது ஃபுல்லா இது பாக்ஸ் தேவையில்லை
தேவையில்லை.
I request Dr. Robin to smile and Dr. Vatishan to remain on the dais for the next session. We move on to the next case presentation. We have Dr. Shanat and Dr. Cameras for the session. Dr. Robinson, smile, Dr. Vishnu Prasad, Dr. Vaidishwar, and Dr. Anand. On to the time.
One second, I'll just copy this.
Videos. We are using at least. Coding agreement, ready? Yes.
Face work வருது face work. You want to upload everything now? Let me start now. You will have 2 minutes. It's sitting already. None of them are starting. Connect to your start as let's see how PPT. Already working on budget. This will change.
Loaded or not?
Loaded. No, share. Go to Zoom, share.
Good morning, one and all. I am Dr. Pranay. This is Dr. Shuraj. We are presenting a case on epigastric mass. A 60-year-old gentleman, daily wage labor by occupation, belong to lower middle class, is modified socioeconomic scale. Hailing from Kadlur, presented with us with chief complaints of post-parental fullness for 3 months and vomiting for 2 months. History of presenting illness. Patient was apparently all right 3 months ago. He started having post-parental fullness, which was gradually progressive, leading to decreased food intake. He also complains of vomiting for 2 months, about 2 to 3 episodes per day, containing undigested food particles, non-bilious, non-projectile, and occurring within 2 to 3 hours of food intake. He is currently tolerating liquid diet and purine diet, and complains of early satiety. He also had history of loss of appetite and loss of weight. Loss of weight was undocumented. There is no history of any bowel movements, no history of early satiety or constipation, no history of recurrent abdominal pain in the past, no history of hematemesis or melena, no history of mass in abdomen, no history of ileal discoloration of eyes, back pain or abdominal distension. Past history, there is no history of abdominal pain or vomiting or intake of over-the-counter drugs in the past. No prior hospital admission except for right angle meshplasty done 4 years ago. Patient is known case of hypertension since 4 years and is on antihypertensive medication. And there are no other comorbidities. Family history, no history of any malignancies in the family. Personal history, patient has been a smoker and smoking 5 cigarettes per day over last 20 years. And he drinks alcohol occasionally. He consumes a mixed diet. Bowel blood habits are normal and sleep is adequate. Treatment history, patient was admitted in local hospital 20 days ago. He was managed with case of peptic ulcer disease and was managed with oral medications and was discharged. Patient self-referred to JIPMER hospital in view of persistent symptoms. 65-year-old gentleman, known hypertensive and smoker, presented with post-parental fullness, early satiety, and non-bilious progressive vomiting for 3 months, associated with the loss of appetite and weight, with no history suggestive of pancreatitis or peptic ulcer disease in the past. Should I?
Ask you for some time, we'll discuss the history and then move on to the examination. Can you just give a provisional diagnosis for the history?
Provisional diagnosis is gastric outlet obstruction, probably malignancy.
Can you please narrate what are the reasons why you give a malignancy as your first diagnosis from the history itself?
Age, patient age, and there is no history of previous upper abdominal pains, and also duration of the symptoms for 3 months, and progressive symptoms.
Since you need to say it's short or long.
It is a short duration, and it is also associated with early satiety and loss of appetite and loss of weight, and progressive.
Can you think of any other differential diagnosis for this? For the history?
Just being peptic ulcer disease can be possibility, but there was no previous history of any ulcer disease or
Not only previous history, but this time also he doesn't have any pain, right?
has no pain. Disability, patient gets a sensation of fullness of stomach earlier than he used to get before. Decreased lumen of the stomach. Sir? Narrowed lumen of stomach. Decreased distensibility. Decreased gastric distension.
Just explain some more, you're saying decrease distance between, no? Just complete the sentence, explain some more. So I was asking what is the reason for early satiety?
Decreased distensibility of stomach causes early filling of the stomach, leading to early satiety.
You know, coach, what is diffuse infiltration of the stomach, then anything else?
Yes, sir. The outlet obstruction itself can cause the early satiety.
Total obstruction cause vomiting. If capacity of the stomach is reduced, what could be the other cause? Anything pressing outside?
Nodal compression can be a cause. Extrinsic compression due to nodal compression can be a cause.
What are the symptoms would have told you? Clearly, it's a person is having. Repeating the same question in one, what are the alarming symptoms?
Complete gastric outlet obstruction, oral intolerance, gastric upper abdominal distension, mass per abdomen, hematemesis and malignant.
Yeah, an exertion, yes, something like that. It's one of the common presentations in the case. We'll find it in investigation. History also.
Patient can have pleural effusion.
Severe anemia. Severe
Partial outlet obstruction because patient having vomiting after 2 to 3 hours of intake of food. Sir? Sir, I can't hear you. Sir, vomitings are there? No, sir.
No, man.
Still, the partial obstruction can be there, which can cause the vomitings.
They have a no big gas line. And you call everything. You call pain. Why is this patient is not resting?
Because he's having vomitings, different types of vomitings, undigested food particles, and time periods like after 2 to 3 hours of intake of food. Partial undigested food particles you mentioned. Non-bilious vomiting, sir. Non-bilious.
Well, in case we don't get though they have a think of the construction.
The decreased peristalsis. The decreased peristalsis involvement of.
Stomach is not anything. So then infiltration of the stomach. And they cannot have. The thing is, they have a small stomach because the intake will get reduced because of that. The stomach gets reduced itself. So they don't have. They don't have anything. Even though they have. If you use infiltration, the stomach will get reduced. And increase sensitivity. Unlike in benign disease, where the pulmonary obstruction is also the stomach damage. Plastic pain.
Sir?
Plastic pain is neurology. It makes, yeah, it can be, it is. Mechanically important.
Moving on to examination, patient was examined in a well-lit room after taking informed consent. He was comfortable, alert, no features of any dehydration, moderately built, undernourished with BMI of 18.5 kg per meter square, ECOG of 1. There was no pallor, no icterus, no generalized lymphadenopathy or edema. He had a nasojejunal feeding tube in situ. Blood pressure was 107/90 millimeter of mercury in the right arm in sitting position. Pulse rate was 78 beats per minute, regular, good volume measured in the right radial artery. Abdominal examination. On inspection, abdomen looked flat, flanks were free. Umbilicus was in normal position, inverted with no nodule. All quadrants of abdomen were moving proportionately with respiration, with no visible fullness or peristalsis. There was a healed scar of previous right inguinal hernia surgery. With spine and renal angle look normal, external genitalia look normal. On palpation, abdomen was soft with no areas of any tenderness. A firm, non-tender mass of approximately size 5+3 centimeter was noted in epigastrium, extending to right hypochondrium and umbilical region. It was starting 3 centimeter below G sternum, extending till 1 centimeter below right costal margin in mid-clavicular line, and the mass was noted 5 centimeter above umbilicus. It had irregular surface with ill-defined margin, moving with respiration, and on head raising, lump became less prominent. Liver was not palpable, no other mass palpable. Spine, renal angle, and external genitalia were normal on palpation. On percussion, superior border of liver dullness was felt at 5th right intercostal space with liver span of 11 centimeter at mid-clavicular line. Dull note was heard over the mass, and tympanic note was heard all over the abdomen, with drop space being resonant. On auscultation, normal bowel sounds were heard. Distal rectal examinations, no melena, no deposits, and normal stool staining on examining finger. There was no supraclavicular lymph node palpable. On other systemic examination, respiratory examination, bilateral equal air entry with normal vesicular breath sounds and normal heart sounds on cardiovascular examination. So coming to summary, 65-year-old gentleman, known hypertensive and smoker, presented with postprandial fullness, early satiety, and progressive non-bilious vomiting associated with loss of appetite and loss of weight, with a palpable form epigastric right hypochondrial intraperitoneal mass with no features of metastasis and with angiotube in situ. So our provisional diagnosis would be 65-year-old gentleman with partial gastric outlet obstruction due to malignancy of distal stomach. With the history and examination, the site of the origin of the mass looks like stomach, sir. So although the organs like transverse colon or pancreas would present with a epigastric mass, but with this history and examination finding, it looks like a stomach mass, sir. Periambulatory tumor with presentation of mass is rare, sir, and also the patient would have but other features like duodenal mass obstructing the CBD would present with obstructive jaundice. Patient does not have any features of jaundice.
Sometimes during constipations, men and women, but most of them, but there is chances that they may not have them. But they may have the mass is part of it. And we can speak of
Duodenal ulcer leading to duodenal carcinoma is possible, sir, but previous history of pain, abdomen, or any dyspeptic symptoms are not there. So I'd still not think so.
Explain the mass.
Mass was a form. Was a non-tender form mass, sir, of approximately size 5 × 3 centimeter that was present predominantly in epigastrium, sir. But its extent was there till the right hypochondrium and towards the umbilicus region also. And it was moving with respiration, with minimal mobility was also there, sir. And it was intraperitoneal mass. Surface was irregular and the margin was no, nodular. Yes. It was done, sir. I think it is the mass that the tumor that stomach mass tumor per se is dull, sir. But tumor per se is dull. But if we are palpating distended stomach, then it will be tympanic in nodes.
What is the note you can go over and dump in this bowler? What type of normally what is the note you get? What type of note?
Tympanic, sir. Yes.
The mass. What will happen?
Impaired tympanic node.
You don't get a bulb. You saw it not. You got any free fluid?
No, sir.
Look for any free fluid.
No, sir. No dullness. Like all the part. Sorry,
Free fluid out.
we'll look for shifting dullness, sir. But it was not there.
Suppose you take that note after the water.
Yes.
You do here examination.
Yes. PR examination was no deposits, and no mass also palpable. Normal stool staining.
You look for mass.
Deposits, sir. We look for deposits. There was no deposits palpable.
What does it?
Hard deposits, sir. Anterior, mostly anteriorly, there will be a form mass, sir. Hard mass. Blooms. Supraclavicular node was not palpable, sir. Between the two ends of left axillary node, I like to see, sir, but there was iris nodes. Not this. No nodal in umbilicus, sir. System. Sir.
Stage of it.
It is metastatic, sir, stage 4. Yes. Sir.
What is the bigger plan?
It was 11 centimeters.
11.
Yes.
What is small, between, right, sir?
Like this 12 to 14 is the normal liver span, sir, but I think 11 would also be.
Could be the first.
I think it's normal, sir.
What would be a total?
5th intercostal space.
6.
5th, sir. 5th.
Okay.
Yes.
Then alcohol.
Occasional, sir. Very rare, actually, sir. On probing only, it told like he drank a few. That also seldom.
Could be a transverse colon mass.
Transverse colon, the mobility was not. It was not very mobile, sir, and also it was moving with respiration. So
Colon mass also not very much.
it was not moving. It was not moving with respiration. Sorry, it was moving with respiration, sir. So I don't. No, sir.
Intoxication would have been because of transverse colon mass.
It could be either you would have obstruction, sir, or features of obstruction or anemia.
Is arising from this one.
Cyst with mass palpable, it can be there, but because patient did not have any history of bleeding, sir, so I think it's not cyst.
It could be lymphoma.
Lymphoma with patient had predominantly luminar problems, sir. So it will produce with obstruction, sir. Still,
Transverse colon mass also multiple. The one equation has got a upper case.
Yes.
And that's likely to be a transverse colon mass. It is totally
okay, sir. Yes.
Weight is not a left lobe liver.
Patient has, because of history, sir, patient had history of early satiety, abdominal pain, abdominal early satiety, fullness and vomiting. Patient with liver mass, left liver mass would present with vague symptoms, sir, and jaundice may or may not be present. So I still think it's a liver, stomach mass, sir.
Levels of blue symptoms.
Yes.
Comes to
Examination finding the gap between the costal mark, right costal mark.
Yes, sir, there was a big gap, around 3 centimeter gap between the costal margin and the mass. So
what would be the purpose is not the
dull node, sir.
what?
It would continue with liver dullness.
The gap there.
Yes.
So that it could be a carcinoma as well.
Yes.
What carcinoma from a any other type of is the tried individual for the get now. Any other one?
Let's stick with gastric carcinoma. Sir. Gist could be there, sir, but complaints wise, it does not give history of bleeding, sir. No hematemesis, no melena, sir. Ulceration, after ulceration, it bleeds. So our provisional diagnosis is gastric carcinoma, sir. So I'd like to proceed with upper GI endoscopy to look for the lesion and then take biopsy. First, I'd like to do ultrasonography.
Yes, but actually from the history of exam itself, extremely the CS.
Actually,
That's why you are not considering even the guidance, sir, or the history control and the malignancy of the government we consider. This Lena has served, but Lena always doesn't like a bleeding. And also, for given malignancy also, you told that the patient doesn't have a history of pain and no history of given cancer. Not all given plasma is supposed or they come back with an answer. That is also not good. So when the examiners give you a prompting diagnosis or a points, you have to take it into consideration. From the history and examination, you do not just pick on to one diagnosis, it is nothing wrong with it. And it's going to approve the three differential diagnosis, which is relevant to your history and examination. That is why you are just jumping into endoscopy. So first is always non-invasive investigation. So what do you do?
Ultrasonography.
So tell me the points, what do you want to see in that?
To localize the tumor, ma'am. First, ultrasonography to localize the tumor, to look for any free fluid, to look for any signs of metastasis, whether the liver is normal or not. And also the presence of lymph node. Ultrasound can very well pick up the lymph node. So these are all findings I'd like to look in the ultrasonography. Ultrasonography, like if we can pick up in a case of liver metastasis or any ascites, which like gets proven as metastasis, then there's no point in doing CECT, sir. We can straight away go for the palliative care. In cases of metastatic, so metastatic CA stomach.
What are you looking for?
In upper GI endoscopy, we look at first. I'd like to look for the lesions, ulcerative proliferative lesion, or what type of lesion is there. If it is adenocarcinoma, gastric carcinoma, then
What are the types of microscope?
macroscopic, sir. Macroscopic, there are 4 types which can be visualized endoscopically. One is protruding lesion type 1, sir. Second is ulcerative proliferative lesion. Type 3 is ulcerated lesion, and 4 is infiltrative lesions.
So what are the things you like to see?
Also, I'd like to see for the extent of the tumor, sir, whether it is involved, like what.
You said you thought that. Usually filtration, right? It's like vomiting and all that.
Stasis, food stasis.
Can you make out the sinuses of the
Yes, sir. Like if the stomach is not fully distended after insufflation, also
not distant?
yes, lymph.
As you go, they see any vision. So what are you doing?
Other thing, type of lesion, the location of lesion, whether we can go beyond. If it is antral lesion, then whether we can go beyond the lesion or not.
Yeah.
And then this to know first to know the status of the patient, whether the patient is in obstruction or not. So second,
Surgical planning and for surgical planning,
What is important to see the vision?
for surgical planning, sir. For surgical planning, surgical planning.
Maybe it's a bit extent beyond the duodenum. You can't give a margin. So this is extended. And also the proximal distance of our eccentricity, the circle. Then
Loss of Brugge also you can see, non-distensible. Loss of Brugge.
we'll take a biopsy.
how many bags?
At least 8 to 10 from all quadrants. 8 to 10 biopsies, including all quadrants.
We are very investigate.
Ultrasonography wise, there was evidence of irregular circumferential wall thickening noted in antrum of stomach of maximum thickness 3.8 centimeters. Otherwise normal, no features of metastasis. Upper GI endoscopy was done, which showed ulcerative proliferative growth involving whole body and antrum extending along greater curvature till 1 centimeter of Z junction. Lumen was noted, but scope was not passed beyond. Biopsy was taken from the lesion and it had come as gastric adenocarcinoma.
What are the types? What are the types of?
Intestinal type and diffuse type. Diffuse type. Intestinal has better prognosis.
Diffuse as E-cadherin loss and more extensive infiltration. Diffuse type. Diffuse type has E-cadherin loss and more infiltrative pathology.
This one, what is like this physical fluid? What is
Intestinal. Intestines.
because it's common in female.
Yeah, female.
Sometimes, younger age and then involved in the very visible masses. What next we would like to do?
Since USC also does not show any signs of metastasis, sir, I'd like to go ahead with CECT, abdomen, thorax, and pelvis. Yes, sir. I'd like to look for renal function test of the patient, sir. I'd like to send urea and creatinine, and if it is normal, then I'd like to go ahead with contrast scan. Yes, sir. Like patient might have occult bleeding, sir. So I'd like to see hemoglobin.
Pernicious anemia. Pernicious anemia, vitamin B12 deficiency. Pernicious anemia is more common.
What identification? Then in CECT, what are the things that we want? Second question is spent indicator protein. It's
HCT is also having a role, sir, in treating.
CECT, what are you see? The first question, second question, this can is indicated or not?
CCT, we mainly look for the extent of the lesion and depth of the lesion, any local invasion, and nodal involvement and distal medicine. And keep it.
Indicated. Do you have a picture of the CT? Yeah. Or something?
Yeah.
Yes, sorry, contrast is the- Okay, this is not contribution.
They also prefer to growth extend given greater curvature and also lesser curvature in the proximal stomach, just distal to the G junction, with the maintained fat gains with the surrounding structures. No significant nodes are visible.
What are we looking at giving space? What are we looking at giving space?
We have not taken venous fluid.
Necessary to look at the answers. Okay.
Liver metastasis will be visualized in venous phase.
You see both of these in detail, entire picture.
PETs, I'd like to do PET CT, sir, because it has been shown that in cases of peritoneal metastasis, almost about 50% is peritoneal mets have been picked up by
I think there's a difference in density for lateral metastasis between breast scan and this. So just how do you measure it? If it's a polydifferential adenocarcinoma, do you want this?
No.
Do you want to evaluate the chest or the? What is the differentiation?
actually they have not given, sir, only
Suppose it is polydifferential adenocarcinoma. Do you want to evaluate the chest?
evaluate with, sir.
Chest. And once we want to evaluate.
Yes, sir, yes, sir.
How will you?
CCT, sir. CCT will cover lungs as well, sir. PET-CT will not be taken up avidly by signet ring or poorly differentiated carcinoma, sir. Yes, sir.
Not good. The CT might be needed if the high grade carcinoma is there, just CT.
Yes, sir.
What other place tests is needed?
Liver lungs are the common, sir, and bone mets are also reported, sir. Peritoneal mets.
There are advantage of the scan which is defined the justice of the other. These are restaurants that get to reach, and it sometimes they can solve. The CT is operable or not?
It looks like operable, sir.
What are
Minimal
the other signs of the problem?
site is features of met.
Maybe type of protein here. Which type of site? Medical assessment, right?
Infiltration, like local infiltration with tumor, with the organs, sir. Pancreas, left lobe of liver.
Suppose it's in your phone.
We can go ahead with resection, sir. Yes, diaphragm. Diaphragm, sir. Like proximal tumor that is extending into the esophagus.
What would you like for this? Would you like to give you directly?
Diagnostic laparoscopy we like to do. Diagnostic laparoscopy and check for operability.
My question is, would you like to give near class report? Would you like to give near chemotherapy before doing diagnostic laparoscopy? I want to diagnostic laparoscopy.
Diagnostic laparoscopy.
We want to give
In this case, neoadjuvant chemotherapy would be ideal, sir. Loss of fat planes is there with pancreas, sir, and diffuse tumor also. It's going till the almost near the esophagogastric junction, sir. So in locally advanced gastric carcinoma, locally advanced gastric carcinoma, neoadjuvant, like perioperative chemotherapy is.
Not clear, guidelines are not clear. Institution. So the plan is going, though we have published more people, we have the indications, we can see a field where incorrect indications from your national system. The exact guidance are not clear, so still the plan is going. So but whenever we find it's enough, not clear set operability is there, so that can be a place where you can try your chemotherapy. And there's always in advanced carcinoma, there's always no laparoscopic stage. Is 9 to 10%, 15%. So change in your modality of treatment because of the laparoscopic stage.
This patient operable, sir. Total gastrectomy with D2 dissection. Diagnostic laparoscopy, see for metastasis. If not, then proceed with total gastrectomy with D2 dissection. Esophageal, yes. Rule loop of esophageal jejunostomy, sir. Esophageal jejunostomy, Roux wise. Yes. No evidence suggesting like superiority of lapo versus open, sir. So we can, with the expertise of surgeon, we can choose.
Thank you, Sir.
Last question, you read a brief cytology.
Yes, sir.
Cytology.
Yes.
Yes, thanks.
Thank you,
Thank you, sir.
Dr. Ma'am. I now request the examiners to award the certificate of presentation. Dr. Shivraj. May I now request Professor Dr. Amit Prashant to kindly come to the dais and honor the examiners. Dr. Robinson Smith. Dr. Anish Ji. Dr. Ashok Prasad. Dr. Robinson Smith.
Vishnu Prasad, basically.
The whole thing, na?
Dr. Vishnu Prasad.
This is also perfect. With this one video, the whole thing he didn't tell you. Now his lecture is one only. The video and no video from here. Copy on this. Not but we check and see if it's written.
We thank the examiners for sharing the session and Dr. Shivraj and Dr. Pranay for their presentation.
The inauguration background.
We now have the inauguration ceremony. We request every minutes to get time to set up the stage for the
The lower part is not visible. And so I told to remove that welcome delegates and all that. Okay, for them to set. In a video please. It's like you message it. Just see how it goes. So you can make it a text to float only. Adobe is that. Put it close to him, but they're only open windows there. From Adobe we can open enough. This is not Adobe. Let's see once.
கண்ணியத்துக்கு சங்கனா இருக்கா ப்ளே பண்றீங்களா அப்படி செக் பண்ணீங்க முத இத
No, like a copy. See, the copy is that only then we can look at. Why do it full screen now? Full screen mode. Okay, but it has to come there. So what we'll do is duplicate the display instead of screen and screen share. Where did you write to? Screen share passage to.
Song இருக்குல்ல song இருக்குல்ல இல்லையா then song ப்ளே பண்ணி செக் பண்ணீங்க சார் இதுல ஒர்க் ஆகுதுன்னு
Working இருக்கு நேத்து செக் பண்ணி connected to the printer and
காப்பி பண்ணுங்க
but sir, now when I leave now this thing will go which now when I to play the file when I leave now I have to go to this and play it will all change. That's why I wanted this as extra like you understand. When the calculation starts it should be there and then we can manipulate it. No, audio will be playing from there, not from here. Audio will be playing from here and audio in the computer play பண்ண முடியாது. எந்த கம்ப்யூட்டர் இந்த கம்ப்யூட்டர்
இது அதுல போட்டுங்க அது அப்படியே
இது வரல சார் நீங்க அஜெண்ட் கொடுத்துருக்காங்க அதாவது டைரக்ட் கோடிங் ஜூம் ஆமா மோர் ஆப்ஷன் இருக்கு
ஹைடு ஃப்ளோட்டிங் கண்ட்ரோல் மோர் ஆப்ஷன்ல எங்க இருக்கு சார் இது
We'll now have the inauguration ceremony. May I request Dr. Gupta to escort
ஆமா இருக்கு சார் அதை அப்படியே பண்ணிட்டோம்
Rakesh Agarwal.
ஓகே போயிடுச்சு சார் தேங்க்யூ சார்
I request.
That's great to that.
I welcome the Honorable Dean Research, JIPMER, Dr. D.N. Dava, to rise. I request the Honorable Medical Superintendent of JIPMER, Dr. N. Durarajan, sir, to kindly go on with that. I welcome Dean Research, Dr. Vikram Kartik, to the dais. I invite Dr. Vikram Prasad, Professor and Head of Department of Surgery, JIPMER, and the organizing chairman of this event to the dais. I invite Dr. Suresh Kumar, Professor, Surgery, JIPMER, and the organizing secretary of the event to the dais. I request everyone to rise for the invocation song.
ये प्रेमयं प्रमुदितानुभाग्यवन्तः देन प्रतिमदचरो सुचिरं शुभायुः वेदस्य दीपानय तत्पुरदन्तरामः येन प्रभवयस्य विदग्य दीक्षा ज्योत्स्नानुजातुषमणि प्रभवे मनातुम् व्यागव्यगाम हृदयाय देवं विकलापि च किलैषः देवं विकलापि च किलैषः विकलापि च किलैषः.
May I now request Dr. Vishnu Prasad, the organizing chairman of JIPMER Surgery Update, to deliver the welcome announcement.
Good morning, dear friends, ladies and gentlemen. It's my great pleasure to welcome all of you to this sixth JIPMER surgery update and also the second JIPMER surgery alumni meet. So we have been conducting this update since 2017, actually, in between the last one or 2 years because of COVID. So idea of this update is to help the exam going postgraduates, to help them in getting the views of all the examiners in and around, and also give them the recent advances in the form of lectures. So last year, we made one more advancement by adding the alumni meet also to this intention was to invite, so our alumni were doing pioneering work in this field and to get their views so that you can also advance like that. So that's this with this idea, now we have the second JIPMER alumni meet. So this is how it was conceived and how we have come forward. So to this August gathering, so I request all of you to give a great applause and join me in welcoming our director, Professor Rakesh Agarwal. So those of you who don't know Professor Rakesh Agarwal is a gastroenterologist, professor of gastroenterology from SGPJ. Is also well-known epidemiologist and a vaccinologist, and he has been here for more than 5 years. So I warmly welcome you. I also would like to join me in welcoming Professor Devinder Mohan Thapa. So he's our Dean Research, previously was the HOD of Department of Dermatology. So, and we also have today with us Professor Dorarajan, who is our medical superintendent. Previously was the head of the Department of Urology and is professor of urology. So I also request you to join me in welcoming Professor Dorarajan. So it's my pleasure also to welcome Professor Vikram Kate, who is my colleague and he was previously the HOD of Department of Surgery. Welcome you, sir. So today also we have our teachers and previous faculty of our department. So Professor Anand Krishnan, Professor Smiles, Professor Jagadish. So the giants of our department, on whose shoulders we could stand to see so far. And they're guiding us further also. They're coming here and it's an encouragement. So I request you to give a great applause in welcoming them. So in addition, we have also alumni who have come, Dr. Fani, Dr. Vaidishwaran, and others. And I also, once again, I would like to welcome all of you because shows the number. And we have nearly, compared to last year where we had 186 registered, and now this year we have to 56 plus, I think, close to 300 registration. It has increased. It shows this popularity of this program. Thank you very much.
We'll now be presenting bouquets to the dignitaries on stage. Firstly, to our director, Professor Rakesh Agarwal. For Dean Research, Dr. D.M. Tapa. For Medicine Superintendent, Dr. Ellen Govirajan. For Dean Academics, Dr. Vikram Gandhi. Organizing Chairman, Dr. Vishnu Prasad. And the organizing. Thank you, sir. I now request the dignitaries to kindly light the ceremonial lamp for both the blessings of the audience. May I now request Dr. Ellen Govirajan, Medical Superintendent of JIPMER, to deliver the presentation address.
Good morning, everyone. Respected Director, Professor Rakesh Agarwal, Dean Research, Professor Papa, Dean Academic, Professor Vikram Kate, Organizing Chairman and Head of Department of Surgery, Professor Vishnu Prasad, Organizing Secretary, Professor Suresh, distinguished past heads of departments and professors, Professor Ananthakrishnan, Professor Jagdish, Professor Robinson Smile, other faculty members from the Department of Surgery, resident doctors, resource persons from all over the country, and participants. I'm indeed happy to be present at this on the occasion of the 6th Surgery Update and 2nd JIPMER Surgery Alumni Meet CME. The Department of Surgery is well known all over the country for its high quality education of its students. But about 10 years ago, they started the JIPMER Surgery Update so that not only students of JIPMER, but also many residents from the neighboring Pondicherry and the neighboring parts of Tamil Nadu and other places in the country can also benefit from the expertise and wisdom of the faculty members of JIPMER. And it has been very well received. It has been hugely attended, and extremely positive feedback on the program. To me, it reminded me when I was a resident of the Maulana Azad Medical College updates that they used to conduct, and we as postgraduates from different institutions used to attend that. So when I joined here, I used to wonder why doesn't our surgery department do it? And it's indeed gratifying that they are doing it now for nearly a decade. They couldn't perform this during the COVID years, but it has restarted, I think, last year, and this is the second iteration post-COVID. So at the outset, let me congratulate the Department of Surgery for restarting the program. This JIPMER, due to our director's efforts, JIPMER has developed this infrastructure, and we have this nice hall here, and we have several other educational halls, and it provides a nice environment for holding such CME programs. So I hope all the participants and the resource persons find it comfortable and in this environment, and I hope it stimulates learning. And lastly, I hope the delegates find some time to take off from this. It's a 3-day program. So I hope the evenings are free, and I hope the delegates and the visiting faculty especially enjoy the city of Pondicherry also. With these few words, I wish this program all success. Thank you.
Thank you, sir. I now request Dr. Veeru Thapa, Lead Research JIPMER, to deliver the presentation address.
Good morning, everyone. Respected our beloved director, Professor Vikesh Agarwal, Dr. Professor Alan Durarajan, Medical Superintendent, Dr. Vikram Kate, Professor and Dean Academics, Professor D.N.R. Vishnu Prasad, Organizing Chairman of this 6th JIPMER Surgery Update and 2nd JIPMER Surgery Alumni Meet, Professor S. Suresh Kumar, Organizing Secretary, distinguished guests, delegates, ladies and gentlemen. It's nice to be part of this surgery update, which is being organized by the Department of Surgery. And I hope this update will be a fruitful one for the youngsters, which have to learn various skills in surgery. As we are knowing that the surgery techniques are becoming more and more different in nature, because they are becoming minimally invasive surgeries, maze-guided surgeries, robotic surgeries, and telesurgeries. I hope this surgery update will be a fruitful one for each and everyone, and everybody will gain a good knowledge about the various things which is happening in this world of surgery. Thank you very much for giving me this opportunity to attend this meet. Thank you.
Thank you, sir. May I now request the chief guest of the event, the director of JIPMER, Dr. Rakesh Agarwal, to deliver the inaugural address.
Good morning. Professor Anand Krishnan, Professor Smile, and Professor Jagdish, our respected faculty members who are here with us and have honored us by being here today. Professor Thapa, Professor Kate, Professor Durarajan, Professor Vishnu Prasad, Dr. Suresh, resource persons for the 6th surgery update, the faculty members of the institute, delegates, and dear students. I'm extremely happy to be here today with you for this inauguration of the 6th JIPMER surgery update. I've been to the previous courses before we had COVID, and I think even last year you had one, and I can see that the course is growing. In the previous years, it used to be shorter, 2 to 2.5 days, and this time it was much longer for 4 days. And that's something what I interpreted is that people asked for more and people, that's why the course has been, duration has been increased. And that's a healthy sign, growth, a healthy sign of growth. Institutions such as us, it is our duty to teach people. There are different modalities. We teach in the classroom, we teach in ward rounds, we teach in OTs. And then there are these periodic courses which add a different flavor. The way I look at these courses are, the way they are different is that they bring in experts and they allow the students to mingle with them, not only during the session, but also outside the session, so that they come to realize that these experts are no different from them and that one day they would also be like this. And it also allows them to interact informally and pick up tips about surgical procedures. And also, I'm sure for some of them, that interaction helps them when they are looking for jobs in the future or future opportunities. So I think while congratulating the department for doing this, I would request the postgraduates from JIPMER and from other institutions who are attending to make the best use of this facility when we have these experts, whether from the institute or from outside, here with you. Ask questions, learn more from them, and whatever you can extract from them, that's what your purpose of attending this workshop should be. On a personal note, the program is very enticing. I can see topics which are of my interest. So surgical management of portal hypertension, chronic pancreatitis, liver mass, looking at choledochal cyst, borderline resectable pancreatic cancer. I wish I could attend all of those. I know that over in the country, the medical gastroenterologists and surgical specialists have moved somewhat apart, but I still come from the era when we used to have common conferences, and I love attending these surgical sessions. I'm feel bad that I have 2 or 3 other functions lined up, so I'll not be able to do that today morning, but I'm sure I'll try tomorrow and come and attend some of those sessions, because looking at the program, I would say they look very enticing and interesting. With that, let me again congratulate the department and hope and wish that the residents have a good time learning newer things and making new friends, not only with people their age, but also with some of the faculty. Thank you.
Thank you, sir. Now request Dr. Suresh Kumar, the organizing secretary of JIPMER Surgery Update, to propose the voting plan.
It's my pleasure and privilege to propose a vote of thanks for the 6th JIPMER Surgery Update 2024 and the 2nd JIPMER Surgery Alumni Meet on behalf of the organizing committee. At the outset, I would like to express my profound gratitude to the chief guest of today's function, Professor Dr. Rakesh Agarwal sir, the director of JIPMER, for sparing his valuable time to participate in the inaugural function. We are greatly motivated by his presence and immensely benefited by his inspiring address. Thank you, sir. I extend my sincere thanks to Dean Research, Dr. D.M. Thapa sir, for accepting our invitation and facilitated this occasion with his insightful thoughts. I wish to express my gratitude to our medical superintendent, Dr. Ellen Dorajan sir, for kindly accepting our invitation and gracing this inaugural function. We are grateful to Dean Academic, Dr. Vikram Katte sir, Professor Senior Scale, Department of Surgery, who has been the driving force behind the successful conduct of this annual event ever since its inception in 2017. I wish to express my gratitude to Dr. Vishnu Prasad sir, Head of the Department of Surgery and Organizing Chairman of the JIPMER Surgery Update 2024 for his guidance and great support in organizing this event. I wish to thank the entire participating faculty and JIPMER Surgery alumnus who accepted our invitation to share their wide experience with us. I thank all the former senior faculty of JIPMER for gracing their event with their presence. I take this opportunity to thank all the members of organizing committee of this JIPMER Surgery Update who went out of their way to make this possible. I thank all the supporting firm for willing to be part of this surgery update and their support for conducting this event. I thank all the support staffs who provided technical and logistic support. Last but not least, I thank all the delegates who have taken their time off to attend the surgery update. And I'm sure this proceeding will greatly help you in augmenting your knowledge and skills in the field of surgical discipline. Thank you once again. Thank you.
Thank you, sir. With that, we come to the end of the inauguration ceremony. I request all gathered here to proceed to the dining area for tea. request all the faculty to join the hall on the right side of the hall. I request all the delegates to proceed to the left side of the hall near the right chair. I request all to reconvene in 15 minutes for the next session. Thank you.
இல்ல அது முன்னாடி சேர் வச்சிருக்காங்க இது வேண்டாம்னு சொல்லிட்டு பிளாக் இது போட்டு
நீங்க பிஜே வச்சிருக்கீங்க ஸ்டாண்ட்
அது இருந்து இன்னைக்கு என்ன கொடுக்கல
டிஸ்டர்ப் இருக்கு இவங்க இருந்தது தான் தெரியுது
வெயிட் ஃபர்ஸ்ட்
தெரியல
ஹைட்டா இருந்தா ஒன்றும் தெரியல ஆமா அவ்வளவு ஹைட்டா இருக்குன்னு
அது இந்த கேமரா யூஸ் பண்ணக்கூடாது
அது இன்னும் தனியா கேமரா வரும் அது இன்னைக்கு கிடைக்கல எங்களுக்கு அத கீழே யூஸ் பண்றாங்க அலுமினிய மீட் அது என்ன
ஐடியா பண்ணேன் ஹேண்டி கேமரா போட்டுருக்கேன் கேட்டேன் நான் கேட்டது
நேத்து நான் அங்க வச்சு பார்த்தோம் அங்க எல்லாம் கரெக்டா தெரியுது என்ன நாங்க பின்னாடி முன்னாடி போய் பார்த்தோம் எங்க ஸ்டேஜ்ல பாக்கல வீட்டுல அதிசயம் எடுத்துக்கிட்டேன் எலிவேட் only just is visible after that
ஆர்கனைசேஷன்ல இந்த மாதிரி பண்றாங்க
ஆமா ஆமா இது ஆன்லைன் கரெக்டா பா
ஆன்லைன்ல போதில்ல இது லைவ் இருக்குல்ல
okay so now the papers will be like this even send that no net send that when will all okay
பாருங்க
PPT we are not seeing
ஓபன் பண்ணுங்க கேமரா
that later like around 2 sessions before your presentation
It's 12:40. And if
okay give
கேமரா ஓபன் பண்ணுங்க
Mute it.
Huh? Okay, sure. Bile duct injury on the right side. So this is one such, it's not going down. It's not moving. Okay. So this is one such patient. For example, he had this is 6 months post bile duct injury with a torrid course, and you can see a wide disruption. And because once the artery is gone and the hilum is gone, there's no collateral from the left. The bile ducts undergo ischemia and necrosis. This patient had multiple abscesses in the liver, multiple PCDs. You can see that, and then so these kind of patients, the outcomes would not be better by doing because we can't treat the cholangitis. We can just drain the bile duct, but with intrahepatic sepsis, we can't treat. So we prefer to do a right hepatectomy and do a left hepaticojejunostomy. So that's the hepaticojejunostomy. Another situation where you do a hepatectomy is in the atrophy-hypertrophy complex, because most of the time when you have a type 4 injury with an arterial injury, sometimes even type 4 injury without an arterial injury, just because one side the bile is draining well into the duodenum, the other side is cut off. Without arterial injury also you can have hypertrophy, but of course the most maximum atrophy-hypertrophy occurs with the portal venous injury. So even if you have atrophy-hypertrophy, if the stricture is type 3, you can just drain it and leave it alone, because that takes care of the sepsis. You don't need to do a hepatectomy, but if it's separated and you have multiple abscesses to rule out the sepsis, you need a hepatectomy. So take home message is arterial injury evaluation has limited role in type 1, 2, 3 BBS, especially in a delayed repair. Because again, if there's an arterial injury, in 3 months, the stricture has all matured. The ischemic endings have become fibrosed and matured. And in disruption of the hilum plate has the important therapeutic and prognostic significance. One more situation which very challenging to manage is BBS with a portal cavernoma. So most often it's not due to portal vein injury. To injure the main portal vein during lap chole is actually very difficult unless the patient has some atrophy, hypertrophy and portal vein rotated anatomy. So the management of this follows sort of similar principles as portal cavernoma. So it's almost like the same area. Only thing is something like an endoscopic removable SEMS, which is now fairly widely used in portal cavernomas to sort of induce fibrosis and treat the strictures, which can be used. If you can't operate them, use get hepaticogastrostomy. Again, it's a temporizing maneuver. Bilateral PTBD can be done to relieve the symptoms. It's a temporizing maneuver. So finally, you have to, in these patients, if you really have to give them a permanent solution, you have to look at doing a hepaticojejunostomy with or without a shunt surgery and a liver transplantation. So how do we select? We have a fairly good experience of doing HGS in these cavernoma and not too many, but reasonable experience. So how do we select these patients for a safe hepaticojejunostomy? This is a patient who actually had a bile duct injury and a torrid course. I mean, re-exploded 2-3 times, multiple PCDs. I think he stayed for 4 months in a hospital. Obviously, secondary to the sepsis, he had a portal vein thrombosis and a portal cavernoma. But his stricture, you see, it's basically a simple one. The hilum is patent. You could call it probably a type 2 BBS. It's a nice big stump, and there's huge dilatation of bile ducts. So in fact, this patient's images, the good CT images I could not get. It's there in a hospital, but I couldn't get. So mainly what do we look at? One is ductal dilatation. So when you're doing a portal cavernoma, you have the bile duct surrounded by collaterals. How big is your target? So to reach your target, if the target is big, most likely it's easy to access it. But if you have a small bile duct surrounded by huge collaterals, that's the kind of patients who lead with torrential bleeding intra-op, and you might even lose them. So that is one. Level of stricture. If it's a low stricture, you have a fairly good length of bile duct to access, you'll probably have an easy anastomosis. The most important thing is distribution of collaterals. So portal cavernoma in biliopathy and these strictures, they have different types of distribution. In some patients, the cavernoma extends till only the confluence, and after that, the normal portal vein is there. So at the confluence, you don't have any collateral. Sometimes they're all posterior. So rarely you'll have a lot of anterior collaterals, more in cirrhotics. And then you can see intramural collaterals. Intramural collaterals, they can be seen on EUS also, but that's observer dependent. Finally, on the CT, you'll find it like a hyperemic zone. So those we chose in this patient, and see in the surgery as well. In the normal patient, you'd completely do the subhepatic addusolysis, Morrison's pouch, everything. We did minimum addusolysis, just went on to the biliary stricture and drained it. There's no addusolysis done all around. It's to avoid any bleeding from the collateral. In fact, this patient we could finish without any transfusions. And he's doing very well after 2 years. He was again a patient advised a liver transplant outside, and we could sort of avoid that, and he's doing well. He had a hernia for it. We did a TAR recently. So take-home messages in BBS with portal cavernoma, when you have grossly dilated ducts with favorable anatomy and collateral distribution. I mean, again, for this, because we are able to do it because we have the the liver transplant experience in which we do deal with patients with portal vein thrombus and collaterals. We should be comfortable with the technical aspect of it. In these kind of patients, hepaticojejunostomy can be attended with excellent results. But if you have undilated ducts, difficult strictures, atrophy, hypertrophy, unfavorable collateral distribution, secondary biliary cirrhosis, so shunt surgery followed by hepaticojejunostomy. Some people say do it whatever couple of cases we've done it simultaneously. But obviously, if the shunt surgery is a lot, there's a very difficult surgery, you would stop it and do the hepaticojejunostomy a few months later, or this for transplant. Again, if the feeding vessels, the splenic vein, SMV are okay. If they are not gone, even transplant can't be done in these patients. Just a couple of dilemmas we'll see. One is the persistent external biliary fistula. So is prolonged waiting extra? This is a common situation. After bile duct injury, patients have a persistent bile leak going on. And the traditional teaching, and which is right also, that you wait for the fistula to close, because then the ducts dilate and you can do the surgery easily. In these undilated ducts, if you do, the outcomes would be poor. But what about, you do have situations after 3 months, 4 months, patient still has a high output fistula, 300, 400 ml of bile per day. Do you keep waiting in these patients? Obviously, the prolonged biliary depression, the effects on the body are too many to even recount. Just not dehydration, electrolyte disturbances, a chronic level of endotoxemia, protein energy malnutrition, weight loss, fat soluble vitamin deficiency. So it's not really an ideal choice to keep on waiting for these patients. The reason is, the traditional teaching is that undilated ducts, your anastomosis is not going to be good. But you should realize that what we do in the biliary stricture is the Hep Quinard approach. So we're not, see, if this is the bile duct injury, the size of this duct does not, I'll just take another minute. Size of the bile duct doesn't determine your anastomosis. It is your length of the left duct. So we're going to lower the hilar plate, like this, there, and then access the left duct, open it and do the anastomosis. So it is the length of your left duct which determines the size of the anastomosis. And also it's this thing that if it's a high output fistula, 400 ml per day, the ducts will not dilate, because every case inevitably or repeated time there'll be some degree of dilatation. Again, these kind of situations, we would go in for type 1, 2, 3. Type 4, you should rethink as to your strategy. But like, for example, this is a patient, he has a persistent external biliary fistula draining around 500-600 ml per day. After 6 months after surgery, he came to us. You can see the anastomotic size is not determined by the end of the duct. It is the lengthwise along the left duct. So we could actually get we measured this, I think, yeah. It's 3 centimeter anastomosis we could achieve in this patient. So prolonged DBF, there's no need to wait indefinitely. Yes, definitely you need to have expertise, because the ease of the anastomosis, when you have a small duct, you need to find 6 sutures, take the anterior sutures, you probably need to use a loop. And ductal identification, again, we normally aspirate, but in a fistula, you have to follow the fistula tract and identify the duct. These can be affected without dilatation, but the length of the anastomosis is determined by the external hepatic course of the left duct. Last is the timing of repair. I think this is a very important thing for all of us. So when do you do repair? You do the immediate repair. Okay, on table, you can do a repair. Obviously, again, like I'm listed here, you need to have these facilities to do the repair, or just call somebody or require to shift the patient, because the first chance is the best chance, especially in a high injury. If you do the repair, the next stricture is going to be even higher. Then early repair, which is a strict no-no. Always delay your repair. Why? Because the biloma is resolved, the sepsis clears up, patient is clinically better, the ducts become fibrotic. If there's any thermal injury or ischemic injury, it's going to stabilize. The big common question a lot of youngsters have in the beginning is, the patient has a complete cutoff, his jaundice is 3. If I wait, the jaundice will become 15, 10, 20. No. Biliary strictures don't behave like malignancies, because every biliary stricture will have a biliary fistula. The duodenum will get stuck there, it will erode and drain to the duodenum. So you'll never see, very rarely, you'll see patients with biliary strictures with high jaundice. So you don't need to worry about jaundice also. And of course, if you do a very late repair, which is not ideal, you should consider the possibility of secondary biliary cirrhosis. So is there any role for early intervention? Early intervention, if a patient has progressively increasing bilirubin or cholangitis, the rare patient, you can just do a PTBD. There are some selected patients. This is one patient actually who came to us from Siliguri again, maybe a few months back. The surgeon sent the patient home as an uneventful course. This is a common event. 2 weeks later, he came with progressively increasing obstructive jaundice. So there's a knee clipping. So in these kind of patients, there's no bile leak, there's no biloma. There's no post-op sepsis. You see, when we went in, how beautiful it's like patient has not had any surgery. We just go there and identify the bile duct and drain it. So in very selected patients, we got a good anastomosis. Actually, an ideal case for a laparoscopy if you want to attempt one, this kind of case. So take-home messages in this are always delay the intervention beyond 6 weeks, within 3 months, and progressively worsening jaundice is ever an issue. Highly selected cases without any biomas or sepsis, you can do an early surgery. Thank you.
We have taken of dog is high quality. That shows how much high quality work we do at the hospital. One continuous comment. When you do this particular vertinoscopy, when all you go for trans-anastomotic
So almost always the trans-anastomotic stent is, I mean, in the situation of BBS, when you do a type 4 anastomosis, so the right duct has no extrahepatic course, and you are able to do only an end-on anastomosis. Sometimes you might have to core out the parenchyma, and it's a very poor quality anastomosis. So when you do that kind of two separate anastomosis of right and left in type 4, always better to leave. I mean, if you, most of the time we have a PTBD that comes out, but if let's say the PTBD slips out and you can't put it back in, you put transparent anastomosis in, and we leave them in these kind of cases for at least 6 months.
Is there any role for the access to?
No, in not in BBS, in hepatolithiasis previously there, and we have also done a few access loops, but right now the intervention radiologists are so good, and whenever we've done a couple of access loops for this thing, the endoscopic quality of intervention has never been very good, actually. So we don't do it anymore. Thank you.
And you are specifically focused on the problematic areas, and you stressed the importance of doing these steps and what to concentrate and what to look into. So,
thank you.
Thanks a lot for that. I have got a few questions. On table, some help is asked for immediate assessment and refer. So what things you take into consideration before you plan for an anastomosis? So if a patient recently
No,
imaging as such as a
no. You mean, are you taking about pre-op assessment of cholecystectomy?
on-table assessment to plan for
So on-table, I mean, there's one is, of course, the preventing. I'll just talk about the classical bile duct injury. So on-table assessment, when you have a contracted gallbladder, the liver getting puckered in, you're having difficulty displaying the hilum, assistant has to give aggressive retraction, the calyx doesn't open up immediately, you're in the playground for a classical bile duct injury. You should always be wary of that, because with the traction, the CBD lifts off the portal structures very easily, because that plane is virgin. Then that's the kind of situation you have an injury. Once you have an injury, obviously, the best thing would be to attempt a on-table repair. But again, because you should have all those, you should be able to use 5 or 6 or sutures. If it's a small duct, you should be able to use loops. So you should get the best possible resources possible onto the table and do the repair.
How do you assess the injury?
We see, I mean, assess the injury. See, if it's a straightforward bile duct injury, type 1, 2, 3, you have the bile duct, we don't do any further assessments. Okay, we just go for a hepatitis. Sometimes you have a type 5 single duct 2-3 millimeters, you're not sure whether to reconstruct or not. Then you can do an on-table cholangiogram. You can put in an infant feeding tube, do an on-table cholangiogram, see how significant it is. If it's a small duct, you can actually tie it off. If it's a major duct, then you decide what you want to do. If you have the facilities for the anastomosis, do it. If not, drain it out like an external biliary fistula, remove the drain after like 6 weeks or something, and then hope it fibros off. If it's just a sectoral or a segmental duct. I hope that was your question.
What's your experience from reading?
0 actually in BBS, exactly. So I mean, exactly BBS, it can be done, but see, the important thing in the BBS repair is to do a wide anastomosis, to do a quality anastomosis. I think that's more important whether you do it minimally invasive. There's so much of additions. The case which I showed recently, in fact, that the last case, those are the kind of early bile duct injury, only just a clip on the bile duct where there's no biliary sepsis. those kind of cases, you may attempt to do a post. It's dependent on your comfort and skill level. I think with the robot, maybe you might be able to do it better. But in high BBS, what happens is the duct is so thick, and each bite you really have to think as to how you're going to take. Some bites you'll have to take with the parenchyma. Some you might have the vessels next, so you might have to take it just on the adventitia of the vessels. So I prefer. I haven't done zero experience lab. Maybe Partha would have some.
Yeah, no, sure. Regarding the patient with extrahepatic portion obstruction, lot of paralysis in the internal segment. With the type 2 stricture, would you consider doing a segment 3 bypass where you avoid completely attacking the hilum and so on? Because the type 2, you can get away with.
I mean, basically, there's not much of literature in the curative. I mean, we are looking at not again segment 3 bypass is something that's for malignant strictures with a short survival. In the curative setting, like we're looking at long-term results, it's not a consideration. And if it's a cavernoma, you're not just worried about the actually attacking the hilum, right? Even the approach is going to be difficult. So it's going to be an equally difficult. If something like this, we would do a temporizing thing like if the hilum is unapproachable for some reason, like a small, like the reasons I told, we could even just do a bilateral PTPD or a EUS guided hepaticogastrostomy, and those kind of long term would be a
Won't work in this case. Because in the idea case where you got away with the scale, but
yeah.
you can go.
No, but the thing is, what I'm saying is, the segment 3 bypass also requires you to approach the hilum. So you have to release all the additions, you have to get to the hilum, you have to dissect in the umbilical fissure. So it's not like we are going away from the portal hypertensive area. The bleeding risk is still there. That's what I feel. Yeah, I think, but that's something, it's a good point, actually.
Rajesh may be showing one video in the afternoon session. The hypertrophy technique for
yeah. There's one more technique in which you can actually do a left lateral segmentectomy, and you can do a left lateral segmentectomy. And yeah, you have to be experienced in all this. Honestly, it's in our time, segment 3 bypass, we've sort of given up on it. Thank you. So in chronic pancreatitis, dilatation of the bile duct is there in majority of the patients. So if persistent ALP over, and some people say 3 months, some people say persistent ALP is elevated, you would need to, when you do, if when there's a dilated duct, persistent ALP, when you do your LPJ, you would drain the bile duct always. If it's a minimally dilated duct and LFTs are normal, you don't need to. Adequate head coring will take care of it. But symptomatic biliary strictures, you have to treat them. And asymptomatic, again, for the same reason of long-term secondary biliary cirrhosis, if the patient is having persistent LFT derangements over a 6-month period, ALP elevated, then you need to tackle it. Yeah. So if that again depends on the symptomatology of the chronic pancreatitis. So if the chronic pancreatitis doesn't need intervention, this is a simple stricture. It can be easily dealt with biliary stenting, or they can now, with all the strictures, they'll put a removable SEMS, short segment removable SEMS, which is taken out after a few days, and it has pretty good results. But if the chronic pancreatitis needs surgery, you would try to deal both of them surgically. Thank you.
He puts his experience into his lectures and videos.
Thank you. Thank you.
I now request the chairperson to felicitate Dr. Krishnan. I now invite Professor Dr. Jagdish onto the stage to felicitate our chairperson. Dr. Sri Venkatesh. Next class, we have a video lecture on basics in robotic surgery by Dr. Vishnu. This session will be chaired by Dr. Udit Kumar Chandra, Dr. Vaidishwaran B, and Dr. Hari Krishna Ravanu. I welcome all the chairpersons to the dais.
Robotic surgery started in 2017, and surgery is also having its contribution in performing various types of robotic surgeries. Sir's interest is more mainly the liver surgery and hepatopancreatic surgery, both clinical access, open as well as robotic surgery. Over to surgery.
Thank you, Uday. So this in this lecture, what I would like to say is first I would tell you what is robotic surgery, and then I will briefly describe the hardware, and then I'll not go much into the details of docking and positioning other things because they are more mechanical, and it will not be interesting. That you will get that experience. It will come to you only if you enter the robotic theater. So first, let's answer this question: what is robotic surgery? To understand this question, we need to go back a bit into the history. So in 1987, Dr. Mauret first performed successfully the laparoscopic cholecystectomy. After that, he advised laparoscopic cholecystectomy should be the method of cholecystectomy because of several advantages. One is lesser tissue trauma. Second, better cosmetic outcome, less pain, quick recovery, and a short hospital stay. So within 6 years, this was confirmed and it was widely adopted by most of the surgeons. So, I mean, majority who are practicing this cholecystectomy. And within the next decade, laparoscopic surgery revolutionized, and many of the surgeries are being done by the laparoscopic technique, like laparoscopic appendixectomy, hernia, fundoplication, nephrectomy, so many things. So laparoscopic surgery became the norm. But there are certain drawbacks in this laparoscopic surgery. One is the long instrument and the wristless tips. So means the movements are restricted. It will not be like a wrist movement. It will only 4-degree movement, not like the 7-degree movement which we get in a robotic surgery. And the associated fulcrum effect, where the tip moves in a different direction when you move the hand. And often we get a 2D vision, and sometimes we get a 3D vision. If you have the advantage of buying the 3D laparoscopic. And the most important factor is the long, steep learning curve and the fatigue associated with laparoscopic surgery, which discourages many of the surgeons who have crossed 50 to take up laparoscopic surgery. So there were some attempts by some of the surgeons in USA to bring into this picture a newer technique which will simplify the surgery. So the telerobotic technology, where a surgeon can manipulate on a patient without coming into contact with the patient. So the telemanipulation, the concept of tele or remote surgery was born. How it was possible to do this? So this scientific marvel, how it was made possible? The answer is it's because of the computer. Or if the computer scientists are allowed to say, they would like to name it as an interface. So this computer interface, so in robotic surgery, is the link between the joysticks or the master grips and the master slaves, where the arms enter the patient. So these three components, so the surgeon, the interface, and the patient, where the robotic arms enter, there is a constant exchange of information, and this is what produces the computer-enhanced surgery. That is computer-enhanced system. So you can see in these pictures, so there's no point trying to understand robot as a improvement in the surgical technique. So we should try to understand it as a computer-enhanced surgery. You can see between the master grip and the master slave, there is a computer interface. So robotic surgery is not just an advancement in the surgical technique, but it's beyond that. So robotic technology is what you can say, it's a conceptual revolution. So a third player is now stepping between the patient and the surgeon. So for giving innumerable types of enhancement and opportunities. So with this technique, a transcontinental surgery is possible. So patient can be somewhere else, an experienced surgeon can be somewhere else. So patient need not to leave his place. He can be operated in a local hospital by a very experienced surgeon from somewhere else. So these are actually the enhancements of the computer enhancement surgery or the robotic surgery over the laparoscopic surgery. So what are these enhancements? So let's see one by one. So the first one and the most important one is the vision enhancement. You get a stable 3D binocular vision, either in a closed console, so which we get in a Da Vinci robotic system, or an open console, you can get on a 2D monitor using the 3D glasses. You can get an open console also, right? So the vision enhancement is the most important. Using that, you can, in addition to the vision enhancement, you can add augmented reality, virtual reality, other techniques, which I will come to that little later. The second enhancement is the fluorescent enhancement. You can give a ICG dye, so intravenously, which will go and accumulate in the tissues, and you can make it fluorescent by using the infrared rays from the camera, and you can see the blood supply to an organ by looking at the image, which will appear as a green. So the fluorescent enhanced. It's also possible to visualize the bile duct structure if you give this ICG dye a little early. So it's possible to look at the anatomical structure as well as the blood supply using this firefly mode of the robotic surgery. So its use are multiple, so I cannot summarize very briefly here. Though another important reality and another important enhancement, which is likely to occur in the very near future, is augmented reality enhancement. You can acquire the image of the patient preoperatively, and it can be projected in real time during surgery, right? So that the surgery can be very precise. You can look at this picture, which I have shown there. It's actually a drawn picture, but this will be possible in future. So you can see the liver with the vena cava and the hepatic veins converging. And this one, when you try this in real time, it moves. You will be able to identify it precisely, dissect precisely, cut it precisely. So this augmented reality will come within a matter of a decade. And it's also, so the next enhancement is a virtual reality enhancement. So with this, images, you can create a 3D model. And before even stepping into the theater, you can practice on a simulator. Just if you want to do the right hepatectomy on a complex case, you can practice it, take the simulator, sit in the robot, practice, cut the liver, and find out what are the steps, technique where you're likely to go wrong, and go back and enter the theater with all this knowledge and do the surgery successfully. virtual reality enhancement. And then the next one is the integrated information enhancement. Supposing interoperatively you find a problem. So with the knowledge of AI, so you can get all the whatever data you need just by the click of the button because of the computer interface. So the whatever problem you encounter during surgery can be sorted out immediately by getting the necessary picture, images, videos, whatever you like. So what's obvious right now is the mechanical enhancement. So endorisk movements, unlike the laparoscopic instruments, where you have 4 degrees of movement. So in the tip of the robotic instrument, you have the another 3-degree movement. Both the roll, yaw, and pitch can occur in the tip of the instrument, the endorisk movement, which makes the suturing simpler. And second thing is the lack of tremors. So when you want a precise movements, so the tremors are filtered by the robotic, by the computer interface. And there will be no tremor when where the robotic arms enter and operate. And movements can be downscaled. If you want to a fine anastomosis, you can do a maximum movement outside, sitting on the joysticks or the virtual on the console. But there, the movements can be downscaled from what you call from say 3 to 1, right? And the movements can be very precise. So the vascular anastomosis which you want to do can be done meticulously. So such thing is possible. So if it is true that computer will continue to evolve, progress, and advance, then potentially there is endless opportunities and application for the computer-enhanced robotic technology. So let's see some of history, how it started. So in 1990 in USA, these two companies started, Computer Motion and the Intuitive Surgical in 1995. They started this robot, ESOP and GEOS, which were used for fallopian tube surgery and the coronary bypass surgery. And the Intuitive Surgical, it first gave this actually, I marketed this Mona in Europe rather than USA because there was no license available till they got the license in 2000, when they changed the name into Da Vinci in the honor of Leonardo da Vinci, the polymath from Italy. So because of you can see one of his drawing where there is a mechanical knight, if you Google and see. So because of that, the name they gave is the Da Vinci, the Intuitive Surgical. So both these companies were loggerheads in the court. So one company filing suit over the other. Before they merged in 2003 in favor of Intuitive. And now we have the Da Vinci robot, which patented this robot for the next 20 years. And the 20 years now passed. Now the other companies have started coming. So we have the JIPMER alumni who was working in the Vertiquity Institute, who has visited our institute several times in the past. So working at Henry Ford Hospital, he was the first person to start the first established robotic training program in the prostatectomy, cystectomy, nephrectomy, and later kidney transplant also. So now the available robot, so what we have is the Da Vinci from the Intuitive, but now we have started with the loss of patents. So other company have started manufacturing. So Cambridge medical robots for producing the workspace, Revo from Korean, Intori from Japan, Avatara from Germany, and even we have the SS Mantra from India, Hyderabad, right? So Dexter from Switzerland, and various other types like table-mounted, single-armed robot, miniature in vivo robot, where you can introduce inside the abdomen, it will operate. You can observe on the computer. So microsurgical robotic platforms. So it's advancing. The computer enhancement has made all this possible. So without telling about this popular robot, which is currently available in our institute, so my lecture will be incomplete. So this Da Vinci Xi, it has got 3 components, which we have currently, on which we have been operating, on which we have operated since 2019. We have done nearly 224 cases. And our experience, you can understand if you come down to the first floor in the afternoon session, I've got a talk. So those who are interested, you're welcome. There's no need to have the hesitancy. That's the alumni program. Those who are interested, please do come down in the first floor multipurpose hall. You're welcome to look at the other giants in the surgery speaking about some of the topics which may not be up to your knowledge level, but definitely it's easy to understand. So sorry for the digression. So it has got a surgeon console, robotic cart with arms, and a vision tower. I'll come back to that. This is how the CMR Cambridge Versier surgical system looks, where you can sit and operate in an open console, or you can stand and operate. This is our computer, SS Mantra from Hyderabad, which costs just 5 crores instead of the 25 to 30 crores which you need to pay for other robots. So this is our console of the DaVinci Xi. It has 4 components: vision system and controls, arm board, where you can control the ergonomics, and a foot plate. So this is how the arms control looks like, right? And this is how the binocular system. You don't need a 3D glass for this. You get a 10 times magnified binocular 3D vision, right, on the console. And this is the foot switch, where you have the arm swap, camera focus and control, clutch for bringing the arms to the stable position, and the energy sources, primary, secondary energy sources. And this is the patient cart, where you can see the 4 arms, the boom, which rotates the column, and the helm base. So this you can understand if you enter the robotic theater very quickly. There is no need for me to go in depth of that. So that's more of a mechanical issue. And you can see the vision card, where you can see the monitor. You can see the camera and the entering into the vision card, and the core, the computer. And this is how the camera looks. It's a dual camera. You can see dual lens system, 0 degree or 30 degree, 8 millimeter diameter. And DaVinci Xi, all the ports are 8 millimeter, where you can hop from one port to another. So the buttons used for targeting and screen capture and light on and off. So this is hardware. So if you enter the robotic theater once, it's very easy to understand. So just to show you how easy I just give you just 3 minutes video of how to do robotic hernioplasty. So in this, patient will be in supine with the both arms stacked. Robot will come from one side, and we put 3 ports. And though it has 4 ports, we install one of the ports, and then we make the incision, the transperitoneal approach. Right, so we make the peritoneal flap at the level of ASIs till the level of medial umbilical ligament, and then create the extraperitoneal space. Right, you can see how comfortably I'm operating. Right, so unlike the laparoscopic surgery, if somebody does this hernioplasty using the robotic surgery, I don't think they will ever go back to laparoscopic surgery to do this hernioplasty. So comfortable, right? And you can see there. So after raising the flap, dissecting the hernial sac, right? So, and the most important part is the suturing. You can see how comfortably it can be sutured, unlike the laparoscopic surgery, where you find it struggling to suture on the, especially on the roof of the abdomen, right? So this is the trying to separate the sac from this thing. And so after separating the sac, it will be paratalized from the card structure completely. And then a mesh will be put. So our man, Dr. Bishal, has made a slow movements there while editing the video. So the sac is being dissected again. So this is after the sac, completely the paratalization of the card, right? You can see the structures there. So you can see the vast different, and so yes, put a mark also, corona martyrs, pulsation femoral artery. You can see all the structures clearly identified there, testicular vessels, pulsation of femoral artery, and the coronum arteries, the crown of death, where there is an injury, difficult to control the bleeding, but less likely when you start. So we are putting a 3D mesh there, right? So you can see how we, after the initial tacking, suturing, you can see suture. So we fix the mesh in 2 places. This is our standard technique. So initially I was thinking only tap is possible in robot, but our Dr. Uday showed us E-tech also possible in the robotic, using the robotic surgery. Right? It's possible. I was not aware of this. So to summarize, robotic surgery is actually a computer enhanced surgery with so many future. So I'm not I have no any disclosure. I have not received any money from the Davids. Thank you.
Some comprehensive talk on robotic surgery. My question is little bit philosophical interest. In the private sector, in a country like India, where affordability plays an important part in surgical decision, you choose a surgery, a particular surgery, and one of the factors which helps you to decide that often the affordable patient. No doubt that in complex surgeries, robotic is definitely a big tool for the patient. It makes a lot of difference in the outcomes of the operation. How do we justify to ourselves and to the patient, first to ourselves, that doing a simple gallbladder or a simple straightforward hernia or a simple procedure which otherwise you are very comfortable with over the period of your experience, how do you justify that to be done robotically, which is going to involve a lot of extra cost burden on the patient? Where do you draw the line where the patient benefits from the robot or the robot benefits from the patient?
Yeah, I was expecting this question actually.
And also, this is a question which I asked myself. I think most of us who have started and are doing robotic will be faced with this. Chief has already asked this question to me.
Yeah. So there are 2 answers. First, whenever the surgeon wants to shift from this laparoscopic surgery to robotic surgery, we have to do some of this basic surgery before we shifting to a better of the advanced. Second answer is, it is likely that the robotic, this cost of the robot is likely to come down and it may become as cheap as laparoscopic surgery, but I don't know when it is likely to occur, but it is likely to occur. These are the 2 answers currently available I can give.
Also, the thing is, robotic technology is continuously evolving and every 6 months of which right now, like things like harmonic, they are not there. We have a doubt here, we are looking at the Indian Robotic Society. When we did a cost analysis, it is actually what is it is coming very close to the cost because they don't have a lock on the number of times you can use the instrument.
Yeah.
Which is got a 10 after SSI instruments can be used much further.
Yeah.
That is drastically brought down the cost. Initially, we were patient has to spend close to a lakh for the robot alone compared to a laptop. It has been brought down to close to 30,000 now, which is definitely a big step. And I think, like you said, in the coming years, we will be able to match it to a laptop for all basic surgeries. Then we are more disciplined.
Yeah.
I would like to add that so the same question they was open to laparoscopy. At that time also there was a cost difference by the difference And this was the question mostly by Roman surgeons asked to the laparoscopic surgeons. Probably the same situation regarding the laparoscopic towards the robot. Third thing is the last one conference was a conference I saw. There are some systems which are can be integrated with the laparoscopic system. So some like the modular or even all these things can be integrated with the robotic system. So such kind of systems have been made from the market. Yes, I don't know. Definitely say that the robotic definitely having its own future for the new generation. We have to learn the new things because so many things are coming like artificial intelligence is there. Plus the cost is going to come down and slowly the robotic will take more advantages. But for a period of time, we see that we have to unlearn and relearn. This is very important practice. And so we have to adopt it and we have to go.
Thank you, sir, for the engaging lecture. I now request Professor Dr. Robinson Smile to felicitate our chairperson, Dr. Uday Kumar Shamra. Dr. Robinson Smile, please, we request you to go on, guys. Thank you, sir. I request Dr. Uday Kumar Shamra to stay back on the dais. Next up, we have with us Dr. Rajalakshmi and Dr. Devolina, final year students, final year residents, JIPMER, presenting a case of lateral neck swelling. The presentation will be presided over by Dr. Jagadish S., Dr. Uday Shamrao Kumbar, and Dr. Ravishankar P. I request them to kindly come on to the dais. Thank you, sirs. One more in between.
Share the screen.
Good afternoon, everyone. We are Dr. Rajalakshmi and Dr. Devolina, final year junior residents from the Department of Surgery, JIPMER, and we'll be discussing a case of lateral neck swelling. We are presenting a case of a 63-year-old gentleman with no known comorbidities. He's a farmer by occupation, hailing from Tiruvarur, Tamil Nadu, belonging to lower socioeconomic status by modified BG+ scale. He presented with complaints of swelling in the left side of neck for 4 months before presentation. Present illness, he was apparently well 4 months back when he developed swelling in the left side of the middle of the neck, which was insidious in onset, approximately 2 cross 2 centimeter in size as told by the patient, non-progressive, not associated with any other swellings in the neck, with no associated complaints of pain. He also had complaints of productive cough with mucoid sputum, minimal in quantity, on and off for the past 2 months, with no associated complaints of breathlessness, hemoptysis, or chest pain. He had complaints of unintentional weight loss, approximately 15 kgs over the past 6 months. He also had complaints of loss of appetite. He had no complaints of fever. He gave no history suggestive of tuberculosis or contact with tuberculosis. He did not notice any swellings in the armpit or groin. He had no complaints of swellings or ulcers in the oral cavity or difficulty in opening mouth. He had no complaints of swellings or ulcers in scalp. He had no complaints of ear pain, discharge, epistaxis, or hearing loss. He had no complaints of difficulty in swallowing or change in voice. He had no complaints of scrotal swelling, no lump in the chest wall. He had no complaints of abdominal pain, distension, vomiting, altered bowel habits, or bleeding per rectum. Comorbidity, he was not a known case of diabetes, hypertension, asthma, COPD, epilepsy, or thyroid disease. Past history, he had undergone circumcision 10 years ago for an infective condition of the prepuce. Patient is not aware of the postoperative biopsy report. He had no history of any neck swellings in the past, no prior history of malignancies, no prior history of radiation. Personal history, he consumes mixed diet. He has normal bowel and bladder habits and normal sleep pattern. He's a smoker for the past 40 years. He used to smoke 10 BDs per day.
Can I disturb you? Can I disturb you? What is normal bowel and bladder habit? Make it as normal bowel and bladder habit. What is your concept of normal bowel and bladder?
Passing stools at least like up to 3 times a day.
Retina like that. And tell me any book which tells me what is normal bowel and bladder habit.
Patient did not give history of any change in habits is what we mentioned.
What is important, the change? If there's no change in the habit, rather than being normal, there's nothing like normal, not suffering for 10 times. Normal, another. What is important is whether any change in the normal pattern rather than don't use the word normal bowel pattern. If then it change the name of the habit, that is more important.
Okay. He's a smoker for the past 40 years. He used to smoke 10 BDs per day, that is 40 pack years. He quit 4 months back. There was no history of use of any other forms of pan or tobacco. He consumes alcohol occasionally. He's a social drinker for the past 40 years. Last consumption of alcohol was 4 months ago. Family history, he has no history of malignancies in the family. Treatment history, patient went to an outside hospital 3 months ago. He underwent needle testing from the swelling. Patient said that the initial test was non-diagnostic, hence it was repeated, and the repeat test was suggestive of a malignancy. After this, he was referred to a higher center for further management, and he presented to JIPMER 1 month ago. Here, he underwent repeat needle testing, imaging, twice endoscopy per orally as told by the patient, and a biopsy from the oral cavity, and later a colonoscopy. So, summarizing the history, 63-year-old gentleman with no known comorbidities. He's a non-smoker, presented with complaints of a known progressive swelling on the left side of the neck for past 4 months, with associated complaints of loss of weight and appetite. He also complains of cough with mucoid expectoration for 2 months. He had no other complaint. A differential diagnosis would be lymph node secondary from an oral cavity malignancy, followed by lymph node secondary from lung carcinoma, followed by tubercular lymphadenopathy. We would also like to keep in mind lymphoma, and down the list would be a carotid body tumor.
Involved in the exam because history is not going to help that much. You don't have to put all the malignancies, just a secondary. Because you're not going to say primary in the lung or primary. Not your diagnosis to find out this. That's all you want to do. So your diagnosis, you can say metastasis, secondary, you don't have to specify lung or that you can come later on. Okay, yes.
Moving on with the examination, general examination. He was examined in a well-lit room after obtaining consent in the presence of a male chaperone. He was comfortable at rest, cooperative, and afebrile. He was moderately built and nourished. Hydration was adequate. His ECOG performance status was 0. He had a pulse rate of 82 beats per minute, regular rhythm, normal volume. The blood pressure was 128 on 88, and respiratory rate was 14 per minute. SpO2 was 99% in room air, and RBS was 98 milligram per deciliter. His BMI was 22.8 kg per meter square. He had mild pallor, no icterus, cyanosis, clubbing, or pedal edema. No generalized lymphadenopathy was noted. Moving on to the local examination, inspection, with patient in sitting position and a 2 × 2 centimeter globular swelling was noted in the left side of the neck. Superior border was approximately 3 centimeter from the angle of mandible. Inferior border was 4 centimeter from clavicle. The medial border was 2 centimeter from the midline, and the lateral border was 1 centimeter from anterior border of sternocleidomastoid, as seen in the picture. And the surface of the swelling appeared smooth. The skin over the swelling was normal. The margins were well defined, and no pulsar.
This word is normal, is very abnormal. There's nothing like skin is normal. What is important is
There were no skin changes noted.
The word normal for people use little bit indiscriminately. What is important, you want to know those skin changes themselves. So in the exam, don't say skin is normal. There are no skin changes over the skin. That will be more specific.
Okay. And there was no pulsations noted over the swelling. The trachea appeared to be in midline. There were no other swellings noted in the neck bilaterally, and thyroid gland was not visible in the middle of, in the front of neck. Moving on to palpation, inspectory findings such as size of the swelling and location, that is a level 3 lymph node, were confirmed, and there was no localizing temperature or tenderness. The surface of the swelling was smooth, consistency was hard, margins were well defined, and the swelling was mobile in both directions. On contraction of the ipsilateral sternocleidomastoid, the size of the swelling was unaltered with no restriction of movement mobility noted. There were no pulsations felt over the swelling. Yes, sir.
It's always important to think of looking more important. You have large swellings. How do you find out that swelling is deep sternal stud and super sternal stud? You are swelling, sometimes swelling shape cannot be altered with all.
The size of the.
How do you find out whether the muscle keep the muscle super the muscle?
If the
And the swelling will not change even on putting the muscle in the contract. How do you make out? You understand my question?
Yes, sir.
You are saying the swelling does not reduce in size of, that's what you are saying inspection. But how do you make out if the swelling remains the same? Even then you can keep to the, how do you make it? You understand? How do you make out a swelling is deep to the muscle even when the swelling does not reduce in size? You should feel the muscle contracting. When you feel the muscle contracting over the swelling, then you take that can assume swelling deeper to the muscle. That we should add.
Okay.
It may not change in size. Most patients may not change in size. But if it is on putting your hand over the muscle is in contracting over the swelling, then you can presume it deeper to the muscle. Okay.
No other lymph nodes were palpable in the neck bilaterally. Tracheal position was confirmed to be in midline, and thyroid gland was not palpable. Carotid pulses bilaterally were palpable at the level of 6 cervical vertebra. Oral cavity examination. Tobacco staining of teeth was noted. Lips, buccal mucosa, tongue, floor of mouth, and gums appeared normal. A white patch of 0.5 × 0.5 centimeter was noted in the superior aspect of the left palatopharyngeal arch, as indicated by the arrow in the picture. It was non-tender. There was no. It was not bleeding untouched. The edges were raised and the margins were well defined, and mild induration was noted around that white patch. Examination of the bilateral tonsils uvula appeared normal. The uvula was in central position. Scalp, there were no swellings or ulcers noted. External auditory meatus was normal. Nasal cavity, there was deviated nasal septum noted towards the right side. Systemic examination. Respiratory system, bilateral normal vesicular breath sounds were heard. There were no added sounds. Cardiovascular system, S1, S2 was heard normally. There were no murmurs noted. Per abdomen examination, abdomen was soft, non-tender. There were no palpable mass or palpable spleen or liver. There was no shifting dullness noted. Per rectal examination, no growth or deposits were noted. Normal stool staining was noted.
Neck node is acceptable. When you do a correct examination, just tell him.
Yes, sir.
I think it should not, it's not fair to the patient. In many examiners are actually very worried about it. Seriously, if the street doesn't not to clear this necessary. For next node, all of us are doing a correct examination.
No, sir, it was a hard node, probably a malignant node, so we wanted to rule out.
Suppose you are the patient selected to come to you.
No, sir.
Next node, you think PR is acceptable? That's a very clear cut sign, and then I think I'm talking from purely patient point of view. And theoretically, it would justified, anything can occur anywhere. But I think we get a next node, it's very unfair to do a PR on a patient. I think many are not doing that. I think that is not fair to the patient at all. I am not aware of any rectal malignancy so far that put in the neck node in my experience. I think we have a neck node look for things commonly in the neck and maybe in the abdomen. Even testis is not in this particular picture. So from a purely what we call communication point of view, I think it's not fair to the PR on the patient who is on a neck node. Unless you have very specific reason for doing so. If you have a reading PR or something. Completion say you might have said that. But to me, I find it disturbing.
In imaging, actually, later we found that there was rectal thickening cell. In imaging, we had found that there was a rectal thickening cell later. We found some rectal thickening cell. This was in cross-sectional imaging.
You did afterwards. And if you're not doesn't it in the initial part? The impression is that medical everybody should not think it's not clear examination for a patient with that neck node. If you have done that, I can understand that. But if I don't think routinely you should not clear examination the patient from the survival. At least from a patient point of view.
Yes. Examination of axilla and inguinal region. There were no other palpable lymph nodes noted in these regions. Spine, there was no tenderness or deformity noted. External genitalia was normal. No scrotal swellings were noted. Summarizing the case, a 63-year-old gentleman with no known comorbidities, known smoker, presented with complaints of swelling in the left side of neck for past 4 months with associated loss of weight and appetite. He also had complaints of cough with mucoid expectoration for 2 months. He had no other complaints. On examination, a 2 x 2 cm single hard lymph node was noted in the level 3 of left side of neck. There were no other lymph nodes palpable in the neck or elsewhere. A 0.5 x 0.5 centimeter white patch was noted along the left palatopharyngeal arch. So our provisional diagnosis for this case would be a left level 3 malignant lymph node with unidentified primary with a leukoplakia of left posterior tonsillar pillar.
So just wanted to ask a few questions. You mentioned about some of the history. So, Father, can you tell me why did you ask the history of fever?
Sir, it could be a case of TB lymph node. So, in that case, patient might have history of evening rise of temperature. Also, in cases of lymphoma, they might have B symptoms. In that case, also they might have fever. Also, it could be a infective node that can also cause fever.
So the history of fever is very important in because of one, all the tuberculosis lymphadentis might not have a very high rate of temperature, not a classical thing that's described in book, but definitely the lymphoma history is very important. So the history wise you mentioned about 2 to 2 centimeters initially. So has it grown in the last 4 months or is it static?
Patient is saying that it has been of the same size. Patient is not mentioning any notice of increase in size.
So does it convey anything else?
Usually, in a malignant hard node, we would expect there will be rapid rise in size, increase in size of the swelling, but here it is contrary to that.
And
usually, benign cases, it will be a slow growing swelling, or even it might not increase in size.
Okay, if I come to a conclusion that this it is a malignant node, or it still can be benign.
After examination, it is most likely to be a malignant node, sir. It was hard in consistency. So based on the consistency, it is probably a malignant.
Then any malignant report where the node can go slowly.
Thyroid secondaries will be slow growing. Sir.
You are saying this is the lymph nodal swelling.
In the given location, the most common swelling that we see clinically is a lymph node.
Is it deep to the deep fascia? It is superficial to the deep fascia.
Deep to the deep fascia.
How do you know that it is deep to the deep fascia?
By clenching of teeth, the platysma will contract. So the
Will tell us it is deep to the platysma. How do you know that?
it is superficial. It is superficial to the deep fascia. Skin, subcutaneous, and then platysma. Immediately below the subcutaneous. Yes.
Beyond the below retinal is superficial fascia. So, but it doesn't come to the picture. We are asking like superficial fascia.
Yes, sir.
What's superficial?
So on contraction, on clenching of teeth, will contract this deep subcutaneous and the swelling. Usually, if it is deep, lymph node swelling will be usually deep to that, and it should decrease in size. But on examination, we could not appreciate that.
So that's why that's the on inspection this swelling is quite obvious. On inspection also it is seen exactly anterior to the sternocleidomastoid. And there are no ways of contracting the deep fascia. There are some theoretical ways by which by extending the neck, usually the deep fascia will be stretched and the swelling becomes less obvious. That's one thing. Second thing, you can contract the muscles, particularly the sternocleidomastoid, which where the deep fascia is covering it, and we contract the muscle, and if the swelling becoming less prominent, the less prominent see if it lies below the muscle or if it even though it is anterior to the muscle because of this contraction of the muscle, sometimes the deep fascia will be stretched and the swelling become less obvious. The second thing I would like to know that will tell us whether it is a lymph node or a significant lymph node swelling. Second thing you told the level 3 lymph nodes. Why you are telling it's level 3? How clinically you know that it is the level 3? Because levels are basically the intraoperative findings level of lymph nodes. But clinically, how will you know what level of lymph node is?
So it was below the level of hyoids.
So there are certain anatomical landmarks which divides the level 2, level 3, level 4 lymph nodes. Based on that, because in this is very weak patient and those landmarks, particularly the lateral septum was very prominent, and on palpation you'll be able to palpate basically the thyroid node. So that is another important point I would like to emphasize. That is the second. Why were telling malignant lymph node?
On palpation, it was hard, sir. Starting from history, age of the patient, and also a complaint of loss of significant loss of weight as told by the patient, and he also complains of loss of appetite. Examination wise, hard swelling.
Regarding mobility of the swelling?
We could not appreciate any restriction in mobility, sir. Malignant, if it is, if there is
mobile, it is fixed.
this is mobile, sir. If there is any restriction, it would point towards a malignancy, but that is not there, but it does not preclude malignancy.
Another thing which sir has raised one question regarding colorectal examination. In this patient, you are seeing this lymph node enlarged, which you feel that it is malignant, and you are having some suspicious lesion in the oral, particularly the oral lines. You are able to see some leukoplakic, or you are not 100% sure whether it's malignant or not malignant, but there is a one lesion is there, and which is in the area of lymph node. Yes, no.
Yes.
So in that scenario, what I feel that rectal examination will not be required. But suppose this is the only swelling and you are not able to find out the primary, where we call it as a unknown primary. In that scenario, the rectal examination is its own one.
How do you as the level of
Lymph nodes, like level 1 will be between the two anterior bellies of digastric and the mentum. And then level 2 will be between the anterior and posterior belly of digastric. Sorry, level 1A is between the two bellies of anterior belly of digastric. Level 1B is between anterior and posterior belly of digastric. And level 3, 4, 5 are classified based on from the base of skull till the hyoid bone will be level 2. From the hyoid to cricoid will be level 3. And from cricoid till the clavicle will be level 4. And level 5 is in posterior triangle. So that is bounded by the sternocleidomastoid medially, the anterior body of trapezius and the clavicle. And level 6 and 7 are there in the anterior aspect of neck.
So will you differentiate the diagnosis by change If the level of lymph is it a level 4?
Yes, the draining areas are different, so our differentials would change based on the level of the lymph nodes. Draining areas of each lymph node, some are overlapping like level 2, 3 and level 4 are overlapping, but still
Oral cavity they commonly drain into it.
oral cavity usually go to 1, 2 and 1, 2 and 3. Sir.
And then so we which part of that?
Oropharynx. Oral cavity can go to 1, 2, 3. Oropharynx can go to 2, 3, 4. Tongue also, tongue can go to 1, 2, 3, and sometimes it can skip also and go to level 4. Hypopharynx and larynx usually goes to 2, 3, 4. Thyroid can go to 2, 3, 4 and also 6.
So the lymph node level also gives some idea about still I would like to say it is a
Nature of the swelling, sir, it was hard and consistency and
any other point?
it is a relatively short duration, sir. It is only there for around 2 to 3 months. And also, like patient has other, like he's a old age patient, and also examination wise it is hard. Like rarely we'll get a benign condition which is hard and consistent.
Mentioned that there's significant weight loss. Do you think that such a small swelling, we have not found any other clinical evidence of any other one? Do you think that the significant weight loss is significant or what is the interpretation after the examination? Then you have to go back to the clinical history and find out.
If we go by the usual definition, it is more than 10% in 6 months, so that comes under significant weight loss. But it might not be related to the lymph nodal swelling per se. It could be related to the primary, which we have not found it.
How will you work up with patient?
Sir, first we would like to do a
Provisional diagnosis and fully go about establishing your diagnosis.
Sir, our provisional diagnosis is a left level 3 malignant lymph node with unidentified primary, and we would like to first do a ultrasound neck.
With unidentified primary.
Like clinically,
We have got a lesion in the.
yes, sir.
Got a lesion in the throat. It is unidentified primary. Nothing is there unidentified. That is the lesion. Maybe you can make a lesion. In this patient, I don't think justified in the unidentified. I got a lesion, must go the lesion. And at least to me, level 1, 2, 3 is more I am operating. They are used to jugular digas, jugular they are supraclavicular, posticlavicular. The clinical discussion, but I use those terms. Level 1, level 2, these are all operating or actually in the street. The thinking that is much more accepted and more people like us, they're more familiar with that product. Okay.
This is
say that you must say that metastasis probably from a oral vein rather than being oh my God. I think that's the way I will.
Okay.
Go ahead. How will you examine diagnosis?
Sir, first we would like to do a ultrasound neck to confirm that it is a node, and also to take a guided FNA from the node. And also we would like to see the thyroid in the ultrasound neck. So after we, and also I would like to take a biopsy from the white patch that was noted in the palatal.
Patch will take biopsy.
From the edge of the patch.
Why not in the center?
It might be necrotic, so we usually take from the growing edge of a lesion.
So why do you take the edge of the lesion any malignancy?
It is a growing end, so there will be more yield.
The microscope, what you use for? Why do you take from the, these are the basic questions. Why do you take the edge of the, apart from what you are saying, what else that is going, but what else do
compare the surrounding normal, if they
compare the normal to the abnormal, that's where it's much better made out, isn't it? So how will you take, technically I would take a biopsy, deep inside, I would take a biopsy. More cases after OPD are admitted, and you will not take a biopsy. How will you take a biopsy?
Ideally, a edge wedge biopsy should be taken, but it is a very small and
how do you mechanically actually take a biopsy in a deep
we can take a punch biopsy. We can take a punch biopsy.
How easy to take one breath in this lesion as they say. You can take.
It is difficult.
How do you know, how is practically as clinician, how you go about it? But this is the only thing you have. Sometimes you have to do it an anesthesia. Then the high mission may be under mission, they can control the process. You're not really comfortable, they can solve that. Punch biopsy and this thing.
Yes.
Okay. Yes. Nothing.
So,
How do you go about this? You are done an ultrasound, then
FNAC,
biopsy, then
FNAC from the node also.
all the, it says metastatic carcinoma, common to carcinoma. What next, what do you do?
Sir, since it is showing metastatic squamous cell carcinoma, we would like to find the primary of
You have
it.
to find it.
So, okay. So that is
Your company is picked up. You have decided you are not, my feeling is you are in other diagnosis. So that is why you are ignoring it. I never seen the patient. You are giving me lesion and I am quite worried about that. The impression many of you people I know, you know all the diagnosis earlier. And then this lesion is going on discounting because it will not show you. But we have a lesion, so we do something about it.
we would like to do an indirect laryngoscopy, visualize the ulcer properly and take a biopsy from that. We would like to do an indirect laryngoscopy.
Actually, biopsy indirect laryngoscopy. What is it? Indirect laryngoscopy will take a biopsy.
Indirect laryngoscopy.
Direct laryngoscopy will take a biopsy, not direct. Indirect laryngoscopy will visualization.
Visualization.
Nobody take the biopsy in indirect laryngoscopy. Direct laryngoscopy, you can. So what are the silent areas of the neck? What are the lesions of the neck? Where faculty is present before the biopsy.
Fossa prosenmular in the pyriform fossa.
What is fossa present?
Fossa prosenmular is where the eustachian tube ends. It is in the nasopharynx.
Nasopharynx.
Yeah.
Then
pyriform.
what are the silent areas?
Posterior one third of tongue, the posterior pharyngeal wall.
The silent area.
Base of the tongue. Base of the tongue.
So what is that area for? Base of the tongue where one anatomic structure comes in front of another anatomic structure. Vallecula. The epiglottis comes in front of that area. What other areas?
Posterior pharyngeal wall.
Posterior silent.
Pyriform fossa.
Pyriform fossa. What else? Apart from these areas, the silent area of the neck. The nodes come before the triangular lesion.
Nasopharynx. Nasopharynx.
Anybody just told the father of there is one lesion which you every day and day you treat, but you are not getting the answer. Thyroid. In thyroid, patients can get metastasis before actually the cell is given the neck. Okay. So how do you if you want to establish the silent area, how do you do?
We'd like to do in the ultrasound, we'd like to look for any enlargement of the thyroid gland if there is any nodule. We would do endoscopy, sir. Indirect laryngoscopy. We'll take blind biopsies from those areas. From the
deeper biopsy areas in the brain. Continue now. This particular biopsy is coming from the carcinoma and the oral malignancy. Now next part. Take the biopsy from the
and that node biopsy also we would want to FNA we would want to know. And yes, yes.
Even if it doesn't fit into a common carcinoma, it's not a malignancy is less whatever the
next, we would like imaging. We would like to do, sir. MRI or CT of the head and neck, sir, to see the.
Why do you want to CT head and neck? You got a node, you got a biopsy. Why do you want to CT?
Soft tissue involvement, depth of the lesion, extent of the lesion.
Not the depth of the lesion. I can understand. Whatever. How deep it is, okay, I understand. Okay.
Opposite side, if there's any nodes. There can be if imaging shows anything else and if it is we would preoperative workup will do and will
We want to operate.
radiotherapy.
We want to operate on.
We'll go for radiotherapy. We would first do a multidisciplinary tumor board discussion, and based on the discussion, we would most likely go ahead with the plan of radiation, the head and neck. So it would cover both the primary and the lymph nodes. So this would probably be the staging. Like it would be a stage 1, stage 3, because node is positive, stage 3 disease. So patient would need a bimodal treatment. We would first give a RT and then reassess the patient. So for reassessment, we would like to do a post RT imaging after.
So the treatment is non-surgical. It will be
Radiotherapy.
Like the FDA is commerce, the target customer direct. There's biopsy is negative. So what do you want to do?
We'll ultrasound imaging will do and we'll try to find out.
Direct now.
So since it has come as a papillary thyroid carcinoma, we have to there is no primary lesion in the thyroid. We'll plan for a thyroidectomy with MR and excision. After the preoperative workup, we'll plan for a thyroidectomy.
I think we'll go on and on, we'll stop here. Then we go to discussion. We can leave a presentation.
Thank you so much. We want different examiners to hand over the certificates to the presenters. Dr. Rajalakshmi. And Dr. Praveen. I now call upon Dr. Sai Krishna Vittal on the dais. To felicitate the examiners, Dr. Jagdish. Sorry, sir. Thank you, sir. Thank you, sir. I request Professor Dr. Sai Krishna on stage to the next floor. Next up, we have a lecture on management of adrenal mass by Professor Dr. Sai Krishna. I welcome the chairpersons for the session on the dais, Dr. Manoharan G.V., Dr. Balamarugi K., and Dr. Prabhagar G.
Slide change.
இது பாயிண்டர்
அதுக்கு சார் green light.
சரி ஸ்லைட் நான் இதே பண்ணிக்கலாம்ல.
Okay, sir.
Good afternoon, all, and as we go to this lecture, I would like to introduce Dr. Sai Krishna Vittal. Sir is a consultant endocrine surgeon from Sri Sai Krishna Hospital and Apollo Hospital, Chennai. He is also an adjunct professor, Tamil Nadu Medical University, Chennai. He is an honorary senior lecturer for REMC Penang, Malaysia. He is also honorary senior lecturer in Hitchhill University, UK. And he is also the president of Indian Association of Endocrine Surgeons. He is a council member for Royal College of Surgeons, Edinburgh. And he is also governing council member of Association of Surgeons of India. He is chairman of Tamil Nadu Project chapter of ASI. And he is member of editorial board for Indian Journal of Surgery. He has delivered more than 200 invited lectures and innovations. He has published articles in peer-reviewed journals and authored chapters and textbooks. In this area of interest, research interest is in parathyroidism. Welcome you, sir.
Thank you for your kind words, chairpersons. It's indeed a great pleasure to be amongst you for the 6th JIPMER surgical update. I think I've been coming here ever since the first update. I'm immensely thankful for the organizing team headed by Professor Vishnu Prasad. I see in front of me luminaries like Professor Ananta Krishnan. Thank you, sir. So I know I'm standing between you and the lunch. So without much ado, I'll just proceed. So I'm not going to talk on adrenal mass as such. I'm just going to talk about adrenal incidentaloma. How do you approach it? Because this is such a common condition which we encounter nowadays. I will not be going into the details of individual conditions. When you encounter adrenal incidentaloma, what are the things which should go in the back of your mind? How will you deal with it? I will not go into the details because I think that's not in the purview of this lecture. I'm compelled to recall H.L. Mencken, who said, war will never cease until babies begin to come into the world with larger cerebrums and smaller adrenal glands. We see war and strife everywhere. I have no political affiliations, but you know, there's a war going on between Russia and Ukraine, war between Israel and Gaza. It pains me a lot to see such war going everywhere, and I hope peace prevails. I am never tired of expressing my gratitude to Professor Vittal, who is not only my father, teacher, mentor, and guide, but is regarded as the father of endocrine surgery in India. I am what I am because of him, and I'm always thankful to him. Right, coming to the topic proper. The term adrenal incidentaloma was actually coined by two endocrine surgeons in the year 1982, Gilhead and Drew. And that was a new problem facing the clinicians those days because ultrasound was in vogue from the 60s, I think. CT scan had come in the 70s and they were increasingly used and they detected these adrenal incidentalomas. How will you define an adrenal incidentaloma? Adrenal incidentaloma may be defined as an asymptomatic adrenal mass more than 1 centimeter that is discovered serendipitously during radiological examination performed for reasons unrelated to adrenal disease. So there are three components. One, it is asymptomatic. Two, it should be more than 1 centimeter. Three, it is discovered by chance when you do an imaging for reasons unrelated to adrenal disease. So when you come to the epidemiology, a summary of around 25 studies show that the prevalence rate is about 6%. The prevalence increases with age. In patients younger than 30 years, the prevalence is around 1%. In older patients older than 70 years, it's around 7%. And there's no gender bias which has been observed. When you come to the etiology, the commonest cause of an adrenal incidentaloma is a non-functioning cortical adenoma, which constitutes 70 to 80% of cases. The other causes may be a cortisol secreting adenomas, pheochromocytomas, Cons adenomas, adrenocortical carcinoma, metastasis, and the unusual causes may be myelolipomas, ganglioneuromas, cysts, infections, and infiltration. So this should be your shopping basket when somebody asks you in the orals or as part of your theory paper, this should run to the back of your mind. Is adrenal incidentaloma a disease of modern technology? Is it a boon or is it a bane? On one hand, it offers opportunities for early diagnosis of hypersecretory states or early diagnosis of adrenal malignancy and appropriate treatment. On the other hand, most of the lesions are pretty innocuous and there's a risk of overdiagnosis, unnecessary investigation, causing economic burden and mental stress to the patient. So what are the main issues I'm going to deal with the next 15 minutes or so? Is the adrenal mass malignant? What are the imaging modalities one would use? Is the adrenal mass hypersecreting in nature? What are the appropriate biochemical tests you will use? Just a few words about what is called subclinical Cushing syndrome or mild autonomous cortisol secretion. When will you operate in a case of adrenal incidentoloma? If you're going to operate, what would be your preferred surgical approach? If you're not going to operate, how will you follow up? So these are the questions which I'll be trying to answer in the next 15 minutes or so. So for the first thing, is an adrenal incidentoma malignant? So what are the two things you should bear in mind then? One, the size of the swelling. Two, the morphology or phenotype on imaging. When you talk about the size, it is an important parameter that distinguishes between malignant and benign adrenal tumors. If the adrenal mass is 4 centimeter, then the risk of malignancy in that adrenal mass is 2%. However, if the adrenal mass is more than 6 centimeter, then the risk of malignancy is 25% at least. So the larger mass, the risk of malignancy is bit higher. So tumor size is not the only criteria, but should be evaluated in the context of other radiological features. The next thing you should remember is imaging or the morphology, morphology of the tumors in imaging. The primary tool you will use is a CT scan. Remember, benign adrenal tumors are lipid-rich, and the lipid-rich masses have low attenuation when you do a CT scan. So the lesions that have attenuation values of 10 or less are more likely to be benign. So enhanced CT attenuation value is a better predictor of benign tumors than adrenal tumor size. I told you about size, but the imaging phenotype is perhaps slightly important criteria than size. This is, as you see, an arrow pointing out to a benign right adrenal adenoma. All adrenal tumors are not lipid-rich, so they do not become straight away malignant in a non-contrast CT. So as I said, what will happen if the adrenal tumors do not have adrenal adenoma does not have lipid, so attenuation value is going to be more than 10. Straight away, it doesn't mean it is malignant. So then you do what is called a contrast enhanced CT. What is the principle of a contrast enhanced CT in differentiating benign and malignant adrenal masses? When you inject IV contrast, benign tumors take up contrast rapidly. They not only take up contrast rapidly, the contrast gets washed away rapidly as well. This is called contrast enhancement washout. So when a relative washout is more than 40% and an absolute washout is more than 60%, don't worry about the numbers. Your friendly radiologist will calculate all this for you. But if the relative washout is more than 40 and an absolute washout is more than 60, then you can be reasonably certain you're dealing with a benign tumor. This has got a sensitivity of 87% and specificity of around 94%. I think you can see here, this is a non-contrast. This is after 1 minute, and this is after 15 minutes where the contrast gets rapidly washed out. So a typical benign lesion on a CT will be size less than 4 centimeter, homogeneous in appearance, smooth margins, attenuation values less than 10 Hounsfield unit, relative washout more than 40, and absolute washout more than 60. This is a typical, you may not find everything, but just to give you an idea. How is MRI useful? MRI is another tool which can be used to differentiate between benign and malignancy. What are the advantages of MRI? Lack of radiation exposure. Iodine-based contrast is not required. So if a patient is allergic to iodinated contrast agents, you can use an MRI and it gives superior tissue contrast resolution. What is the principle of MRI here? The chemical shift imaging is used to differentiate benign from malignant adrenal masses. What is the principle? In the presence of a magnetic field, MRI is it involves magnetic field. In the presence of a magnetic field, the protons in water vibrate in a different frequency when you compare to protons in lipid. This principle is used to differentiate between benign and malignant adrenal tumors. So when is an MRI indicated? When you do a CT scan, enhanced CT scan, and adrenal mass is indeterminate, you are not able to give a conclusive idea, or when iodinated CT contrast cannot be safely administered, then you would use an MRI. And this is what you encounter. On the right side, you will see there's a loss of signal intensity in out-of-phase images when compared to in-phase images. And why does it occur? Because benign tumors contain more lipid. Once again, the same principle. Here you can see, and this is a right adrenal benign tumor where there's a loss of signal in out-of-phase images. What is the role of PET-CT, FDG PET? Very unusual in a patient with a history of cancer. If you want to evaluate whether the adrenal tumor is malignant or not, then you will use, not commonly used for a management of a adrenal incidentoloma. So we have talked about the malignancy component, where you see the size, where you see the imaging or the morphology on imaging. Now you want to know whether the incidentoloma which you have found out is hypersecretory in nature. You need to take a proper history. There is no substitute for clinical examination, because you can pick up manifestations of adrenal hormone excess in clinical examination. Please note, all adrenal incidentolomas require biochemical evaluation to exclude excess hormonal secretion. A few words about subclinical Cushing syndrome. This was introduced, the term was introduced in 1981. Here, there is no obvious hypersecretion. There's subtle autonomous production of cortisol from the adrenal mass, which suppresses cortisol production from the contralateral gland, but there is no obvious clinical manifestations of Cushing. Nowadays, they use the term mild autonomous cortisol secretion. This is seen in around 5 to 8% of adrenal incidentalomas. Why is it important to recognize this? Because when you have mild autonomous cortisol secretion, there is increased incidence of risk factors like hypertension, impaired glucose tolerance, obvious type 2 diabetes mellitus, dyslipidemia, obesity, osteoporosis, and risk of vertebral fractures. And there is evidence now to state that there's also increased risk of cardiovascular events and increased risk of mortality. So it is always good to diagnose mild autonomous cortisol hypersecretion at an early stage. When you have autonomous cortisol secretion, does it normally progress to Cushing syndrome? The answer is no. Majority may not progress. Maybe 1 to 2% may progress. Then why are we so worried about this? Because we now know that this may be associated with these risk factors. So what do we do when we find such a mild autonomous hypersecretion, cortisol hypersecretion? Do you offer the patient adrenalectomy, or do you do active surveillance? There are two schools of thought, but majority would agree that if there is a worsening of risk factors, definitely you will offer adrenalectomy to the patient. Whenever you offer adrenalectomy, you have to make sure you give perioperative steroids, because the contralateral gland is suppressed. Coming to the biochemical test you would do in a case of adrenal incidentoloma, The first test you will do to pick up increased cortisol secretion is a 1 milligram overnight dexamethasone test. This is a very good screening test for cortisol excess. You will give 1 milligram at 11 o'clock in the night, measure the cortisol levels between 8 to 9 in the morning. If the level is less than 1.8 microgram per deciliter, it is then normal. If it's more than 5, then we are dealing with autonomous cortisol secretion. Once again, I want to emphasize, this is only a screening test. You will do other confirmatory tests as given here. I will not go into the details because this is not in the scope of my lecture. So what are the screening tests you will do to exclude pheochromocytoma in adrenal incidentoloma? The best tests are plasma-free metanephrines and a 24-hour urinary fractionated metanephrines. Why would you use this as a screening test? Because if you note that, I will circle that plasma-free metanephrine has a 99% sensitivity and a urinary fractionated metanephrine has a 97% sensitivity. So these are ideal screening tests to exclude pheos. What will you do to exclude Conn syndrome or primary hyperaldosteronism? Do you need to exclude Conn's in all cases of adrenal incidentoloma? The answer is no. So when will you screen? When an adrenal incidentoloma is associated with hypertension or when an adrenal incidentoloma is associated with hypokalemia, then you are duty bound to rule out Conn's. And what are the biochemical tests you will use as a screening test? All of you know that in hyperaldosteronism, there is increase in the aldosterone. What happens to the renin? Renin is suppressed. So when you measure the aldosterone, it will be high. The renin will be low. Aldosterone to renin ratio, if it's more than 20 and the plasma aldosterone concentration is more than 15, think about the possibility of a primary hyperaldosteronism. Once again, this is only a screening test. You will have to do confirmatory test, which is once again probably dealt with later. What about hyperandrogenism? When will you do this? Routine measurements of sex hormones and steroid precursors are not needed in incidentalomas. When will you do it? When imaging or clinical features of adrenocortical carcinoma is suspected, then you will want to do the steroids. Why? ACC is associated with more than 50% of cases with elevated sex hormones and steroid precursors. So when you're thinking in terms of adrenocortical carcinoma, definitely you will do it. This is a 10 centimeter tumor, which we did a couple of years ago. Right, coming to the next part of my lecture. When will you offer surgical intervention in the case of probably another 5 more minutes? When will you offer surgical intervention in the case of adrenal incidentalomas? All functioning tumors, irrespective of the size, you will offer surgery. When imaging or size points to malignancy, then you will offer surgery. So once again to say, functional tumors, irrespective of size, mild autonomous cortisol secretion, I told you, either you can do active surveillance or if there's risk progression of the risk factors or if the patient is keen, then you will offer adrenalectomy. Coming to the imaging characteristics which is suggestive of malignancy, when the Hounsfield units is more than 10, when there's a delayed washout, heterogeneous appearance, irregular margins, when there's areas of necrosis or evidence of local invasion in a CT, definitely you're duty bound to suspect malignancy and offer surgery. This is a patient with left ACC. With regard to the size, if the size is less than 4 centimeter, you will follow up. Size more than 6 centimeter, definitely you will offer surgical intervention. Between 4 and 6 centimeter, criteria other than size should be taken into account. But more and more studies are saying more than 4 centimeter, better to offer surgery to the patient. Having decided about surgery, what would be your approach? Laparoscopic adrenalectomy is the treatment or the approach of choice for all adrenal masses less than 6 centimeter with no evidence of local invasion. open adrenalectomy would be offered to size more than 6 centimeter and evidence of local invasion. What is the sanctity of 6? Nothing much. Based on the principle is, if it is a cancer, if it's 6 centimeter or less, you can remove safely by the laparoscopic route without rupture of the tumor capsule. If the tumor capsule ruptures, then there'll be tumor seedling. So this is just a ballpark figure, but it's not hard and fast. Finally, last few words of conclusion: an individualized decision-making process is required. Moreover, it depends upon the experience of the surgical team, patient characteristics, and the local logistics. With regard to the follow-up, if you're not operating on a patient, how will you follow up a patient with adrenal incidentoloma? Currently, there is no uniform way of following it up because we lack enough data. But once again, it is based on imaging and hormonal studies. There are two real, what shall I say, universal guidelines which may be followed. One is the American Association Endocrine Surgeons / American Association of Clinical Endocrinology Guidelines, which was given in 2009, where you image in 3 to 6 months and then annually for 2 years. You offer surgical intervention when the tumor grows more than 1 centimeter. The other popular guideline, more pragmatic, more recent, is the European Society of Endocrinology Guidelines of 2016, which says that if the adrenal mass is less than 4 centimeter and obviously benign on imaging, don't bother following it up. If it's an indeterminate mass, image after 6 to 12 months. If there's no growth, don't bother. You will offer surgical intervention if the lesion enlarges more than 20% or if there's a 5 millimeter increase in maximum diameter. With regard to the hormonal evaluation, if it's normal in the beginning, do it annually for 5 years. This is what the American guidelines say. The European guidelines say if the initial hormonal workup is normal, don't bother. Unless there is any clinical manifestation of endocrine activity or worsening of comorbidities like hypertension, type 2 diabetes, obesity, etc. To conclude, practice points, I would say adrenal incidentalomas are more commonly diagnosed because of increased use of abdominal imaging. A multidisciplinary approach is essential and a must. First is you have to aim whether the lesion is benign or malignant. Non-contrast CT is the initial ideal investigation. And in the non-contrast CT, you will see the size and the imaging phenotype. Next, all adrenal incidentalomas will require hormonal tests to exclude hypersecretory states. Mandatory is an overnight dexamethasone suppression test to rule out cortisol excess. Mandatory is plasma-free metanephrines or urinary fractionated metanephrines to exclude FEOs. These are two mandatory tests. Only if the adrenal incidentoloma is associated with hypertension or hypokalemia, then you will want to rule out cons. You will do sex steroids only when you're suspecting ACC. When will you do surgical resection? Hypersecretory states, irrespective of size, or when you are thinking in terms of malignancy. When you are operating, laparoscopic adrenalectomy is the preferred approach. Open adrenalectomy if it is more than 6 centimeter. However, these are all broad guidelines. It should be tailored to the particular individual. With regard to follow-up, there is no international consensus. You have the American Association of Endocrine Surgeons guidelines, and you have the European Society of Endocrinology guidelines. I think the European Society guidelines is more recent and more pragmatic. Finally, I believe that every institution which does it should have their own institutionalized approach depending upon their experience and their logistic. So I strongly feel that we have to frame our own guidelines. Just before I end, this is for the student. Success doesn't come in a day. Success is the sum of small efforts repeated day in and day out. Thank you for your patient hearing.
I now request the chairpersons to felicitate Dr. Sai Vishwanath
Very outstanding. And the privilege to listen to your father. No, there is an MLP. Now, so many years MLP.
We know the first of the Northern and GB to felicitate Dr. Balabhadranath. We now request Dr. Balabhadranath and GB to felicitate Dr. Balabhadranath. Dr. Prabhat.
Thinking that we have some discussion, but it's wondering why participation. I think any questions or any comments from the audience on this session? Yeah, I think Dr. Julia. Sir, yeah. Dr. Julia.
One is number two, when there's a history of cancer in the patient, either past or present history, your duty bound to include metastatic disease. Because when you have a history of cancer, there's a 20% chance that it can be a metastatic cancer. Normally, biopsy is not recommended because arterial biopsy is not very good in differentiating benign from malignancy. Number one. Number two, before you do a biopsy, your duty bound to exclude PO. And because the utility value is not good, you don't use biopsy, you use a combination of imaging tests. That is why sometimes a PET CT may be useful. But a good radiologist will be able to pick it up.
So in this case, if it's confusing, then an MRI would be the solution.
Whichever, finally, it all depends upon how good MRI is a good tool. Contrast enhancing is also a good tool. Definitely, but sometimes it can be a challenge. Biopsy is generally not recommended. And you only do a biopsy when it's going to change the management. If the patient is going to be having multiple lesions here and adrenal, you're not going to change the management. If you have a history of cancer and just a solitary adrenal lesion, then it may make a difference. But the chances of that being very rare. You understand my point? But if you have a doubt, there's nothing wrong in doing a FTG. Yes, please. So,
This is in reference to my question. What's the utility of other nuclear imaging?
What are the nuclear imaging of thinking in terms of? Question to you.
DOTA scan is, I was thinking about DOTA.
Why do you want to do DOTA? What is the principle of a PET? DOTA is, what will you do? We are thinking in terms of neuroendocrine tumor, DOTA might be used. If you are thinking in terms of a PO, it can be picked up in your biochemical test will pick up a PO. Once it's a hypersecretory tumor, it doesn't matter if benign or malignant, you have to operate, irrespective of the size. So it doesn't matter. The utility value of all the other tests is less. Occasionally they may be required. How is the DOTA PET going to help you?
Like just to find out if it's secreting or not.
No, your biochemical test will find out. You use an imaging test to differentiate benign or malignant. Your imaging test is not going to tell you whether it's a functional or non-functional. To tell you it's a function, non-sense function, it's a biochemical test. Your superb screening test, later on you can do confirmation for your field. Okay.
When they don't have any roles in it.
They have occasionally, MIPT may have a role when suppose you are diagnosed biochemically PO. You will definitely do an imaging test. You will definitely do either a CT or MRI. That is sufficient. But suppose you are thinking in terms of extraadrenal PO, suppose you are thinking in terms of a multiple PO, there's nothing wrong. I am not going into the individual details of management of PO, cons, everything. I am giving you a broad perspective of what you will do when you find other incidents. I am not saying MIPG is not useful. MIPG is still that, but the utility value is less. So why do you want to have your PO is already picked up by a biochemical test? Then you do a CT or MRI, that's going to show you. Occasionally you do MIPG, but nowadays the number of requests would be decreasing. You are able to understand my point now? Because I'm not gone into the management of PO, I'm not gone to management one. That is a huge discussion by itself. But generally imaging is done to differentiate benign from malignant. It is not to differentiate between functional and non-functional. That is done by a blood test biochemical. I hope I'm clear.
Thank you, sir. And so one more question can be.
Yeah, please.
Suppose most of the incidents when they have hypertension, that may be due to coachings or maybe due to cons. So that means urinary aldosteroids, plasma aldosterone we don't do routinely, or only we need to do your first year screening test of those dexamethasone.
Adrenal incident, two things are mandatory, irrespective. One is dexamethasone. I'm talking about screening test, and the other is you have to rule out PO. In addition, if the patient is a hypertensive, you will definitely have to rule out hyperaldosteronism.
That may be a feature of Cushing's also, sir, with condoms.
That's what I'm saying. When you do the test, do all the screening tests. Then, just because the screening test is positive, you can't stop that. You will have to go to the individual confirmatory test. If, for example, if your dexamethasone suppression test is positive, you will not stop there. You will next do ACTH. You will do a confirmatory test like a 24-hour urinary free cortisol or a late night salivary cortisol secretion. They are confirmatory tests. They are more specific but not sensitive. Similarly, just because we do a renin aldosterone renin ratio, it's positive, it doesn't mean it's gone. It's only a good screening test. Later on, you will have to do a urinary 24-hour urinary aldosterone. You may have to do a salt loading test. That is more comes under the purview of a medical endocrinologist. But having said that, our aim in an incidental OMA is to screen and pick up and say, okay, we need to do something, or we don't need to worry about it, because we do such a number of scans nowadays. You will definitely end up picking up incidental OMA. And believe me, when an incidental OMA you pick up in a younger individual, pregnant individual, less than 40, try to rule out malignancy.
Your experience on retroperitoneal approach to small tumors.
I think, yeah, retroperitoneal, I don't do it, but I can tell you, in safe hands, it is very good. This was popularized by, actually, I know Martin Walls very well, a German surgeon. He has got the largest adrenal experience in the entire world. In fact, he has done at least 2,000 retroperitoneal adrenalectomies, I think. That's why it's called Martin Walls. It's called the Walls technique. He does it amazingly well. I have seen him operate on 6 pheochromocytomas in Coimbatore, and the patient will walk few hours after surgery. But if you go in the right plane, if you go in the right technique, that is super. Personally, I don't do it. But I am amazed at his skill. He is a master of adrenals, I would say.
Thanks.
We'll now break for lunch. Lunch is being served at the ground floor. I request all of you to have lunch. Please reconvene here in 30 minutes for the rest of the session by 2 o'clock sharp.
the first floor. So please, those who are come from the purpose, come to first floor, multi-purpose hall.
We'll also be having the post presentation for case reports during lunch break. Same to the left of this hall. The candidates should kindly proceed to the hall. I repeat, we will be having the post presentation for case reports in post floor during lunch break.
Again, something is changing. Protected. That is Zoom setting. We have to share later when we're presenting. Now it won't come there. No, it's now it's such. You know what is coming out. It's okay. We'll remove HTML. It's okay. It doesn't matter. Nice. Okay. Once I put into slideshow, yeah. There is a slide changer is there, sir. Pointer is there. Pointer will be needed for radiologist. Not will give it in there. Yes. It will be odd, no? They will be facing here, like so. We can't adjust further. No, this actually only the audience can see. They have to see in the TV. The TV. Okay. And 3 separate displays. Like they will be able to see only TV. We will be able to see only. There are 4 people, so they'll be able to sit there. But I can't see them. That is the only problem. That because it won't be like a actual. It's okay. What is it? You know, the screen is like a little bit more forward. They told they cannot keep it very back. Okay, the screen has come forward. Like 1 feet gap. Okay. Ideally, it was supposed to be back. They told false. So first thing actually we had put two like that, like so. 2 panels here, 2 panels. It's okay. Set. It's fine. Yeah. You know, well. Yeah, that's anything pertaining to this. Hello. The word so far balance or something.
He still didn't get my session starts with the You've given us like something. Okay. The picture has it, no problem. But we are loading it now inside the car. Posted for case reports happening. You have submitted your thesis. Yeah.
And we can take those members for our. Anything like you here.
This is the afternoon session. No, any principal there in alumni. I don't think so.
Carry on, sir.
Delete it.
Grammarly வச்சிருக்காங்க. ஏன் 300? அது ஓகே. எனக்கு என்ன அப்படி இருந்தா 75 மாத்திரலாமா? 15 போகுது. 59. இதுலதான் இருக்கணும். இல்ல இப்படிலாம் இருக்கக்கூடாது. அவங்க வேணும்னா வந்து
All three are I want this. Sanjay, Sanjay, do you want to see this? Right?
Yeah, once again, just
So this case.
switch it off. Okay. Let's change it. Play video gets played up. Yeah, it will be. Just okay. Yeah.
Good afternoon, everyone. We'll now start with the rest of the program. We have with us Dr. Kamala Kannan and Mohammed Adam, final year residents of Pondicherry Institute of Medical Sciences, presenting a case of thyroid swelling. The examiners for this session are Dr. Sai Krishna Mittal, Dr. Sri Venkatesh G and Dr. Balavantan K. I request the examiners to kindly provide the evidence.
Good afternoon to one and all gathered here. Myself, Dr. Kamala. Good afternoon to one and all gathered here. Myself, Dr. Kamala Kannan, and he is Dr. Adam from Pondicherry Institute of Medical Science. And we are going to present a case of thyroid swelling today. 56 years old female residing at West Bengal, former by occupation, presented to OPD with the complaint of swelling in front of her neck for past 2 years. The patient was apparently asymptomatic 2 years before. Then she developed swelling in the anterior aspect of her neck, insidious in onset and gradually progressive in nature. In the past 3 months, there is a rapid increase in size, but it is not associated with pain. No history of hoarseness of voice, no history of difficulty in breathing.
Excuse me, can you just come back to the previous slide, please? When you say the history of presenting illness, generally you say in the patient's own words, am I right?
Yes.
So when you say she develops swelling, the front of her neck would be ideal, rather than say anterior aspect.
Okay.
You would use the word anterior aspect when you are presenting your findings on clinical exam.
Okay.
Okay?
Yes.
So I think it's better to correct you then and that, otherwise we should carry on. What is the significance of saying rapid increasing in size? Any significance?
Carcinoma will be having a rapid progression.
Malignancy can. What about pain?
It is not associated with pain, sir.
Yeah, how is it relevant? What is the association between pain and thyroid swelling?
In anaplastic carcinoma, there will be a nerve involvement, nerve entrapment, and patient will perceive pain. So,
Okay. And how common is anaplastic carcinoma?
it is the least common thyroid carcinoma. It is
Tell me something more common. The example, thyroiditis.
Yes.
That is more common. Anaplastic is though. So if somebody asks you, okay, then you're talking about thyroid swelling and you're saying not associated with pain, why if they ask, so no, sir, swelling, thyroiditis may have pain. That is the answer. Okay. This is only going to be interaction. You are not examined. This is going to be a lively discussion. Okay.
And no history of hoarseness of voice, no history of difficulty in breathing, no history of difficulty in swallowing, no history of increased
Once again, I'll stop. All of these means there is no history suggested of
pressure symptoms.
You understand? So when you say that, if the examiner asks, then if you say no history of hoarseness, he'll feel more impressed. Or you can even delay and everything is time bound, you know. So instead of saying that, similarly, I think I'm telling you now itself, no history suggestive of toxic symptoms. Because I can see that when you carry on.
No history of toxic symptoms, no history of hypo or hyperthyroidism features. And past history, not a known case of hypertension, diabetes mellitus, CAD, epilepsy, and asthma, COPD. No history of exposure to radiation to the neck or in a chest region in the childhood. No history of anti-thyroid drugs intake in past history. Family history, no relevant.
What is the importance of exposure to radiation? Why did you ask that?
In childhood, if there is a radiation exposure of to the neck and chest, there will be more common for developing carcinomas in the adulthood.
What type of carcinoma do you expect?
Papillary carcinoma.
Family. So, what type of thyroid swelling can run in family? Can name some benign and malignant?
Toxic adenomas and medullary carcinomas.
What about Hashimoto's thyroid?
It can occur.
Iron deficiency goiter. Also. Endemic family, no? They are the same of that. When will you call it is endemic goiter?
If the patient is residing in the area where there is a low iron content in the food or else in the areas itself, then it is called as the endemic goiter. In India, the northeastern part of India is called as the endemic region.
How much of the population the locality has to be affected?
No,
10%. More than 10% is called endemic goiter. But one more thing is previous slide you go. History of weight loss. Does thyroid why you ask for weight loss?
In hyperthyroidism, there will be a patient will have weight loss, sir, because of
history, nothing suggests of hyperthyroidism.
no history suggestive hyperthyroidism features.
Hyper.
No history suggestive hyperthyroidism.
No history.
Yes.
So hyperthyroidism only it can have weight loss, isn't it?
Yes, sir.
Increase of weight loss. So we have asked about that. Usually the thyroid malignancy they don't present with the weight loss. Okay. Like J malignancies.
Sorry for the interruption. I would like to make an announcement. The alumni meet has started on first floor. Those who would like to attend it can proceed to first floor hall for the seat. Thank you.
Carry on. Sorry, I interrupted your thought process. But you will be interrupted in the exam, so better interrupted now.
Yes. Obstetric history, P2, L2, and full-term normal vaginal delivery, and menstrual history, attained a menarche at 15 years, and 5 by 30 days cycle regular, and attained a menopause at 49 years of age. Personal history, mixed diet and normal appetite, unaltered bowel and bladder habits, and no addiction history.
What diet you are particularly interested in?
High iodine rich diet.
Then nitrogenic vegetables or
cabbage mostly cabbage and its lentils related to that.
What do they cause? Why they cause? What substance which is present in those cabbage and all this leads to antithyroid. Bioscience. Okay, they interfere in trapping of thyroid. Just a practical point is not for the exam. I know we asked a lot about the cabbage, cauliflower. This is actually more for Westerners actually, because they eat cabbage, cauliflower in the form of salads every day and uncooked ones. You don't eat cabbage, cauliflower every day. I tell my patients, so we don't eat. And even if we eat, we fry, roast, gobi manchurian, nothing will be there. I think for the exam it is better. And anything which is consumed in excess, even cabbage, cauliflower, consumed in excess can have a glycogenic effect. But in the Indian population where we probably have once a week and fried and roasted, perhaps it doesn't have clinical significance. It is just practical point for the exam you have to say. Because your aim is now not to gain knowledge. The aim is to pass the exam. Okay.
The general examination, patient is conscious, oriented to time, place, person, moderately built and well nourished. Patient weight is 50 kg and patient no pallor, icterus, cyanosis, clubbing and pedal edema. Vitals, heart rate is 90 beats per minute, BP 140-90 millimeter of mercury, SpO2 is 99% at room air, and respiratory rate is 18 per minute.
I'm stopping you there. Come back to your field. You can't, in the case of thyroid, you cannot stop with just 90 per minute.
Oh.
You have to say
Regular.
Rate, everything in thyroid definitely.
Yeah.
Okay.
Okay. The local examination inspection, swelling present over the anatomical area of thyroid in front of the neck. A swelling of size 6 into 5 centimeter present over the right lobe of thyroid gland, extending to left lobe, crossing midline, extending from an right anterior border of sternocleidomastoid to left side of the neck, 2 centimeter away from the midline. Lower border of swelling is visible. Skin over the swelling appears normal. No visible pulsation. Moves with deglutition. Does not move with protrusion of tongue. And no ulcer, scar, and sinuses. On palpation, no local rise in temperature on non-tender. 6 into 5 centimeter swelling present over the right lobe of the thyroid gland, vertically extending from thyroid cartilage up to 2 centimeter above the sternal notch.
and horizontally extending from anterior border of right sternocleidomastoid muscle to left side of neck 2 centimeter away from the midline. And lower border is palpable. The swelling is smooth surface, firm in consistency. Plane of the swelling is deep to staph muscles. Trachea is in midline, no pulsation felt, and the Coach's test is negative.
No, let's not touch. Go to the previous slides, please. Yeah, so the previous, the first slide. You said lower border of the swelling. Why do you want to say moves with deglutition?
Sir, it is attached to the.
No. What do you signify moves with deglutition?
Sir, it is a thyroid gland. It is a swelling that is from the thyroid gland.
Okay, why does it have to do with deglutition? I know it's basic, but I only ask basic.
Because of its attachment with the Berry's ligament with the trachea.
Come again?
Berry's ligament.
One of you only should answer. You can't answer half, he can't answer half. One of you answer.
The thyroid gland is attached to the pretrachea with the Berry's ligament.
Thyroid is attached to pretrachea.
Sorry, it's a trachea. It is attached to the trachea by Berry's ligament.
So the thyroid gland is
attached to
the Berry's
ligament.
What is Berry's ligament? From where does it extend to where?
Sir, it is attached to the posterior part of thyroid gland to the thyroid cartilage. The trachea. The trachea.
To the trachea. That is wrong. First of all, Berry's ligament is a condensation of the posteromedial aspect, condensation of the pretracheal fascia between the gland and the cricoid.
Correct.
I will not waste time. I will tell you. The thyroid gland is enclosed by the pretracheal fascia. And where is the pretracheal fascia attached? It is attached up to the cricoid and to the thyroid cartilage. So what happens when you swallow? You have the cricopharyngeus and your thyropharyngeus contracting the inferior constrictor. So when they swallow, the cricoid and the thyroid cartilage move up. What is happening? The pretracheal fascia is attached to the. So they also move. Because the thyroid gland is enclosed in the pretracheal fascia, anything which is enclosed in the pretracheal fascia moves. That is point number one, important point. Second point, what you mentioned, the Berry's ligament is a condensation of pretracheal fascia connecting the posterior aspect of the thyroid to the cricoid. So that is second reason. Third reason, the isthmus of the thyroid gland is closely associated with the tracheal rings. The tracheal rings move up while swallowing. So the thyroid, which is on the isthmus on top of the tracheal ring, is also will swallow. The first is the most important one. Second is yes. Third you can say. You have to have clear concept. You should not say it is attached to the trachea. The Berry's ligament is not attached to the trachea. You will not be faulted for not knowing important big things, but you will be faulted if you do not know basic. Okay, under postgraduate. Okay. So what are the other swellings? Can go with the beginner. Since you understood the concept now. Thyroid.
Thyroblastal it moves with thyroblastal cell will move with deglutition and it is also moves with the protrusion of tongue from midline swelling.
Okay. Pretracheal lymph nodes, laryngeal, even tumors of certiopharynx. Anything which is enclosed in the pretracheal fascia will go. Just imagine it's a balloon, everything in the balloon. That's all. Simple as that. Okay. Carry on.
And
previous slide. You said plane of the swelling. How did you test for the plane of the swelling? I know there was a lot of discussion in the previous case as well. Just to recapitulate, how will you test for the plane of the swelling? You said deep to the strap muscles. How do you check it was deep to the strap muscle? One of the answer.
Clenching of the teeth.
Clenching
of the teeth will. I'm not sure.
How can you write? What does the strap muscles do?
It helps in the flexing of the neck, in the flexion of neck movements.
So how did you test pain on the swelling?
We have to flex, ask the patient to flex his neck and have to palpate the swelling.
Again, the resistance.
We have the swelling, the size of swelling is reduced on flexion of neck.
How did you check for the trachea and midline?
Trials. By trials method.
What is that?
Placing the middle and index ring finger and index finger over the head of clavicle, and by you have to follow the trachea with the middle finger. So that is in the midline on.
Okay, carry on. Rogers test negative.
Yes, sir.
What does it indicate?
So
what is the inference?
There will be hoarseness of voice and thyroid swelling is pushed. Thyroid gland is pushed medially, so that there will be hoarseness of voice will be present. Sorry, striders.
Right. Why? What is the inference? What does it indicate?
Will you get a positive?
Yes.
If thyroid gland is compressing the trachea, we'll get a causes test positive.
What does it tell about the tracheal wall? Tracheomalacia. Isn't it? Think out trachea. That's why you're able to compress.
Yeah.
It will be helpful for us when you do surgery, because we have to be ready for tracheostomy problem, right?
Check the position of the trachea. It's not only just feel for the trachea, also if you in the finger press, see the space between on either sides of the trachea. From the center of the groin and the trachea, you see the space between the finger goes in.
Yes. The right side level 3 cervical lymph nodes of size approximately 1 into 1 centimeter was palpable. Auscultation, no breath audible. Percussion over the manubrium sternum, resonant was there. And examination of a toxic sign, no tremor and no eye signs.
Why did you look for resonance over the?
Sir, retrosternal extension.
But clinically, yes, in the lower body.
Lower body.
Still, why you want to do the percussion?
To confirm it.
Already you are seeing the lower, you're able to feel the lower border of the, you're able to see as well as you're able to palpate. And how they can now. But you have to do. Okay. Because sometimes nodes, in case of middle ECA, they can have done the mediastinum. So that time it will be done. Okay.
The systemic examination, respiratory system, bilateral add entry was present, no added sounds. Cardiovascular system, S1, S2 here. Central nervous system, no focal neurological deficit was present.
Once again, here cardiovascular system, you will have to tell about added sounds. Because if it's a toxic case, especially we'll have to look out for arrhythmia. It's just for complete, may not be relevant in this case. I just want to encompass the entire thyroid exam. Okay.
Is complete in the normal position?
It was felt in the normal.
Felt in the normal.
Suppose it is not felt, so what do you do?
Sir, it is displaced laterally and due to the enlarged swelling. It is felt somewhat higher in higher positions. Sir. Usually it is felt at the C6 level, but due to the displacement, it can be felt somewhat higher.
It's not higher. In this case, it's okay. It looks like a small thing. But otherwise, it is big. If it is posterior, so now the posterior border of sternum thyroid and big thyroid is being displaced. Suppose if it is not felt there also, what else will it be?
Sir, it can be out of two reasons. One is behind the sternocleidomastoid, and the other thing is there may be a compression so that the carotid pulse cannot be felt. Filtration.
Infiltration. Not displaced.
What is it called? It's called Berry's sign. See, basically, in benign conditions, the carotid is displaced posterolaterally. It is felt, but felt posterolaterally. In malignancy, because of infiltration, you will not be able to feel it. And that sign is called Berry's sign. Okay?
Yes, sir. The provisional diagnosis of 56-year-old female, clinically euthyroid, presented with enlarged right lobe and isthmus of the thyroid gland with significant palpable cervical lymph node, probably malignant in nature.
What makes you think it is malignant?
Sir,
Was the tumor hard? Was there any evidence of fixity? Was the cervical lymph node hard? What makes you think it's malignant?
One is the rapid onset of growth, and the second one is the cervical lymph node. Level 3 lymph node is hard in consistent.
So what? Hardly 1 centimeter, you said. 1 centimeter node can be barely palpable according to me. And what is the nature of the node? Was it hard? Was the swelling hard? You never said anything hard about the swelling. It's just points for discussion. Still it can be malignant. That is, just because the lymph node is not straight away jump, will have a differential diagnosis also. Because the thyroid also can have it.
yes.
Okay.
What will you do? How will you manage this patient?
We'll go for a quadruple assessment. Initially, we have to clear clinical history and a clinical examination, and followed by blood investigations. That is, TSH is the main important factor. Then, radiological inspection of ultrasound neck.
Can I stop? Sorry?
Ultra.
You have written indirect laryngoscope.
I mean, to look for vocal cord mobility is a complete.
The first thing you do
No,
first,
sir,
you have to
ultrasound
come to a
neck.
diagnosis. These are other tests you do to corroborate or as a pre-operative evaluation. I will not agree with you if you say after blood test you do indirect laryngoscopy. How will you approach an nodule of the thyroid? Will you do indirect laryngoscopy? So what will you do? Yes, you will do a blood test to see whether the patient is clinically euthyroid and biochemical. What will be a next test?
Then, USG neck, ultrasound neck.
Ultrasound neck.
And based on that, we'll go under a scoring system of thyroid scoring. And
have you done here?
Yes, sir.
Yes, slowly the ultrasound.
It showed a thyroid score in both the lobes with a.
What does this thyroid score mean? Educate me.
It's a thyroid score. It's a mostly malignant condition where the composition, echogenicity, shape, margin, and echogenic foci of the lesion is it is scoring comes under 4 to 6.
What is thyroid score? What does it indicate?
Mostly malignant.
What is thyroid scoring?
Thyroid imaging reporting and data system.
Yeah. Okay, lack of time. Yes, the American College of Radiology, just like the BIRADS, they had a thyroid system to determine the risk of malignancy in a nodule by ultrasound. So they made thyroid 1, thyroid 2, thyroid 3, 4, and 5. You understand? So thyroid score means moderately suspicious of it. Okay. So what does it indicate then? What will you do next?
FNAC. We'll proceed with FNAC.
What is the FNAC finding?
It showed Batista classification of 4, that is suspicious to malignancy.
What is Batista 4 means? Yes, Batista 4 means suspicious of malignancy.
It is mostly malignant.
Follicular.
That means you do not know Batista. What is Batista classification?
It is a scoring system based on the FNIC findings. They will categorize into 6 gradings.
Tell me their different gradings.
Batista 1 is non-specific.
No, you are wrong. It means non-contributory. You have done an FNAC. The smear is inadequate. The cytologist is not able to interpret. It doesn't mean non-specific. Okay, it means inadequate. In your opinion. That is Batista 1. Okay, next. Batista 2.
Benign.
Okay.
3 is mildly malignant.
What point? Do you know?
Sir, 4 is follicular.
3.
3 is goiter and benign.
Let me tell you. 1 is inadequate. 2 is benign.
undetermined signal.
Follicular lesion of uncertain etiology or atypically of uncertain etiology. That's what it means. 4 means follicular. 5 only suspicious of malignancy. You said 4 and you said suspicious of malignancy. 6 means frank malignancy. Why is this gradation mean? The risk of malignancy increases from 3 to 6. If it's Bethesda 3, then it may be 5 to 15% of malignant. If Bethesda 4, then it 15 to 30%. Bethesda 5, maybe 60 to 75% malignant. Bethesda 6, 97 to 99% malignant. These are very, very basic. You cannot say Bethesda 4 and say suspicious of malignant. Sorry, you need more of this. Okay?
And for this patient, total thyroidectomy with the right side central compartment lymph node dissection was done under general anesthesia. An intraoperative bilateral enlarged nodes, lobes with multiple nodules was present. And the
We'll come back to the management. So what's your final diagnosis based on this history investigations?
It's a follicular carcinoma.
Tell me the clinical diagnosis. What's your clinical diagnosis?
It's a follicular carcinoma of thyroid. Okay.
Clinical. Clinical diagnosis, you tell me it's a solid thyroid or multinodular goiter or a diffuse goiter.
Multinodular goiter with the euthyroid state.
Why do you say it's a multinodular?
In ultrasound, it showed a
Clinically. When you say multinodular.
On palpation, a multiple nodule, the surface was multinodular.
Means nodules on both sides of the lobe or a single lobe.
Single.
Isthmus palpable.
Swelling was also enlarged.
So in this case, if when the isthmus, if there multiple nodules. When both the lobes are the single.
only in a right side lobe with the isthmus palpable, some multiple nodules.
Okay, so right side, the right side well multiple nodules. So
It's been there for 2 years, isn't it? Now it has become in 3 months started growing fast. So 2 years, what has been there? So what do you think was that? Probably multinodular effect. Right. So 3 months it is increasing in size fast. So what type of cancer is more commonly seen in multinodular effect?
Multinodular follicular will be most common.
What about Hashimoto's thyroiditis? Is there for some time, can it turn into a malignancy?
It can turn into follicular, sorry, papillary multinodular phenomenon.
of course, it's only one nodule clinically. What are the different diagnoses clinically you say? There is a conflict thyroid.
Papillary carcinoma.
What is asking you is if you are clinically see a solitary nodule, what are the possibilities? Like it can be a solitary nodule, it can be a dominant nodule of a
multinodular, right?
What else can it be?
It can be adenoma or lymphoma. It can be a lymphoma. Then
it could be adenoma, it could be a cyst, it could be malignancy. That's all. It could be a pure solitary nodule. It could be a dominant nodule of multinodular goiter. It could be adenoma, it could be thyroiditis. Malignancy. Incompressible malignancy.
What are the other investigations you'd like to know? Directly at the total before that, the investigation you did. Will you do CT scan?
no, sir. CT scan can be run if in a
What are the indications for CT scan?
extrathyroidal, if you are suspecting extrathyroidal extension, you can go for a CT scan.
Okay.
A soft tissue or any skin involvement. If there is a pre-tracheal or pre-vertebral or esophageal involvement, you'll go for MRI scan.
Okay.
So for after putting the FNAC, you should not have written about operation. done an FNAC, then you have come to a diagnosis. You know, after saying FNAC category 4, immediately you put total thyroidectomy with right-sided central compartment. Anyway, I think your thoughts are a bit clouded. That's why you carry on.
And you said there's level 3 nodes associated, no? So, but in your, I mean, there's only single compartment and not dissection. So that's how the, I don't know, what will be your plan if there's level 3 node because in class. So what will any other further evaluation needed?
Radio in uptake scan can be.
What is the indication of radio scan and
This is how you will bury yourself in the exam. This is what is called digging your own grave.
The radioactive isotopes will be given as a therapeutic.
I'm not asking what will be the radio? What are the indications for radio scan? That's not the indications. We don't do radio scan all patients, right? So when you
If ultrasound wise, if clinical and radiology, if the thyroid gland is normal and you still suspect if TSS level is TF level is abnormal, you can go for radio iodine uptake scan.
If it is
Ectopic.
hyperthyroidism, that is possible. It's not for all cases of hyperthyroidism.
In a ectopic thyroid gland and for metastasis.
People functioning, we have a node in your thyroid. Thyroid node is hyperfunctioning. That is an indication.
You said node is palpable. Why FNAC of the node? That will directly give a good metastasis.
Right, level 3.
Level 3.
Palpable also. Yeah.
FNAC of the node is imperative, pre-operatively. I do not know what is that from, but that could have been a bad experience.
Another thing is that you suspected malignancy because the level 3 node was hard, no?
Yes, sir.
So what is generally the consistency of the node in a thyroid malignancy, the very essentially thyroid malignancy? Is it in the heart? Generally, if you see it's not hard, no? It's squamous cell carcinoma, secondaries you had hard nodes. In the thyroid, yes, sometimes, but most of the time it will be firm or cystic. So node which is cystic, which can be still a metastatic node, is thyroid. Not very good. So that we should make. Yeah, so how will you proceed? Now, what will be your, after your investigation, what is your diagnosis? How will you proceed? Now we have a FNAC based test of code. So definitely you need sample the node, right? Yes. So otherwise, ideally we should have done an FNAC of the node.
So what did you do? Why was the right-sided node left back? Right level 3 node. What was done for the node?
Node was
Thought it was benign and left it, or
so sir, excised.
you
The
had
central
never
compartment.
mentioned it here?
I mean, we have done a central and lateral compartment lymph node.
You said only central compartment. There's no, you are adding lateral now.
The right.
Read what you have written. What is central compartment?
It is the pretracheal and pharyngeal lymph nodes. It is present between the between the carotid arteries and sternal.
See, nowadays we talk only about levels. What are the levels of lymph nodes you remove in central compartment?
Level 6.
Earlier we are talking about 1, 2, 3, 3 level discussion, 4 nodes. Same thing I'm asking. When you mean central compartment, you are removing the fibrofatty tissue and lymph nodes of level
6
dash and dash
6
and 7.
7.
So basically 6 and 7 only you are removing. You have never mentioned about level 3. What did you do to the level 3?
Was it excites?
But you're not telling me. So did you really do it, or you just why are you not mentioning? Carry on. So I just want to point out.
Yes.
Because what you're telling, what you're mentioning are totally different. First of all, FNAC should have been done pre-operative. Because that will determine. Even if we still have a doubt, you can do a intraoperative frozen section of the lymph node. Frozen section of the thyroid is not very useful. It used to be done in the past. They're not very useful. They used to do it for follicular neoplasm to see whether it's follicular adenoma or carcinoma, but that is not very useful. Frozen section is useful, one, to determine if thyroid is malignant, two, if a lymph node is malignant. Okay, so if you had any doubt, you could have done a frozen section of the lymph node.
Well, only given at right side, sir.
So it is called ipsilateral paratracheal section or a right-sided central compartment. So why did you do right-sided central compartment? Because why did you do? Are there any enlarged lymph nodes, or you thought the thyroid was obviously malignant? Why did you do?
And there is a enlarged lymph node, I mean central compartment lymph node is
Why enlarged?
intraoperatively.
Okay.
In biopsy, it showed a right lobe of one focus papillary carcinoma composed of two papillae with nuclear features, and isthmus one focus of papillary carcinoma, and left lobe multiple foci of papillary carcinoma. So it is a multifocal infiltrating papillary carcinoma of thyroid, and with the DM stage of
You have removed the lymph nodes. You have not told me anything about whether the lymph nodes, number of lymph nodes removed, how much was positive for malignancy or all were negative for malignancy. You did a central compartment. You have not made any mention about it in your biopsy report.
it was a right, I mean right lateral and central. It was negative for malignancy, sir. Negative for malignancy. So you haven't mentioned it. It was.
You have to say it was not malignant. Okay, that is very important. Whenever you remove something, you're telling me you've done a central compartment dissection, but you're not telling me the biopsy report of that is not acceptable. Okay, you have to say it may be negative, but you have to tell me it is negative.
What is the complication of central lymph node discussion?
I mean, recurrent lesion damage and
Yes, terminating.
now
Which nerve?
recurrent laryngeal nerve damage.
Anything else? Generally, even for a protothyroid, we see the nerve and then preserve, right? So generally, usually we preserve it unless the nerve is infiltrated or something. What is more than that, what we are worried about? Especially in assembly nerve section.
The other structure apart from the nerve and thyroid, you have
Parathyroid, right?
I think we thought of only two things. Even now, your biopsy report is incomplete because you're not told me the size of the tumor. That is very important. Next thing, before we end, after this, is there any adjuvant therapy necessary for the patient? If so, what? We'll end with this. I think we are on time.
Adjuvant therapy is not, I mean, not indicated for this case.
Why do you say it's not? Why do you say? Justify your answer. Why do you say it is not indicated? On what basis do you say? What are the indications for adjuvant therapy? What? One, it depends upon the size of the tumor. So if you don't tell me the size, how can you say it's not indicated? Two, you are using infiltrator. What is the indication for adjuvant both radioactive ablation? One, size. Two, extrathyroidal extension. Three, presence of lymph node. Four, distant metastasis. Okay, we agree distant mets are not there. You said lymph nodes are negative, although right level 3 we didn't do anything. But you're telling me it is infiltrated, you're not telling me the size. So your biopsy report is not complete. Based on that, you cannot decide. Okay, but you should know the indications, whether it's necessary or not. Okay.
Yes. Thank you. Especially for diagnostic radioactive scan. Yes. Thank you.
Yes,
Thank you.
Thank you.
Promote the certificate of presentation.
One slide.
Dr. Kamala Kanna. Dr. Mohammed Adam. Thank you, sir. Moving on to the next session. We now have with us Dr. Sagar and Dr. Banu Prakash, pioneers and residents from JIPMER, presenting the case of peripheral vascular event. This presentation will be presided over by the examiners. Dr. Simon Dasria, Dr. Balasubramanian, Dr. Kapil Paliwal, and Dr. Prabhakar Ji. You welcome this welcome.
Non-dependent slide. Mic is on.
Good afternoon, everyone. Myself, Banu Prakash, Junior Assistant JIPMER.
Myself, Sagar, Junior Assistant JIPMER.
We are presenting a case of peripheral vascular disease. A 63 years old gentleman hailing from Villupuram, farmer by occupation, and belonging to lower socio-economic class, according to modified Copeland scale, present to our hospital with complaints of pain in the right leg for the past 3 months and blackish discoloration of the second and fifth toe of the right leg for the past 2 months. History of present illness. Patient was apparently normal before 3 months when he developed pain in the calf and foot region of the right lower limb, which was insidious in onset, intermittent, cramping type of pain, moderate to severe in intensity, which aggravates on walking and relieved with rest. Initially, patient was able to walk around 300 to 500 meters, when after which he fought complaints of pain, which was temporary and relieved with taking rest. But later, he has progressed to complaints of pain after 100 meters of walking, and patient currently complains of rest pain, relieved partially with hanging of legs by the side of bed. And patient also gives history of blackish discoloration of second and little toe of the right foot for the past 1 month, which is insidious in onset, gradually progressive, to involve the toes and also the dorsum of foot and up to the ankle of right leg. Patient gives history of paresthesia, that is pins and needle sensation over the discolored toes, no history of trauma, no history of ulcer, no history of first discharge, and no history of blackouts, no history of blurring of vision, no history of chest pain or palpitations, and no history of upper limb involvement, no history of postprandial abdominal pain, no history of impotence. Comorbid history: patient was non-diabetic for the past 8 years and he is on oral hypoglycemic agent drugs and he is on regular intake. No history of hypertension, coronary artery disease, transient ischemic attack, and epilepsy. Past history wise, he doesn't have the similar complaints in the past, and no history of previous surgeries or interventions he underwent. Person history wise, he is married and has 2 children. He consumes mixed diet and has normal bowel and bladder habits. Patient is having sleep disturbances because of pain. Occasional alcohol consumer, and once in 2 weeks, about 90 ml of whiskey he consumes for the past 33 years. And he is also a non-smoker for the past 30 years, and 10 cigarettes per day he is smoking. Smoking index is coming around 300. Family history is there is no significant family history. I'd like to summarize my summary. A 63 years old male, non-diabetic with history of smoking, presented with complaints of intermittent claudication, which has progressed to rest pain of the right leg and foot, with blackish discoloration of the second and little toe of the right foot, which implies our diagnosis possibly chronic right lower limb peripheral arterial disease. Possible level of narrowing would be femoral popliteal.
So just go back to claudication. How many patients, per se, in epidemiology, how many people do you think claudicators go on to gangrene? We follow 100 patients with claudication.
About 20%.
Yes. So claudication, usually what does it mean as far as disease is concerned? Is it a severe disease or mild to moderate?
Mild to moderate.
Usually it's mild disease, mostly at one stage. It can be an iliac occlusion or iliac disease or a pure femoral reservoir disease, only one segment. Usually it's just one segment. So very few that go on for gangrene. Second thing is many of this thing, your story seems good, okay, your storyboard seems good, but it doesn't progress like this. You really have this patient 500 meters for some time, then 300 meters for some time, then 100 meters after some time, and then gangrene. There are no holes in the story. It seems very perfectly going down, like a tap being closed slowly, and then it doesn't work that way in real life. I don't know whether you have this patient. Most of the claudicators remain stable for a long time. One of the most important point about claudication is it is reproducible. You see the patient today, somebody else sees the patient after another. Every time you walk, you'll have the pain at 50 meters or 100 meters. It's very reproducible pain, unlike venous or neurological claudication. I don't want to diagnose, but in venous claudication, you see, there may be a school teacher who's standing for a long time taking classes, but he may not have a lot of pain on Wednesdays or Tuesdays, but he may have a lot of pain on a Saturday or Sunday. You cannot explain, it's not mathematical. Whereas arterial pain is very mathematical. You walk 100 meters, you will get the pain. Always. Morning, night, Sunday, Monday. But whereas venous and neurological, they are very variable. You don't want to go into the pathophysiology, but they are variable. But this is very mathematical. Okay, that is first thing. Second thing is these people would have suddenly gone into for gangrene. Okay, they are just it's just worsening of disease. Okay, at postgraduate level, you should know the pathophysiology because we are looking at arteriothrombosis. So we go into sudden gangrene occurs in these patients who are having a chronic disease for a long time. Okay, so this 500 to 300, 300 to 100, I think doesn't hold. Okay. So define what is basically what is this kind of thing, gangrene? So define gangrene.
Dead tissue discoloration, blackish discoloration of the dead tissue.
Loss of
Define it clinically or you can define it pathologically. So what do you choose?
loss of vitality and function of tissues.
Have to include non-reversible. Okay, death of tissues, the blackish discoloration.
Yes.
You said second and fifth door.
Yes.
Yes. Okay. Just go to the next one. Why have you asked all this history? Blackouts, blurring of vision, chest pain, or?
Usually, we are suspect most common cause will be atherosclerosis. It is a systemic disease which involves brain and central retinal artery, and also in vessels in the chest and abdominal mesenteric artery. And also, we want to know whether it is involving interiliac artery for importance.
So basically, it is simple, common sense. Supposing we are suspecting peripheral vascular disease and you're saying it's an atherosclerotic process. So take for example, femoral artery is diseased. That's what the patient has come. So the diameter, supposing it's this is the diameter. So the coronaries, all the other coronary arteries as well as the cerebral vessels or the carotids, they are smaller than this. Correct? Yes. So if this itself is getting occluded, a diameter of this is getting occluded. So definitely smaller vessels like renals or coronary or something would have definitely have some disease. So that is why we are asking. Because if such a big artery like femoral or popliteal has got disease, so how will those be untouched? So they may be just waiting for a disaster to happen. So that's why we have to make sure that we check all this. How often is smoking? How do you ask for smoking? So how association of smoking and PVD? How close is it?
Patients who have smoking along with diabetes will have 4 times more than risk factor for atherosclerosis. But who has not having diabetes, smoking only it has less towards the atherosclerosis, but it will be more towards the thromboembolic laboratories.
People in the audience should know this is just an awareness thing, whether you know medicine or not, you have to know this as a public awareness. You have 3 times higher risk of peripheral vascular disease than coronary artery disease if you are a smoker. It's a very, very serious problem. And don't think that you need to smoke for a long time to have a peripheral vascular disease. There are certain studies which have shown doing an ABI before smoking And just 20 minutes after smoking 2 cigarettes, there has been perceptible drop in ABI. Just smoking a cigarette, doing an ABI before, and smoking cigarettes and doing an ABI 20 minutes after. So don't people under the impression, youngsters, don't think that you can smoke and you need 20 years or 15 years of smoking. It's real. Cardiovascular disease is 3 times more association, strong association with smoking. And so be careful. And many of the countries in the cigarette packets, we are still in cancer. But the countries like Australia, Brazil, they have an amputated limb on the cigarette packet. Many of the time, because everybody there, they already know about cancers. So now they have moved to the cigarette packet warnings for limb amputation. Okay, so it's that serious. Okay.
Examination.
Yeah.
Proceeding to the examination. General physical examination. The patient is conscious, coherent, well-oriented time, place, and person. He is sitting with his legs hanging down by the level of the bed. Patient is examined in a well-lit room after taking consent. We noticed that he had a limping gait. He was moderately built and poorly nourished with a BMI of 18.42 kg per meter square. He did not have any signs of pallor, ictus, cyanosis, clubbing, or pedal edema. Vitally, his blood pressure, which was measured in the right arm in a supine position, was 128 by 78 millimeters of mercury, with a pulse rate of 97 beats per minute, measured in the right radial artery with a regular rhythm, normal volume. There was no radial delay, no radiofemoral delay, and no vessel wall thickening was appreciated. All other pulses will be mentioned later. Patient had a respiratory rate of 16 cycles per minute with a temperature which was normal. Moving on to the local examination, patient was explained about the procedures of examination and is examined under adequate light exposure after exposing both the lower limbs completely below the level of anterior superior iliac spines. This is a clinical picture of the patient's right foot. This is of the left foot. This is up to the below knee level. Moving on to the inspection of both lower limbs, we found that the attitude of the limbs, patient was sitting again with his legs hanging down the bed. In the right lower limb, we found that there was dry gangrenous change in the second and the little toe with brittle nails, and there were hyperpigmentation changes, loss of skin lustre, loss of hair, which were noted till the lower third of the leg. In the left leg, we noted again the patient had brittle nails, loss of hair, loss of skin lustre just below the ankle level. And there were no tortuous veins that were noted, no obvious muscle wasting that was present, or no obvious ulcers noted in bilateral limbs. Burgess test and capillary filling time we could not appreciate due to dark complexion of the patient. Moving on to the palpation of lower limbs, comparing both the limbs, we couldn't find any significant difference in temperature between the two limbs. There was a dry gangrene of the little toe and the second toe in the distal phalanx region of the right lower limb. There was no tenderness or crepitus that was appreciated. Movements of the joints were restricted only in the affected toes. Rest of the movements were noted to be normal. Capillary filling time was noted to be prolonged in the right lower limb. There were no palpable regional lymph nodes. Moving to the examination of peripheral arterial pulses. On the right side, we can see that there were absent pulses in the DPA, ATA, PTA, and the volume of the popliteal pulse was little less compared to the left side. And on the left side, we found that there were attenuation of flow. There were feeble pulses of DPA, ATA, PTA, but popliteal and femoral, ulnar, radial, brachial, subclavian, and temporal bilaterally were normal. Moving on to the neurological examination, sensory examination, we found that there was loss of sensation over the gangrenous toes, and rest of the lower limb sensations were normal. The sensations that we assessed for were through touch, fine touch, pain, and temperature. Motor examination was grossly normal, and bulk of the muscles, the measurements we noted were on the right side, 28 centimeters at the mid calf level, and 43 centimeters in the mid thigh level. And on the left side, it was 30 and 44 centimeters in the calf and thigh respectively. So summarizing the history and examination, Here we present a 63-year-old male patient, a known diabetic with history of smoking, presenting with complaints of intermittent claudication, which progressed to rest pain in the right leg and foot with blackish discoloration of second and little toe of the right foot. On examination, patient had dry gangrenous changes of the second and little toe with loss of sensation over the affected areas, increased capillary refilling time with absent pulses below the popliteal region in the right lower limb, feeble pulses below the popliteal region in the left lower limb, with skin changes in bilateral lower limb. So our diagnosis would be a 63-year-old gentleman with chronic peripheral arterial disease affecting both lower limbs with critical limb ischemia of the right lower limb. The possible levels of occlusion on the right side would be in the superficial femoral artery, and the left side would be an infrapopliteal occlusion.
Go back to the examination slides. Yeah, just go. Local examination, next one. Next one. This right heel has a gangrene culture.
Right heel.
From this picture is showing the right heel or something, right? It's showing a gangrenous patch on the right heel. Go to the next photo. In this photo also there is something on the right heel. At least that's what my eyes are able to see.
I think there was a.
Now show me your finding this thing, inspected finding. Is there anything on the right pressing? Only your toes are mentioned. It's just a brief glance of the photos and able to see.
There was no gangrenous patch, sir. That is some artifact that is not yes.
Accepted. Okay. You mentioned about the muscle wasting. Why is it significant?
In a patient who has reduced flow to the muscles, we would expect some amount of nutritional deficiency in the patient. Chronic picture, he can have a atrophy of the muscles.
Why?
Blood supply is cut down to the muscles.
It is one of the features of ischemia, sir. Features of ischemia include loss of subcutaneous along with muscle wasting.
Basically, whatever food you take, whatever nutrition you take, you need the blood to reach there for it to see. So basically, you're having something like a localized malnutrition of the muscles. That's one. What's the other reason?
Hesitation to eat.
He's having rest pain. No, he's not been walking. So some sort of disuse atrophy has been setting in. As per you have been telling, no, that 200, 300, 100, and then now rest pain. So he's not using that limb. So he's having a disuse atrophy of the muscle. So both these reasons are. So I think you know about all this dry gangrene, wet gangrene, all the stuff, right?
Yes.
The differentiation and all. You don't have to go into. Just can you just quickly say?
Dry gangrene usually it line of demarcation will be there. Above it, edema will not be there, and like rise of local temperature will not be there. In wet gangrene, local rise of temperature along with edema, and also it will be progressing, and also redness, inflammatory features also will be there, proximal to the lower limb gangrenous part. In dry gangrene, those will not be there, and also line of demarcation will be better in acute and dry gangrene, and line of demarcation will be loss. I mean, will be very. It will be not demarcated in case of chronic limb ischemia.
So what you see here is dry or wet?
Dry gangrene.
Also get that mummification, which is sucked, kind of sucked appearance. Next. So whenever you're examining a PVD case, also make very sure that you have to examine for infection also.
Yes,
so many times that is missed because in all this you may miss the infection part.
Yes, sir.
So because many of these atherosclerosis or diabetes, they have this two demons are lurking there. First demon is infection, and second demon is ischemia. So you need to make sure that you don't just catch on one, you may totally miss the patient, or may have a bad outcome. So this motor examination may not be so important in chronic cases, but in acute cases, it's very important because they'll have in acute limb ischemia, you have to check for sudden loss of motor loss because you can have nerve injury because of the sudden ischemia. So it carries more importance when you examine for checking for sensation and motor this thing, especially when patients having a acute limb ischemia. Okay, but here, okay, not so important, but there it will be very important because they may go for foot drop in nerve injury. So this arterial, this is how you are able to say right femoral artery, left intraarterial artery, how do you say come to that thing?
Complaints phase, first patient is having complaints for the calf region and foot cell. So actually patient will be having pain, what is the below the level of the occlusion. If it is involving iliac or iliac bilaterally, it will be having pain in the buttocks, thigh and calf. Our patient will have only in the thigh, calf region and foot. So we separate this in the side superficial femoral artery. Left side is having chronic like brittleness of brittle nails. So it could be in the starting phase of chronic. So we kept like infraorbital occlusion in left side.
So supposing you have an ulcer, how can you just say 4 or 5 points about how do you tell whether it's a venous, arterial, or neuropathic ulcer?
So an arterial ulcer will be generally involving the end arteries. The tips of the toes will be involved. There'll be a punched out ulcer that is seen associated with pain. It is usually acute in onset. Venous ulcer usually is seen in the gaiter zone. They'll have sloping edges and with associated dilated tortuous veins or history of dragging pain that is there. Neurogenic ulcers, patient will have loss of sensations. Any trivial trauma will have punched out ulcers again, and it will be usually a long-standing condition. Patient misses.
Derivative neuropathy also will be there in diabetic ulcer.
Usually on dependent areas and other than this, pain scores are very high in arterial. Whereas venous, because of the chronicity, usually there will be something like 4 or 5, at least less than 5, under secondary infected. Whereas arterial will be very high and neuropathic may not be painful. And discharge?
More in diabetic ulcer, it will be more in diabetic ulcer.
Just tell about arterial, venous, or neuropathy. How often do they have to change the dressings? You are working in the ward, you would have seen, right? How often do you change the dressings? How often it just gets soaked as soon as you do the dressing? Which ones?
The venous ulcers get soaked quickly and we'll have to
venous
change.
ulcers are more medicine, maybe followed by neuropathic and arterial ischemic. Okay, they really don't have any edema. You see this dry, it will remain dry. You throw a gauze on that, it will stay the same way. Okay?
Yes, sir.
Okay, so pain scores and discharge you have to document, and that will give you a clue to what kind of ulcer that you should be.
Where do you get claudication pain and where do you get wrist pain? Generally, where do you get wrist pain? Where do you get claudication pain?
The conditions, sir.
Head.
Region.
Atypical region.
Rest pain usually is in the foot region, sir, and claudication is in the calf region.
When patient is walking, usually in the time of claudication, pain will be because of lack of blood supply to the calf muscles. And before patient compensates to walk, pain will be because of the muscle. But rest pain will be because of loss of blood supply to the skin, cutaneous vasculature, and also dying of nerves. Dying of nerves.
Can you kind of explain why there is depletion of the second toe and the toe?
Patient also has, he is a non-diabetic for the last 8 years. There could be microangiopathy also sporadic.
Any other possibility?
Dislodged trauma. Maybe
No, we also affected and
any dislodgement of atherosthrombus.
Any other possibility? Is it an alcoholic? Will you take alcohol and sleep in a particular position?
Not sure.
Sometimes when patients have such critical ischemia, they go into some kind of a shock for some reason, or they lie in a position
Consciousness, they may just raise their legs and some of the ships of the boat may go into downhill. What is the physiological difference of dry gangrene and wet gangrene?
Infection will be there in wet gangrene.
Theoretically, and if you factor gangrene, intracity is more than probably.
And the sir said, so how are you going to differentiate venous ulcer from the arterial ulcer? That as a PG level, it's a very important. Already you have said pain score more in the arterial ulcer we told. So how are you going to relieve the pain? That also is very important. Suppose venous ulcer, you have to elevate the limb, the pain will be coming down. Arterial ulcer, you have to hang it down. That also one of the important points. How are you going to differentiate things? Other things, venous ulcer, you have a edema. Arterial ulcer, patient does not have any edema. That is very important. These are all the things we need to differentiate venous ulcer from the arterial ulcer. One more thing, claudication is very important. As a PG level, claudication is very important. What is arterial claudication? What is venous? What is neurogenic? What is osteogenic? You should know how are you going to differentiate each and everything. So can you tell, okay, what is arterial claudication? What is venous? What is neurogenic? What is osteogenic? These four things is very important. Can you able to tell what is it?
Arterial claudication is a cramping type of pain that is usually seen in the muscles. And this pain characteristically occurs after the patient starts walking for a little distance. And
exercise, yes, the muscle does not get enough blood supply, so you start the pain.
yes. And it also characteristically relieves when the patient takes rest in a few minutes before the patient can perform any exercise again. And it is always reproducible.
Venous ulcer will having throbbing type of pain, stabbing type of pain, and it will be relieved on elevating the limb. And it is not, it will take more time to relieve the pain. And also, it not always reproducible.
Here, classic point, once you started here, arterial claudication, once you started exercise or started doing any work, you will get pain. That you started any work, you started doing any exercise, that pain will be coming down. Why? Because all the toxic metabolites are very well away from the muscular structure. What about neurogenic?
Neurogenic claudication, it is posture attitude dependent, sir, in a particular position.
Positional dependent.
Yes.
Osteogenic. Osteoarthritis will be continuous, pelvic inflammatory type of pain will be continuous and will aggravate on movements.
Once you keep the step down, immediately you get a pain. You join or you get a pain. These are the things, four things you should know at the PG level. And one more thing, arterial ulcer and venous ulcer, you should know how are you going to differentiate. Okay. Then find what is the diagnosis. Then how are you going to proceed your things.
First investigation we want to proceed with is duplex ultrasound scan. In duplex ultrasound scan, we would like to know the flow of the blood vessels and also level of, if any flow abnormality, we want to know the in duplex ultrasound. Along with, if further investigation step would be our CT angio based on the duplex.
Whether it was done here or not?
Duplex is done, sir.
Can you able to tell what is the finding?
Biphasic flow noted in the left lower limb below the popliteal region in DPI, PT, and ATA, and monophasic flow noted in the right lower limb below the popliteal region in the infrapopliteal region in DPI, PT, and ATS.
Okay, what is the limitation here?
If it is in the groin region, in fact, obese patients, we cannot able to see iliac region. That is.
We cannot able to why? Why we cannot able to
One is obese patient. Obese patient because of
main patient you can able to
think patient.
Main thing because of the bowel one. Because of the bowel, okay, we cannot able to accurately we cannot able to tell. That is the main thing. Okay. What is the other limitation of duplex scan?
Can't comment on collateral development.
Calcification. Suppose any calcification over the lateral wall, this your wave, okay, it did not penetrate immediately calculated the protein. Should not keep beyond the calculation of the vessel volume. That is one of the major limitations. Apart from that, any other limitations? Reflex scan.
If it is thrombus in the abdomen, thorax regions, we cannot do so.
It is multiple occlusion level. That is one more limitation of the reflex scan. So based on reflex scan, what is your finding? What is your impression?
Right lower limb partial obstruction, sir, and left lower limb partial obstruction, right lower limb complete obstruction.
Where was the level of obstruction?
It will be in the intrapopliteal, like in the antitibial arteries, or antitibial and common both arteries.
So, main thing is arterial duplex is useful because it's very non-invasive. And if you have, even if in an obese patient, if you have a triphasic flow in the femoris, most of the time we take it as nothing major is because it's a running vasculature, right? So inline flow. So we take it that nothing significant stenosis, not a significant stenosis.
Where it is affecting the phases, the waveforms.
So how much you
more than 50%?
Yes, 50% and more is taken as significant stenosis. So then it will affect the downstream. Okay, if something is happening upstream which is more than 50 or more, then you know that there is going to be changes. So by and large, you have triphasic waveforms in the make it that the aorta is okay. And as he said, I think sir you were stating that these are one only thing you have to know is it's operator dependent. So we need to be careful, but no, by and large, it's okay with all the flows and all that. So bifasic is normal or abnormal in the rodents?
Abnormal.
Okay. In upper limbs?
Okay, arteries, it is abnormal.
Upper limb arteries are fine. For the radial and ulnar artery, bifasic flows are can be physiological. Okay. And so this other than monophasic, that means there's no direct occlusion in any of the vessels. That is what the scan is saying. That means the vessels are open.
Progressive occlusion.
No, whether the vessels are open.
Yes, sir. Like it is monophasic flow is also suggestive of complete obstruction, but flow is there.
So other than this, there are any other investigations you will do? Non-invasive.
For that, this a complete report or there is only a Doppler report, it's not a.
So next line of investigation.
It's not a Doppler report, no? Doppler report, you should also know the structure of the.
Full report is not. Full report is not, but only the findings.
Did you discuss with the radiologist because what kind of blockade and all. Just because the flow of the. You know what it is scan.
Yes.
B scan plus Doppler.
Doppler will show you the flow. B scan is not mentioned here at all.
If you have the non-invasive tests other than the Doppler scan,
Ankle brush.
ankle braiding tests. In fact, many of the times you have to do that even before you come to this. So because we use many of our classifications, many of the disease classifications depend on the duplex scan. Like what scores? Wi-Fi glass. Okay, so we use any other scoring, you know?
Glass scoring.
Oh, glass. Okay, then anything else?
Yes.
Sinbar? What is Sinbar? No. So these are your classified Wi-Fi you should know. Okay, so you need to know that it is know about the API sequence. Any other things you can measure pressures? Your
Ankle
PVR, not those PVR, other PVR, medical PVR, pulse volume recordings. No, all the diabetic clinics patients you would have seen, even though I think you have in JIPMER also, endocrinology has it. You have patient is lying down, BP cuffs are tied on all thigh, calf. Like you not seen this machine? Patients would have brought at least because every diabetic clinic outside has this. They are connected and you get these. You not seen? So these are very common PVR machine. Maybe you didn't know that thing. They give API as well. You get pulse volume recordings at various levels. You get these waveforms at the thigh level, at the calf level. 4 cuffs are tied in each. You can get these pulse volume readings. So they are also non-invasive. They do it as a regular checkup for diabetic, just like you do your neuropathic workup. You can measure pressures on the ankle, you can measure pressure on the toe. Do you know that?
Yes.
That's non-invasive, that's what. What is the TDA?
Toe brachial index.
So what is significant? Normal, abnormal?
Systolic pressure of less than 30 mm of HCl that measured at the toe is significant.
So 0.6 and below is taken as abnormal, anything above is taken as normal. Okay. Next. Tell me, how are you going to measure angle brachial pressure index? Just tell me where do you want the cup, where do you want to tie the cup? How are you going to measure? Any idea about this?
Patient has to be in lying down position, and ankle cuff has to tie just above the ankle, around 2 to 3 centimeters above the ankle region. So that
Any other exact position? Just above the ankle, just below the knee joint also, we can call it
2 to 3 centimeters, around 3 to 5 centimeters above the ankle joint we have to, so that we
as possible in the lower side of the coffin. Okay, this is exact position we have to tie around the coffin. Okay.
and we have to do it with the pocket Doppler or handle Doppler. We have to measure the Doppler sound is in the PTA and DPA. We have to take the higher systolic pressure either of the artery. And for brachial pressure, we have to measure tie cuff in the forearm region, and we have to measure in the brachial artery to Doppler. With handle Doppler, what is systolic pressure we have to take. On bilateral arms, we have to do what is the highest pressure we have to take. If normal is 0.9 to 1.3, less than 0.5 is ischemia, less than 0.3 is more severe chronic limb-threatening ischemia.
1.4 should be normal, no? Higher is good, no? Why you are saying, why you are cutting the thing as 0.9 to 1.3?
That might indicate a falsely high value.
Why you get false value?
Because we are not able to compress the vessel wall with the cuff that we are applying. So it is a false medial calcification.
So mainly in chronic diabetes and also CKD patients, heavy wall calcifications will be there in renal patients as well. So that time it will be, you will not be able to compress. So the API will be falsely elevated. Good. And that's it. So what is the indication for CT angiogram? Up to this is fine. I am totally with you. But what is the indication for CT angiogram?
Anytime we are planning for any intervention or revascularization procedure, we would like to get a CT angio done in the patient.
Only when you are looking at revascularization, you are looking for revascularization of whatever sort, then you get a CT, any angiogram. Otherwise, because angiogram itself carries its own risks. Okay.
Yes. In the CT angiogram, it was reported that the right ATA was visualized till the lower third of the leg. DPA was not visualized, and multiple collaterals were noted. And the left lower limb, they also mentioned that there was attenuated flow on the DPA, PTA, ATA, noted with a few collaterals. The right side PTA and DPA also were not visualized in the lower third. That's not mentioned earlier.
Know the usual things of what are the drawbacks or what are the risks first of taking a CT angiogram and what are the. So we just, okay, you go to the next slide, management and then initial findings. One more thing, two more things you have to add. You should know actually what is digital subtraction angiotherapy. One more thing, when we are going to do MR angiotherapy, that also you should know. Okay. Okay. Next slide.
Next slide. We just feel management.
Medical management and what we do. First, you finish up the medical management.
First, we'd like to advise lifestyle modifications. We'd like to ask him to cessate smoking and have adequate sugar glycemic control. And we try to put them on medical therapy initially with single antiplatelet along with statins, and also prescribe a exercise training program under guided under supervision. He has to exercise for 30 minutes thrice a week for 3 months. We can, for his pain, if the CT angio, we think it can be revascularized, we can try a revascularization. But CT angio here is not definitive, so the arterial anatomy is not defined. So we'd have to do a digital subtraction angiography. And if there is a vascularization available, then we'll have to revasculate. If there is no revascularization available, since he already has rest pain, we can consider lumbar sympathectomy for this patient.
The spine is not an indication for lumbar sympathectomy. What is the idea for lumbar sympathectomy? Only one indication.
Vargas
The spine, if you do lumbar sympathectomy, the spine will worsen.
Critical limb critical limb
Chronic non-healing ulcer, it is one of the indication for only lumbar sympathectomy. The spine is not an indication for lumbar sympathectomy. If you do lumbar sympathectomy, the spine will worsen.
Okay.
Indications only. Chronic non-healing cutaneous ulcer is the indication for lumbar sympathectomy. Here, interventional procedure apart from devascularization, medical management, here only small vessel involvement. No? So what about interventional procedure?
interventional therapy.
Conservative amputation, wait for the line of treatment.
Endovascular.
Any balloon angioplasty?
Endovascular therapy with or without stenting we will do, sir.
Endovascular revascularization with wire and balloon and doing an angioplasty can increase the vascular supply. The other new things which are coming up are stem cell therapy. That is also now thing. And still more, we can also do prostaglandins are also tried, both intravascular as well as intravenous EG-E1 infusions. Just you can just at your level at least know that these are the names and the thing. So kind of PVR also, because many times you are seeing these charts, they need to do the training. So you need to know this.
Yes.
Just the names. Okay.
Yes.
Thank you.
Thank you.
Thank you, sir. I now request our examiners to award the certificate of presentation to Dr. Sagar.
Random.
Dr. Bhanu Prakash. We now call upon Professor Dr. Jagdish to come up on stage to felicitate our examiners. Dr. Simon Garcia. Dr. Balasubramanian. Dr. Kapil Valit. Thank you, sir. We next have a panel discussion on management of early breast cancer. The panel discussion will be moderated by Dr. Gomati Shankar. The panelists include Dr. Sunita VC, Dr. Dinesh Kumar, Dr. Prashant Dinesh, Dr. Guruseelan K, and Dr. Amrit J. We request them to kindly come on the dais.
Eight changes. Just for the point. A very good afternoon, respected teachers, colleagues, and dear delegates. We'll be having a short discussion about management of early breast cancer. So myself, I am Dr. Gomti Shankar. So I'm a surgical oncologist and breast surgeon. And my panelists are Dr. Prashant Ganeshan, sir is a professor in medical oncology. And Dr. Sunita Nair, madam is our radiology HOD, and she is our breast radiologist. Dr. Gunaselan is a professor in radiation oncology with a special interest in BCS radiation. And my colleague Dr. Ankit Jain is a fellow breast surgeon with me. So going to the case per se. So this is a 57-year-old postmenopausal female who presented with right breast lump for 2 months. And no other symptoms she had. It was an incidentally detected lump. So Dr. Ankit, how to proceed further? Like, so what will you do? Please speak into the mic.
Clinical examination, the investigation is the public examination photo. Clinical examination finding.
Okay, so as you rightly pointed out, the assessment is called triple assessment in any breast cancer. It is clinical, radiological, and pathological. Sorry. This is the clinical finding. What else you would like to know from us?
The women is the first week for the patient.
Yeah.
They are seeing the first time. Clinically, we can have some idea whether it can be a malignant lump or not. So I would like to see the breast volume to the lump ratio. What characteristic of that lump, position of that lump from the nipple and the breast meridian and other areas, so that upfront surgery is planned, so that we have some idea what kind of surgery we are going to do. And X-ray assessment and quadrilateral breast assessment will be used.
Okay, so like as Dr. Ankit has pointed out, in early breast cancer, it is important to note the size of the tumor and also the tumor to breast ratio, because most of these patients will be planned for a breast conservation surgery, and which quadrant the tumor is located and whether the clinically the axilla is negative or not negative. So what next? We saw the triple assessment includes clinical, radiological, and imaging. So should we do imaging next or should we do biopsy next?
So like guidelines will say imaging guided biopsy is the purpose of imaging for biopsy. And we have studies which says that imaging guided biopsy, the sensitivity and specificity is more. But on the other side, we have some studies which show that both are equivalent. At the end, the decision should come down to the logistics of the institute. If a patient has to wait for an investigative imaging guided biopsy for a month, then it will not be a feasible thing. Then
No, assuming that you have availability of same day ultrasound guided biopsy, what is your take on it? Like, so?
That is because then what guidelines suggest, then we can go for.
So what are the pros in doing? I'm not asking about image guided biopsy. I'm asking about doing imaging first, like doing a mammogram first versus doing a biopsy first and then doing a mammogram. That's my question.
So if I do biopsy first followed by mammogram imaging, it can alter certain findings in the imaging, which may make it difficult to interpret. It may update the biopsy staging for that patient, biopsy staging. So that we have to keep in mind, because ultimately biopsy is not some definitive thing. Then we have to call it clinically and radiologically, and then it may be a difficult diagnostic dilemma to go ahead.
Ma'am, your take on it, like, would you advise imaging before biopsy or like so?
I would also advise imaging before biopsy. As Ankit said, it may alter some findings, and the post of hematoma, post biopsy hematoma in very rare occasions can also alter the size of the lesion and characteristics.
Yeah. So, but logistically speaking, in a palpable lump, If you can get the imaging first and then do the biopsy, that's well and good. But most institutions, including ours, do have a waiting time for breast imaging. So practically, it is okay to do a breast biopsy in a palpable lump, noticing the clinical size accurately, so that you don't get confused later because of hematoma or something. So note down the clinic, because finally every decision is based on clinical and imaging. So clinically, we have to capture the details accurately, and then you can proceed with the biopsy and then do a mammogram later. If you have facilities, then best is to do the mammogram first and then do the biopsy. So this is the mammogram of that patient. Ma'am, can you please interpret this mammogram?
Okay, so this is a cranial view of both right and left hip for comparison. So we should always remember that whenever you are interpreting mammogram, always compare the right breast with the left breast with similar views, like cranial caudal with the cranial caudal of the other side, and similarly MLO complex. So in this particular case, the clinically palpable lump, we all know that it's in the upper outer quadrant. So here also in the, this is the craniocaudal view. So whichever is closer to the upper part of the screen is the outer half. If you draw a midline from the nipple, the part which is closer to the upper part of the screen, that is the outer, and part which is below the in the from the midline to the lower half, that is the inner quadrant. So in the CC view, we are seeing some asymmetry. You compare with the opposite side, left side, there is right significantly higher density. But I tell that it is not a very clear-cut margin. So I would like to see the MLO view also to exactly locate the lesion. Okay. So here also we are seeing, and it is having an irregular shape. So it is already okay. Here also we can draw one line from the nipple to the pectoralis. Can you just point at the nipple and the pectoralis? Can you draw one line?
Yes, ma'am. Aditya, no, how to draw here?
Okay, no, just with the laser you can just point with laser pointer if it's possible. Yeah. So from nipple to pectoralis. So whatever is above that line is the upper quadrant, and whatever is below is the lower quadrant. So this way we can localize the lesion in which quadrant it is. And also one more thing is, apart from the quadrant, we have to tell the depth of the lesion, whether it is in the anterior 1/3, the middle 1/3, or in the posterior 1/3. So this particular lesion is in the middle 1/3 of the breast in the upper outer quadrant. Shall I go to the details of description of a mass, or you can come in the following slides?
Yes, ma'am. Can you explain these terms for us? Like, what do we mean by these terms?
So whenever we are in the, can you please go back to the yeah, please. So here we are keeping the right and left side by side. So before assessing the lesion, we have to tell what is the density of the breast. So density categories are, there are 4 categories. The category A is an entirely fatty breast, where the sensitivity of mammogram is very high. We can easily detect any lesion. And the category B is where there are glandular density very scattered here and there, a few glandular areas. Here also interpretation is easy. The third category is category C, where there are heterogeneous areas of dense glandular tissue. Here, if the mass is also within that area, it may be osteal. And the last one is extremely dense breast, where the entire breast is having glandular tissue. So this is a type C breast, where we have heterogeneous glandular tissue, and the margins of the mass is not very clear. So now coming to that is about the breast density. So this is a type C breast. Next is describing the mass. So when you describe the mass, first you have to tell what is the shape of the mass. The shape can be either oval, round, or irregular. So this is an irregular. This is neither oval nor round. Next, about the margins of the mass. Whether it's a well circumscribed margins, or it is indistinct margins because it's merging with the glandular tissue, or it has spiculated margins, or indistinct, or microlobulated. So in this particular case, I will say it's an irregular mass with some speculations from its margins. So these are highly suspicious features. And after describing the mass, next we will go to any associated microcalcifications or associated findings such as skin thickening, nipple retraction, or axillary lymphadenopathy. So if you describe all this, so that will, and finally we can give a PIRADS category to the lesion,
and also mention the additional finding. Now, apart from mentioning the BIRATS category, we should also mention what is the next step. So if it's a BIRATS 3 with a like when it's a well circumscribed mass having more of benign features, you can say the patient can come for short interval follow-up. Whereas if it's a suspicious mass, either BIRATS 4 or 5, definitely she has to undergo the BIRATS.
Thank you. Okay, so the key lesson is if you see only one breast mammogram, if it's only one side is projected, are we able to make out something? It's very difficult. We see the isolated sides. So you have to always see them side by side with comparison. And we actually need magnification tools also to use. All the basic imaging viewing software will have your magnification tool. That is also essential to identify the lesion. So like ma'am has pointed out, if you see this side, the normal breast, there is nothing here. Whereas on the affected breast, we see a high density lesion. So that's why we're able to make out. Otherwise, if you compare this, it is very difficult to make out which is the, if you put only one side, it's very difficult to make out is there a problem here. So only when we compare with the normal breast, we'll be able to make out the lesion and make sure that your radiologist uses the appropriate terminology, like what ma'am has said, irregular, density, speculated. These are the terms which are used to describe malignancy. If a radiologist says malignancy, but none of these terms are available in the report, it's better to discuss with them again on what basis they are calling it as a malignant tumor. So this zone also, like madam has explained prior. So this is the anterior, this is the middle, and this is the posterior zone. If you divide breast into 3 zones, in a good report, you will get also the zone of the lesion because that helps us in surgical planning. So this was the report we got. There was no suspicious calcifications. Retromammary zone appears normal, and this is again a specific negative comment which a radiologist should give because that is a zone prone for missed cancers actually. So what is the role of ultrasound, Dr. Ankit, in this patient?
Since this is a calcareous lesion, still US will help us to first of all localize any suspicious lymph nodes in axilla and in the suprapubic fossa or other side of the axilla. And within the breast, we would like to note any other secondary lesion and extent of that lesion which may not be palpable to us actually. So that we can, with the help of the radiologist, we can point out and see and plan the further.
Okay. So, ma'am, can you explain about the ultrasound features on the lymph node part? When will you call a node a suspicious?
So normally, a normal lymph node will be oval in shape with a central fatty hilum, whereas a lymph node which has metastatic deposits within it loses its oval shape and becomes more of a rounded shape. And sometimes the cutoff usually given is if it's above 10 mm short axis diameter, that is suspicious, then you have to do an histopathological diagnosis for it, either an FNEC or a biopsy. But if it is within that borderline range, but still if it has a cost which is thicker, more than 3 to 4 mm, that is also a suspicious feature with compressed fatty hilum in ultrasound.
To sum up, we should understand that ultrasound is essential to characterize the axillary lymph node. Mammogram can give us information about the primary, but to talk about the node, we need an ultrasound always. So sometimes it's always done, but you should always look for it. Like just seeing the mammogram report alone is not sufficient. So you have to understand that because people think like younger women, ultrasound, and older women, mammogram. It's not like that. Both have got role in both. And for the nodal part, ultrasound is very essential for all age groups. And as ma'am has pointed out, based on the shape and the cortical thickness and the fatty hilum and the size, we will call it suspicious or not suspicious, which should trigger an FNAC. Okay, so now we have the imaging. So imaging wise, it is a small lesion, less than 2 centimeter lesion with no suspicious lymphadenopathy. So how to go about the biopsy? Dr. Ankit, will you do a guided biopsy for this, or will you prefer a, given the assumption that we have guided biopsy available? Availability is a different issue, but suppose both are available, what would you prefer?
It is available, so then going by according to guidance, we go with the guided biopsy.
Okay. Any reasons why it is preferred?
Sir, we discuss unguided biopsy after imaging, or we are discussing before imaging?
After imaging also. After imaging also, it's not always possible to have a guided biopsy. The source constraints are there.
after imaging guided biopsy, because sometimes we can target the areas which look more suspicious because tumor may have lots of desmoplastic reaction, which may not be actually tumor. In that way, it helps us to target the area. But again, we have to see the logistic thing. If delaying it, will delay the biopsy report more, than better to do a unguided biopsy. It's not like the sensitivity is almost half. 20-30% difference are there. But again, we have a paper which says, some study which says it's almost equivalent.
So, ma'am, where would you recommend a guided biopsy for sure? Like where you say that this patient has to undergo guided biopsy. There is no role for unguided biopsy.
Sometimes the lesion may have a solid component as well as a cystic component. In such situations, it is ideal to go for a guided biopsy so that we can target that solid area and take good course from the solid area. When palpation, this may not be possible.
So whenever we have imaging available, then it will help us further. The lesion is entirely solid. It is acceptable to do a unguided biopsy. If it is solid cystic, then guided biopsy is the best choice. And when you do a guided biopsy, the second option you have is you can also put a clip within the lesion under guidance. That will help you later in treatment planning. So the lesson is you can do an unguided biopsy after imaging in a palpable lesion which doesn't have any cystic component. If there are cystic components, then it is better not to do an unguided one because unlikely to be successful. You'll be doing 2 biopsies. So what to request in the biopsy form? Gonna see, let's yes.
Then what says what nature of the freedom to others of
Would you ask a K67 also sir, for all patients? Like so. Okay. Okay, so we need to ask for the diagnosis per se. What does the pathologist think? What are the type of the breast cancer? Because there are special types and there is a type called not otherwise specified, which is the most common type of breast cancer. You should ask for the grade. We should ask for the ERPR status, HER2 status, and the K67 status because all of these things have an implication on further management. This is the biopsy report we have, which showed the tumor was predominantly DCAS, cribriform pattern, and it was grade 5. There was invasive component, but it is only 10% of it. It's ER negative, PR positive. They did not have adequate tissue to do the HER2 but K67 was also not done. So this is the final impression by the pathologist. It's DCIS and the invasive component is only 10% of the biopsy. So should we do a repeat biopsy or is it because or can we offer surgery? To sum up so far what you discussed, this is a probably T1 lesion, N0, and biopsy showing DCAS with an invasive component. Receptor status is incomplete. So in this scenario, Dr. Ankit, what is your take?
So rightly speaking, all the biopsies pre-op should be decision should be based on taking aside the biology of the tumor, which includes type as well as hormone status and all. But having said that, this is T1 N0 tumor, both clinical and radiologically. So having a hormone status may not alter our treatment plan. Other than that, other than the thing, if you want to go BCS and if tumor breast ratio is not adequate. So it's a enough ratio is adequate for a BCS and upfront surgery is possible, then doing a repeat biopsy as such will not alter the treatment plan in this patient. Even if TNBC and HER2, she will qualify for upfront surgery because of even and
Prashant sir, any difference of opinion? If it is 2 centimeter, if it is TNBC or HER2, would you like to change the plan or would you allow us to go out with surgery?
We are a very strong believer that it's an operable tumor. There is no harm in operating the tumor.
Okay.
All these thoughts of giving neoadjuvant therapy in HER2 positive cancer or in triple negative breast cancer, which is now commonly practiced, including our center. The benefits are notional.
no randomized trial has ever shown that giving neoadjuvant therapy improves survival in HER2-positive or fertilized breast cancer. So if it's going to cause unnecessary delay by repeat biopsy and things like that, then otherwise operable breast cancer metastasis, if a BCS is going to be feasible upfront, there is no harm in doing upfront surgery, even if it's TNBC or just for that sake, we need not keep on biopsy.
Yeah, I agree. So if the scenario is say it's node positive disease, then we might have thought of something else. But in this patient, I think without even the receptor status, we can go out. But you should understand that this is not the norm. This is a decision based on a discussion we take. You always need the receptor status before starting treatment, but you may face scenarios like this.
So one thing to add, sir, sometimes in such cases also we may have to do the repeat biopsy, because if an old patient not getting fit for surgery, then she might want to have for neoadjuvant hormone therapy, or she wants to wait for genetic testing because of a family history and all. Then we are waiting, then we can do the
So
biopsy.
basically, when there is a strong role for neoadjuvant, then we should get the receptors sorted out very clearly. But in a T1 lesion, it is okay, even though it's not the standard of care, it is acceptable to offer surgery. That is the message. So will we do any further workup for this patient?
Just in case the patient has the same symptom, should we get an epilepsy or
Sir, we try to document the axillary lymph node status, because that has impact on the post chemo radiation, all that. So it's treated as node positive disease. Post chemo, the thing can come negative actually. So it's better to assess the axilla pre-op. With the clinic. That's one of the advantages of doing a guided biopsy resource. Okay, will you do any metastatic workup, sir? T1 N0.
Just one more point. If you go back to the slide on the cytology of this, so here there was not enough tissue available for HER2 assessment. Suppose we do a HER2 here, what are we likely to find? So this is a common thing which happens because there's a lot of DCIS component here. The residents should remember that the DCIS component will almost always be HER2 positive. But that does not mean that the tumor should be taken as a HER2 positive tumor. The thing to start neoadjuvant chemotherapy using an anti-HER2 agent. This is a very important thing to keep in mind. There's a lot of DCIS. The DCIS is invariably HER2 positive. So that does not mean that the tumor is HER2 positive. You have to look at HER2 specifically in the component that has to be discussed with the pathologist.
Yes. So DCA, I mean, HER2 has got value in the invasive component to sum up in one line. Metastatic workup, sir, will you do
This is the T1 for T2 early breast cancer, no nodes. There is no need for any elaborate metastatic workup with this patient. So we can straight away go for
So that's the other thing, because these patients are commonly ordered CT scans, bone scans, all that. In a hormone positive disease, T1 lesion N0, T2 N0, up to T2 N0, there is no need to do any metastatic workup unless it is clinically indicated. If the patient has got some bone pain, some symptoms suggestive of metastasis, yes, we should. Otherwise, there is no need to do any metastatic workup for these patients. Any other investigations?
Other than if you are considering upfront surgery, other than the PSC workup, I don't think we need to do anything, because she does not qualify, I think, for genetic testing.
Okay.
And MR mammo, again, the evidence is not clear to go ahead with anything. So we have a baseline mammo, we have an ultrasound of the breast. She does not qualify for metastatic workup. So the PSC workup is the only thing next to the usually comes.
Okay. So, but the evidence keep on changing for the genetic testing thing. The current guidelines recommend up to age 65, even though we're not broadly adapted it, it can be offered if the patient is keen. So that is something which you can offer to everybody who is less than 65 diagnosed with the breast cancer. But so this patient we did not offer. So this we already discussed, the pros and cons of NSAID versus upfront surgery. Sir, will you consider neoadjuvant hormonal therapy? She is 57, strong ERPR positive.
Here, one problem is that we did not have the full year.
Uh-huh.
So let's assume that she is strongly
Yes, sir.
positive in this question problem. So the exact indication for giving neoadjuvant hormone therapy, if, so again, the same thing comes here. Whenever we are contemplating a neoadjuvant therapy, then only the question of neoadjuvant hormone therapy comes. If there is an indication for giving neoadjuvant therapy, suppose a person cannot withstand chemotherapy, either due to age or sometimes due to patient's personal choice. We have faced situations like that also. Some patients just deny chemotherapy, they don't want it for whatever they are perceived or real risks of the. In those situations, in a strongly positive tumor, neoadjuvant hormone therapy is a reasonable option. Please remember that if your aim is to shrink the tumor and you want to shrink it to make it available for let's say PCS or something like that. In that situation, generally speaking, neoadjuvant hormone therapy will have a lesser response rate than neoadjuvant chemotherapy. But there are exceptions that it's strongly positive or it's biologically, if you are able to do some special genetic tests, biologically you will be highly responsive to hormone therapy. In that situation, you may get up to 50% response rate with hormone. But in general, the response rates are higher with chemotherapy than with hormone therapy. So depends on where you want to place this.
Yes, sir.
It can be used mostly elderly patients, some expected delay in surgery, and you just want to buy some time. But if you don't want to use chemotherapy, then it's perfectly fine with neoadjuvant hormone therapy.
Yeah. So we have an option called neoadjuvant hormone therapy, which can be used at the discretion of the medical oncologist. That's what I would say in one line if you ask me to summarize. So what we decided for surgery. So what options should we give to the patient? Because this is early breast cancer. Dr. Ankit?
So like this patient will qualify for the BCS. So options as such is not in the option actually. It's a clear-cut medical decision because she qualifies for BCS in all the checklist which we have checkpoints in which clicks. Because evidence-wise we know now initially trials says like local differences were higher and OS was similar. But now the current meta-analysis that which all have the latest one with the 18 lakh patients shows overall survival is also better and local difference rate is in fact less than this is at least 0.64. And quality of life is obviously better because such patients have early return to their daily activity. They are more confident. They are more satisfied with their appearance and acceptance in the society. So all
any
this,
different takes like Dr. Gunaseelan, sir?
Usually, takes is very clear. It's not the patient. It's obvious that for early disease, conservation is superior to the rest of them. We are talking about very early condition. So that in terms of survey benefit also, the same previously, initially it was a similar survey, but now it is even better than mistaken. All this under the bottom line is that patient has to come rigorous follow. So they have to be motivated for a minimum of 10 years should be there. So that is very important. So otherwise, conservative surgery is the treatment of choice.
Yeah, the message I want to give is very clear.
One point,
Yes,
I think the different hospitals
yes, sir.
are there here. So one thing is, we are going for BCS, radiation should be available.
Yes, sir.
I think that important point is keep in mind. If you have a radiation facility available, then okay, it's perfectly fine. If you don't have radiation facility available, then there's no question about it. You have to go for that.
We see here is that since it is surgery unradiation.
Yeah.
It is not the radiation to give out like when survival level. So it is an inherent component. So after that, use radiation.
Yeah, it's as sir said, it's BCT, breast conservation therapy, it's surgery and radiation. So in early disease, if you can offer it, that's the best thing for the patient actually. If you cannot offer it, then it's a different question. What is your logistics? What is patient's logic? That is different. But whenever possible, this is the recommended treatment.
So one thing I just want to add, if radiation is available, just to avoid radiation, doing mastectomy is not the right option. If radiation is available and patient qualifies, then BCS is the option.
Yeah, I think there is some data about what Dr. Ankit is saying, which shows that BCS plus RT has shown superior survival for mastectomy without RT. Anyway, that's a matter of debate, but there is a lot of evidence upcoming in this.
how will we manage the axilla? So whenever we manage the breast cancer, two things we have to manage, the primary and the axilla. So axilla, what are we planning here?
So like since this is a both clinical and radiologically axilla, so ideally this patient qualifies for sentinel lymph node biopsy, and subsequently based on the outcome of the sentinel lymph node, we can decide on the ALND or simple observation. Simply doing observation without SLNB is still not proven. Trials are there, like a sound trial, which recruited a very limited number of type of patient, T1 disease with a very good biology. But to trust those kind of data, we still need a longer follow-up and all. So right now,
So what will be the standard of care, if you ask me, like so?
That right now, if we have to ask terminal or ALND, depending on logistic, this should be the thing. So SLNB should be the standard of care, but if logistic don't support, then ALND should be.
Okay, so a sentinel lymph node biopsy is the current standard of care in early breast cancer, because obviously the morbidity is much lower and local recurrence rates are much lesser actually. So there is no advantage in doing a therapeutic ALND for early breast cancer, but if you don't have the logistics, that's fine. And observation is just put to sensitize you that is also on, there is, I mean, it's absolutely experimental as of now, but we have emerging data saying that in a patient like this, less than 2 centimeter, hormone positive, node negative, you can just observe also without doing anything. But it's a very small cohort, but data is quite promising. But the current standard is SLNB. So if you do SLNB, what is the preferred technique of SLNB?
So like we have three options. Either we can do technetium, labeled colloid, or supravital dye, or ICG. But the standard of care is we have to use at least two things to keep the false anti-rate low. But still, like there are studies from good centers like CMC Vellore and PGI, which says even with a single dye, the results are good enough. But still, most of the guidance suggests two dyes to be used to achieve a acceptable false negative rate of less than 10%. So if you have logistic support, well and good. Otherwise, single dye also Indian centers are practicing and they are happy. But you have to choose depending on the data and counsel yourself and the patient accordingly.
Okay, so broadly three modalities are there: immunofluorescence, that is ICG, gamma, radio guided. Other thing is the supravital dye, blue dye. You are supposed to choose any two out of three. Single is also acceptable, but that is not the standard of care. Dual is the standard of care. But if you don't have anything, ALND is an acceptable option. If you don't have anything. Okay, so if we go for BCS, so I'll just ask you about what should you do about margin assessment. Can you answer the third point alone, Dr. Ankit, in the interest of time? Like so.
Margin assessment, either we can go with the radiologist assistant. We can send the sample for mammogram. If the tumor is visible on mammogram, then the good enough margin of the tumor around the visible tumor can give you an idea like you are safe to go ahead and wait for the final histopathology report. Or you can do the USG yourself or take the help of the radiologist. If on USG also it is visible, then also it's good enough. Or the third thing is going for the frozen, which again it has a very high false negative rate. So it all depends how the patient is being informed, and negative positive margin also should be taken as like a normal complication to take for any surgery, not something out of the blue.
Yeah, what we wanted to highlight was whenever we do breast conservation, there is something called intraoperative margin assessment. You have to use some of the other tool which is available to you. The gold standard, actually there is no gold standard. The most common used thing is frozen section, if it is available. The other options are ultrasound also. We can do an ultrasound to assess the margins. If the specimen has got calcifications, we can do a specimen mammo also. Basically, you can use radiology as well as pathology to assess the margin, but it is a must to do intraoperative margin assessment whenever you do a breast conservation surgery. Dr. Ankit, can you walk through this surgery? This patient underwent a single incision breast conservation surgery, meaning like through the same incision, we did the lumpectomy as well as the axillary dissection. So can you explain this?
This is the 10-second incision, sir. It covers all the basic principles for oncoplasty. The oncoplasty, the first thing is onco. So you have to do a wide local excision with a 1 centimeter margin all around. The incision extend to the axillary fold, so you can access the axilla from there. And after the closure, for closure, you have to mobilize the breast tissue of the pectoralis so that the closure is tension free.
But once you do that, the scar tissue will pull the nipple laterally, especially after radiotherapy, the pull and fibrosis will move. So you have to lateralize or medialize depending on where the insulin. In nutshell, you have to centralize the nipple. Centralize the nipple means scar is going to pull the nipple later, so put it more medial as compared to its current position. Post-op, it will come to the normal position after radiotherapy and all. So for that, we make a concentric ring around the alveolar, de-epithelize and close it. The concentric circle is actually a oval. It is more broader where you want nipple to go. Okay, and the rest thing is tension-free closure. So ultimately, it will be a single scar seen to the patient. And as I said, final histopathology report is the next thing we have to do.
Okay, so this patient, as he has explained, through the same incision, we have done the axilla as well as the removal of primary. And if we close this, the nipple is likely to get pulled towards the axilla. So that's why there is a de-epithelialization happening here to keep the nipple in position. So this is one of the basic principles of oncoplasty. Whenever you do a BCS, you have to decentralize the, I mean, not whenever you anticipate a shift of nipple, you are supposed to reposition the nipple. Okay. So, from radiation point of view, can you tell us more about tumor localization? How to help us helps in radiation planning?
Positive, there is no answer very clear. Apart from that, will be the aging but the practice is one section. So the residency, there should be no confusion. And the second part is about the localization. The gold standard localize in bed, because when we have to radiate apart from focus radiation, bed radiation is also done. So in the bed radiation, the gold standard room one is by the clips or being placed in such. So when we see a patient of insulin mass, when we say a clip placed like 8 centimeter size, it is smaller and local, then it will be a challenge to consider the placement. So as said here, the placement of the clip placement is very difficult when you decide that. Also, we visualize the tumor nowadays with three-dimensional, not on a single, meaning there is a anterior, posterior, medial, lateral, and we need to do the depth also. The tumor might be superficial or at the mid level, but if the clip is placed at the pectoral facial level, then we have to go to that side, because as of now, the gold standard to follow for the tumor margin negativity is desired by the clip margin. There are various methods are there, like if the clips are not placed, but clips is not never a replacement for other methods. It is a must. If you are practicing BCS, then clips has to be placed on the tumor bed. If in some circumstances we do cases, such cases like in our tumor board, so there we might take a surgery CT image available. Also, to get the depth of the tumor, we inject the radio diagnosis free for the mammogram wise, what is the depth of the tumor. Then the grossly missed site where to localize a tumor will be the surgical scar. So surgical scar, and there are studies have proven that there is a least indicator for the tumor site. So going by the surgical scar, you cannot localize a tumor. So that's only a clinical possibility. But the agency doesn't indicate the tumor bed. The only tool to indicate the tumor bed, the patient has to receive confirmed treatment such as radiation is by the clips. If you are planning for BCS, be ready to place a clip also.
Yeah, when we place clips, it's the conventional hemostatic clips, Liga clips. That's what is used actually. But you have to understand that when we do BCS, BCS is always BCS plus RT. BCS minus clips plus RT is one of the disastrous complications you can ever have. It's sometimes it does get missed, like, so it's something you should be in your checklist whenever you do BCS. Margin assessment is there, and clip is also essential. Without clips, there is RT planning. It's extremely complicated. I will skip the IORT part, sir. I'll just run through the post-op biopsy in short of time.
Okay, so this sir has already covered. What do we mean by a negative margin? So there is no concept of millimeters, centimeters here. There should be no ink on tumor. When the pathologist applies ink on the surface of the tumor and when he cuts through it, there should not be, the tumor should not be touching the specimen. That's what there is. Earlier we had 2 mm, 5 mm, all that. So broadly speaking, so there should be no ink on tumor for the invasive component and 2 mm margins for the DCS component. That is also essential because this patient had a DCS component also. So the pathologist should report the separate margins for the DCS component also. This was a biopsy. It was a 2.4 into 1.5 centimeter unifocal. It was invasive breast cancer, grade 5. Grade 1, score 5. DCS component was also there. All margins were reported free. Notes were 0 out of 15. In the post-op biopsy, we got ERPR positive and it was K16 was 20 and it was F2 negative. So the final stages, pathologically it is T2, smallish T2 types, 2.3 centimeter tumor, node negative, non-metastatic, hormone positive. Prashant sir, what is your take on adjuvant treatment for this patient?
Look, the post-menopausal early breast cancer surgery done, and it's a strongly hormone positive tumor. And go to that pathology slide. Yeah, yes. So the decision on adjuvant therapy in breast cancer depends on the hormonal status. That's the first thing that we see. We also pay attention to the KH1 and the HER2 status. So here it is clearly HER2 negative, so we won't discuss further about that. What is the importance of the KH on this? Why? What is that 14% cutoff? So when we look at the biology of breast cancer, we say when the KH is less than 14%, it confirms it is similar to a type A tumor, luminal type A tumor. More than 14%, it can be considered a luminal type B tumor, which is slightly more aggressive than a luminal type A tumor. So this is all factors which play into our mind when we take the decision on whether to give chemotherapy or only hormone therapy. Having said that, all these are kind of surrogate markers, sort of a full genetic profiling. We can never be completely sure whether a patient would actually benefit from chemotherapy or not. So before all these genomic assays became available, now also because these assays are very expensive. So we, in a situation like this, there are some online tools available where you can feed in all this information, and that will tell you how much benefit is expected from chemotherapy, how much benefit is expected from hormone therapy. So without a doubt, in any patient with hormone positive breast cancer, we are going to give hormone therapy. There is no question about it. Hormone therapy adjuvant is always given in hormone positive breast cancer. So that is already given, and that gives the major part of the benefit of prevention of recurrence. What we want is prevention of recurrence of the tumor. The bulk of the benefit, whatever you are going to get from systemic therapy, is going to come from the hormone therapy component. Whether over and above that, there's going to be additional benefit of chemotherapy, is what you are going to see here. So if you put this into traditional models, you will say that chemotherapy will have additional 2% benefit or something like that. That was only you will get in a tumor like this. Whether for that 2% benefit you want to subject this person to chemotherapy, as usual in any decision making in oncology, it's the decision of this person's benefit. So the chemotherapy here is going to be 4 cycles of some form of chemotherapy. So your question here is whether 4 cycles, how much of risk it is for whatever little bit of benefit is going to give. So you have to look at the performance status of the patient, the age of the patient, the willingness of the patient, and all this. Generally, a 57-year-old fit patient is not considered as an old patient by any means. And it is otherwise well, we would advise them to take 4 cycles of chemotherapy because 4 cycles of chemotherapy does not constitute a too high a risk in our mind. So if you're not able to go into genomic assays, in this patient, I would probably just give 4 cycles of chemotherapy followed by hormone therapy. For whatever little bit benefit of 2% or 3%, I'll just go and give it. If the patient is not keen or very strongly against chemotherapy for any reason, I'm okay to leave it also. So that is how we would look at it. Because the risk here is very low. The benefit of chemotherapy is marginal. So that's how we have to take the decision. It's a bit nuanced and complicated. But this is how it is. But same patient, if she is 80-year-old, again the risk will go up of the chemotherapy. It's not like 80-year-old should not give, but the risks are higher. So you may take a decision that here the risk of benefit is not matching. So you may do only hormone therapy in that case. So that's how the decision is. Now here is the report of genomic testing. So now in the last decade or so, there are many genomic tests which have been developed, where the tumor tissue can be tested for certain biological markers. And based on that, you can more precisely predict how much benefit you will get from additional chemotherapy. So one of these is this oncotype DX, which is the most popular and most well validated book. So if you do the oncotype DX and you get a score of less than 10, then they are unlikely to benefit from chemotherapy. The risk of recurrence is very, very low only with hormone therapy. So you can see the risk of recurrence is only 3% with adjuvant hormone therapy. So this kind of score is available from that. So you would consider that already 97% of them are going to be recurrence free. How much more is chemotherapy going to add in that situation? So you can safely avoid chemotherapy if the recurrence risk score is less than 10, definitely. But there is also data in post-menopausal women. If the recurrence score is less than 25, also you can avoid giving chemotherapy with no negative and all those things. But in a pre-menopausal woman, the recurrence score, only if it is less than 10, you will avoid chemotherapy. If anything more than 10, you would still give chemotherapy. So this is how the decision making goes.
Okay.
Yeah.
We are running short of time. We have 5 minutes to go. To sum up what Sir has said, in an early breast cancer in a postmenopausal setting, there are two broad options. One option is the default option for most of us, which is giving adjuvant chemotherapy. Any tumor more than 1 centimeter gets adjuvant chemotherapy, 4 cycles of AC. Whereas if the patient can afford testing, oncotype DX, fortunately this patient was able to afford, but this costs around 2.5 lakhs, sir, like so.
Yeah. Cost of testing is about 2.5 lakhs. The cost of chemotherapy is only 20,000. That's another factor.
Yeah.
So just give the chemotherapy and forget about 22.5 lakhs.
But if you do that, and if you found out, the thing is, even if you do the testing, you may realize that your recurrence score is high and you may end up in chemo. You need an understanding patient for this. The patient has to understand that this money is not spent to avoid chemo. This is to know their risk. Fortunately for her risk came low, so we could spare her of chemo. So her absolute benefit of chemo is only less than 1% according to this. So we didn't give her any chemotherapy actually. Can you explain us about these terms, sir? Like
So we mentioned radiation will be a part of the breast conservation. So here there are two types of radiation is like generally practiced is by whole breast radiation and followed by regular blood juice. The other means under this patient also will qualify for partial breast radiation, meaning instead of treating the entire involved breast, only the involved cavity surrounding margin taking around the 2 centimeter margin will be allowed radiated. So the way how the partial breast radiation will be given either by brachytherapy, which is well established, other is by external radiation, whether externally or intraoperatively. And third, that is using X-ray based or by using proton electrodes. So all three modalities are now being practiced. But the most common modality among all PPIs, which is well established by using interstitial brachytherapy for partial resistance. So here we'll be giving a very high dose of around 35 grade, then 10 fractions, giving morning and evening dose will be given. So total of 5 days within a week, the entire treatment will be completed for partial resistance. So there is no question for observation here. So patient will be receiving radiation for this particular treatment. About
say what about role of boost, sir, for us like so.
Yeah. So about the boost, also here for in general practice here we will be giving boost radiation for majority of the patients who undergo full breast radiation also. But the evidence says that for a low risk category, especially for her with no nodal involvement and provided the age is bigger means it's an indicator for pregnancy. As for breast is concerned, 8 or more is not what we think it is usually say 60 or 50 years. So this is that they come under high risk category. So those group will be easily bedrooms radiation. Addition to that, which is not there in this patient, is the presence of extensive intracranial component. So if it is ECS is present, more than 25% with high grade under younger age group will receive bedrooms. For otherwise, this patient will not, therefore is not, there will not be. And with oncoplastic surgery, RP planning is quite challenging because the anatomy will be different when we do a simple laparoscopy for radiation or when we do oncoplastic surgery. So there, only guidance for us will be the clips. Again, I reiterate, so the clip, that will not be disoriented. That will be in the similar position where the human bed was broken. So clips in PCS play a very vital role when radiation comes in.
Okay. To sum up, when you do oncoplasty, you need a radiation oncologist who understands oncoplasty. Otherwise, your planning is going to go haywire. Okay. And as I said, you have both options available now: whole breast irradiation as well as accelerated partial breast irradiation. Even though it has not become standard of care in early breast cancer, everything is moving towards de-escalation. We are doing less and less in compared to more and more. Like I would summarize the hormonal therapy for the interest of time, sir. Okay. So this lady is postmenopausal. So the choices between tamoxifen and AIs in a postmenopausal woman, we give aromatase inhibitors, which is usually letrozole. The key is definition of postmenopausal, whom we call postmenopausal. Age more than 60 is postmenopausal straight away. Anybody who has undergone bilateral oophorectomy is postmenopausal straight away. Or anybody who has got chemo, then it becomes difficult to define the menopause status. So then you have to do hormonal assessment and then take a call. So you need to understand that sometimes defining menopausal status can be a complex thing in these patients. If it is defined and clear, then we give 5 years of letrozole as a standard therapy. We also give adjuvant bisphosphonates with them. The role of CD4 inhibitors is, as of now, not proven in early breast cancer. And follow-up, to summarize in one line, it is only clinical follow-up essentially with only annual mammograms. There is no need to do any other routine imaging unless it is triggered by a symptom. I thank the panelists for their participation and the delegates for patient. Thank you.
Thank you, sir, ma'am, for the informative and comprehensive panel discussion. I now request Professor Suresh Kumar, the organizing secretary of the event, to felicitate the moderator, Dr. Gomti Shankar D. And the panelists, Dr. Sunita VC, Dr. Prashant Benyamin,
I don't should be prepared. We only control the
Dr. Gulfidan K. And Dr. Ankit J. Thank you, sir and ma'am. Now we shall take break for tea. The tea is served on the same floor. Let's all meet and meet in 15 minutes. Around 5 p.m. We have a short announcement to make. 6 candidates have been chosen from the 6 posters that will be presented today in the candidate case reports. They've been chosen for the final presentation tomorrow. I'll be reading out the candidates' names. Girishan Rao Subramanian, Dr. Surya K, Dr. Manish Kulshrestha, Dr. Parth Maheshwari, Dr. Drita Sahu, and Dr. Sai Ganesh. I'll repeat the names. The chosen candidates, 6 candidates in the candidate case report, will be presenting in the final presentation tomorrow. Dr. Girishan Rao Subramanian, Dr. Surya K, Dr. Manish Kulshrestha, Dr. Parth Maheshwari, Dr. Drita Sahu, and Dr. Sai Ganesh.
They're not, other, they're job. It's very. Thank you.
Short announcement. Six posters in the category of case reports have been selected for the final presentation tomorrow. The chosen candidates are Dr. Dilshan Nao Subramanian, Dr. Surya K, Dr. Manish Kulshrestha, Dr. Parth Maheshwari, Dr. Dritta, and Dr. Sai Ganesh. continue with the rest of the program. Now we have a case presentation on professional sarcoma by Dr. Sanjay and Dr. Yoshida, postgraduate 5-year students from Venkateshwara College. They're presenting on soft tissue carcinoma. I welcome the examiner for the session onto the dais, Dr. Jagdish S., Dr. Selvakumar K., and Dr. Balmurugan P.
Good evening, everyone. I'm Dr. Yoshida, and this is Dr. Sanjay from Venkateshwara Medical College, final year postgraduate students, here to present a soft tissue sarcoma case. So a 54-year-old male who's a bakery shop owner from Kalakurchi, belonging to upper middle class socioeconomic class, came to the OPD with the complaints of swelling in the inner aspect of right thigh for the past 8 months. History of presenting illness. The patient was apparently normal 8 months back, after which he developed a swelling in the upper medial compartment of the thigh, which was insidious in all.
Don't use scientific terms here. Compartment and all should not be mentioned, and you mention history in a surgical case. Mention upper part of the thigh. Compartment all is what we find on investigation or treatment. So when you are presenting history, just say upper part, lower part, don't say compartment. The compartment is a later on development. Understand?
Upper part of the right thigh, which was insidious in onset, slowly progressive, and the swelling was initially small in size and attained the current size with a rapid increase in size for the past 1 month. And it was associated with dull aching pain over the swelling, which was also insidious in onset, gradually progressive, no movement of pain, no aggravating or relieving factors, and not associated with features. So history of skin changes present over the swelling for the past 1 month.
I don't understand this. What are you trying to say? Skin changes, what do you find? Skin changes in skin on examination. What will the patient complain of? Patient will not say, I am not having skin changes.
So the patient.
I don't understand this particular.
The patient.
What you are trying to say.
So the patient initially he told the 8 months back he had only the swelling, sir. For the last 1 month only he had that.
If there is ulceration or something, the patient himself will mention. But in the history, no skin change doesn't mean anything. Is that clear?
Yes, sir.
Yes, sir.
On examining different thing. Patient will not tell you, I don't have skin changes. If he had skin change, he will mention, you will find it out. So this is redundant, isn't it? You don't have to say patient does not have it, does not say anything. He won't tell, he is not a doctor. Okay, yes.
History of heaviness of limb present for the past 1 month. No history of gangrenous changes.
Again, how will he know gangrene? Does patient know, he is a doctor, he will know what is gangrene? So don't say no is a gangrenous changes in a history of a patient. Gangrenous changes can be found on your examination or on investigation. Patient will not come and tell you, I don't have any gangrene in the leg. Will he tell you?
No.
So again, if you want to say no is a color change, that is better. But no is a gangrenous changes in foot and all that, this particular term should be avoided. In the history presentation. Do you understand?
Yes, sir.
Okay.
No history of any color changes in the foot or numbness in the thigh, foot.
Again, foot drop. Go back. Now, why should you mention foot drop? Foot drop you might find on examination. Patient will not tell you, I don't have foot drop. Isn't it? I hope you are understanding what I'm trying to say.
Yes.
Must tell you exactly what patient told you. Yes.
I is focusing on only the history of person plus you have to elaborate the history. So you are not put any scientific terms into the history of person. That's all.
No history of fever with rigor or presence of any other swelling elsewhere. No history of difficulty in squatting or walking. No history of loss of weight and loss of appetite. And no history of radiation exposure. No history of chemical exposure, no history of trauma, no history of swelling elsewhere in the body, no history.
Mentioned this earlier.
No history of cough, hemoptysis, mass per abdomen, bone pain, headache, or seizures. Past history, patient is not a known case of diabetes mellitus, hypertension, bronchial asthma.
So why did you ask about this last minute? History of cough, hemoptysis, heart problem?
For metastatic history, sir.
So metastasis patients come with all these symptoms. Cancer patients who are metastasis, what's the common presentation? Most of the time it is found incidentally on taking a chest X-ray. If they do get symptoms, more often they get pleural effusion. Very unusual for a patient with metastasis to come with hemoptysis, etc. Understand?
Yes.
Mass per abdomen also, but that I may prefer to accept. But these are all, frankly, as Darren is saying, they are not important. It's waste of time. If it is there, you mention. If it's not, doesn't mean there are no metastasis.
Yes.
So in your history, what is important is shortness. So these are all redundant now.
Okay.
All this chemical exposure and all this, there's no history of trauma and all these are not necessary. If it is there, yes. Not there, it's not of any importance. Because the part of the cases in short case in your exam. So in short case, salient positive history and saliently negative history, then straight away you can go to the local exams. Only for general examination. This examination.
No history of similar complaints and treatment for any swelling in the past, and history of open mesh repair for umbilical hernia 20 years back.
Umbilical hernia, not inguinal hernia. Yes. Okay, done.
No history of any steroids, insulin, analgesics intake.
Why particularly asked about this? Go back. Any particular reason why you mention all this?
Any loose drug intake, sir.
Precancers or anything, why you mention all this? If it is there, important, then you mention. Just take the monitor. If you have any drug which you think is responsible, mention it. But no history of steroids, it doesn't. A lot of unnecessary time you are wasting in servicing. Exam, short case 10 minutes, exam will start 15, 20 minutes. So relevant detail important. Yes. Whatever is you have to substantiate. So whatever you have to learn. Explain. So others don't ask.
No history of allergic to any medications or food. Personal history. Patient consumes mixed.
What next? Anything significant will let me know. Go next.
So summary, a 54-year-old obese male who's a bakery shop owner from Kallakurichi belonging to upper middle class socioeconomic class came to the OPD with the complaints of swelling in the inner aspect of the right thigh for the past 8 months, which has rapid increase in size for the past 1 month, and history of discoloration present over the swelling.
Earlier you said no skin changes. Now you see history of skin changes.
History of skin changes is present.
Yes. Then you should mention what skin change. Yes.
Discoloration over the swelling for the past 1 month, with a heaviness in the right lower limb for the past 1 month, and history of swelling of the bilateral lower limb.
Coming to the general.
Somebody wants to read first. I'm swelling for 8 months. The last 1 month I having rapid increase in size. What's in your mind?
Malignant transformation. Rapid increase in the size.
So some benign swelling may transform into the ailment phase. Because I will having quite long history of ailment.
On coming to the general physical examination, after informed consent, patient was examined in a well-lit room with adequate privacy. Patient was conscious, oriented, afebrile, hydration fair, well-built and well-nourished. Carnot score was 90. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or capivalar spots in the body.
Specifically, capivalar spots.
For
I can look for it.
neurofibromatosis one, sir. For von Reckling
The
disease.
predisposing factors for.
Does it have generalized neurofibromatosis?
Yes.
What is capivalar spot? What is it due to?
Pigmented skin lesions. Pigmented skin.
FA spots, what's the importance in neurological tumor? Why are we looking for it in a patient with neurodermatosis? What is the critical basis?
For one in a one Reckling disease.
I'm not asked. Since you have mentioned, I'm asking you.
For in case of one Reckling disease, it is one of the diagnostic.
Why does it occur? Why do you need cataral spots in neurofibromas? Mechanism of formation of
Pigmentation which is happening in the skin. So because of
those
that.
melanomas, they are also part of that this thing, no?
Because of melanin formation.
Process. They are all nerve endings. So they are nothing. So because of their changes in the neural the changes in neural tissue, that's why you get various pigmentation there. But it is not a very great important in this patient. The patient with one lymphoma disease, they got so many other things. So it has no relevance in this patient, in my opinion. Yes.
And pitting pedal edema was present in bilateral lower limb extending till the knee joint. And his BMI was 42.1 kilogram per meter square. Pulse rate was 83 beats per minute in right radial artery, regular, normal volume and character, normal vesicle thickness, and no radioradial delay. Sorry.
RRD.
Radioradial delay and radiofemoral delay.
Please don't use abbreviations which are not. So for old people, like we don't know abbreviations. It's not important here also. In this patient, radioradial delay is not important because it's not a vascular case. So don't mention things which are not necessary, especially the abbreviations.
Yes.
Okay. Yes.
And
things will lead to later discussion.
BP was 130/80 in the left arms in supine position. SpO2 was 99% on room air. Respiratory rate was 16 breaths per minute, abdominothoracic type. So the swelling. After verbal consent, patient was examined in standing position with adequate exposure from the umbilicus to bilateral lower limbs. Examination of the left lower limb is normal except for the presence of dilated veins in the medial and lateral aspect of leg and the medial aspect of the distal thigh. On examining the right lower limb, attitude was slightly external rotated, abducted at the level of hip joint and full extension of knee and ankle joint in neutral position. No limb length discrepancies or deformities, no muscle wasting and distal neurological deficits. A single swelling of size 30 cross 25 cross 20 centimeters, pedunculated swelling present in the upper medial aspect of right thigh, extending 4 centimeters below the inguinal ligament as the upper margin and 20 centimeters above the medial femoral condyle as lower margin. Smooth surface, well-defined margins, no sinus, purely orange appearance present over the skin.
Your fixed state, Pondicherry.
Yes, sir.
When Pondicherry or Tamil Nadu?
Pondicherry, sir.
Pondicherry, it's a purely orange, it is a crime. It's peau d'orange. It's a French term. It's orange peel. Don't say purely orange when you are in France in Pondicherry. Peau d'orange. Orange peel appeal. What does orange peel appearance mean?
It's because of the subdermal lymphatic obstruction.
Lymphedema.
So don't say purely orange, say peau d'orange.
And there is no visible pulsation over the swelling. And on palpation, all the inspectory findings.
Please slow down. Don't rush. Why is specifically mentioning about sinus?
There's no.
Just say no skin changes.
No skin changes.
You said pigmentation is there. You are not mentioning pigmentation here. If the patient complained of
Skin
change in color, but have you seen change in color here?
No, sir.
You mentioned in it.
Skin changes.
Change of color. I don't see that being mentioned in the examination. So what
So patient was complaining. No, sir. Patient was complaining of the multiple pits which were present in the swelling, sir. He told like that. Multiple
pits, blackish colored pits.
Pit-like appearance in the swelling, sir. That was the exact word which he was saying in Tamil.
Whatever he complained, it look for it here.
Yes.
I don't think so. You didn't find anything. Then if you didn't find, why did you mention it at all? Okay, continue.
All inspectory findings were confirmed by palpation. Warmth present.
Inspector's findings,
Inspectory findings.
these are all you spend some time, you must correct these spellings. Inspection findings, yes.
And warmth was present, no tenderness. A single swelling of size 28 cross 24 cross 18 centimeters, pedunculated, present in the upper medial aspect of right thigh, extending 4 centimeters below and lateral to the pubic tubercle as upper margin and 30 centimeters.
So fast. You have to catch a train or something, or you have got another place and give a lecture or something. Please slow down.
Yes.
At least I am very old. I cannot by the when you are talking about support and things like that. So slow down, take your own time, don't be in a hurry. That is because you are reading. Please go slowly so that audience, I hope audience also agree with me. Please slow down. Exam also don't rush. Take your own time.
Yes.
And 30 centimeters.
Palpation, what to mention the first, after the generally what to mention about the
And 30 centimeter above the medial femoral condyle has lower margin, and it was smooth surface, well-defined margins. No sinus, no.
Palpation, smooth surface is not enough. What else? Somebody else earlier also mentioned that in inspection you can just smooth or irregular. Palpation, what should you say? Something smooth and irregular is not. There are some other terms inspired. What are the terms?
Nodular surface.
Lobular, nodular, vacillated. What is this like? Is it nodular? Is it lobular? Is it vacillated? What is this?
Vacillated surface, sir. Vacillated surface.
Smooth only.
Smooth surface.
There is no irregular. I have not seen the patient, so I cannot question you, but you are saying it's smooth.
Yes, sir.
Smooth surface.
Regular surface.
Nodular surface. The variable consistency, well-defined.
It's neutral for a consistency label to have smooth surface. Both
Sir,
cannot
the
coexist.
proximal part of the swelling was
Very little experience. You cannot have a smooth surface and variable consistency. Okay, yes.
this proximal part of the swelling was soft, sir, and the distal part was firm. Softer firm, sir. Softer firm, sir.
Very soft, very firm.
In the proximal aspect of the swelling, it was soft, and in the distal aspect of the swelling, it was firm, sir.
Continue.
And swelling becomes prominent on contracting the underlying muscles in the subcutaneous plane.
Even the swelling is subcutaneous plane.
Yes, sir.
How do you assess the plane of the swelling? You have just mentioned, but you are not mentioned. Prominence is not enough.
So ask the patient to
How do you find out the swelling is subcutaneous?
ask the patient to lie down, supine position.
Plane muscle is there here.
So
Here the medial compartment.
The medial compartment
The
of
medial compartment of thigh will.
What muscle specifically tell me what muscle?
gracilis, pectineus, adductor longus.
Adductor longus.
This part of the thigh, what are the muscles you tell me?
Adductor longus.
Adductor longus there.
Adductor magnus.
So how do you put
Adductor
them the contraction? How do you put adductor longus, adductor magnus contraction?
By
Adducted.
adducting the thigh, sir.
So did you put that?
Yes, sir. Patient was asked to lie down in the
Now-
position and then.
You did that. Now
Yes.
tell me, how do you know it is not fixed to the adductor longus or brevis?
So we also palpated the contracted muscles, sir.
First we must test the mobility first.
Mobility.
Test the mobility
Mobi-
first.
Yes, sir.
You didn't mention it earlier. Where in this part of swelling to test mobility? In
The
this
ba-
portion of swelling it has mobility.
The proximal part of the swelling, sir.
The base of the swelling.
No, and then when you put the muscle into contraction, the mobility is restricted, then it's fixed to the muscle. Not restricted, it's not. fixed to the
Not
muscle.
restricted.
Here prominence is not enough. Become prominent and contracting alone is not enough at a PG level. You must be able to say whether the mobility is restricted, putting underlying muscle into contraction. That you have not told so far. And you said it is in subcutaneous plane.
Mobile in all four directions, sir.
So it is mobile to start with, but doesn't mobility not restricted, putting underlying muscle in contraction, what you should say. Okay, fine.
Skin was pinchable. Skin over the swelling showed purely orange appearance. No dilated veins over the swelling.
Purely orange.
Posh.
Both orange.
Both orange.
You cannot straighten a dog's tail, no? Indeed, take it down, you can't straighten.
And no palpable pulsation over the swelling, and it was not compressible.
So go there. Why are you in a hurry? Let me see what your skin or swelling shows QD orange appearance, no dilated, no palpable pulsation. So any other reason, and why did it test for compressibility?
So in case of vascular tumor,
Vascular tumors are compressible?
might be.
What is compressible? Go to undergraduate basics. Which swelling is compressible?
Hemangioma is
Hemangiomas.
compressible.
Hemangioma,
It's compressible.
Athena's fistula. Vascular tumors are not compressible. They are vascular, they are not compressible. So I think why I'm telling you all this is exam as far as saying lower tangents. Some bad examiner like this comes, he'll take it to one side and drown you. So don't mention things which have no basics here. Understand? So no dilated veins and no one needs to mention compressibility if it is a tumor link. That is the only thing is hemangioma. Okay, yes. Continue.
On measurements of lower limbs, normal measurements of right lower limb and left lower limb with no muscle wasting. Measurement of the right and left lower
Again,
limbs.
this are no use. Next.
Now, auscultation.
Finish the exam, please.
No range of movement restriction at right.
Apart from what swelling is, have you seen anything else?
Yes, sir.
What else are examined?
The gait of the patient was examined, the arterial system was examined, and the sensory system and motor system was examined. Reflexes, lymph nodes, regional examination we have done.
You have mentioned so many other things, lymph lines you are mentioning and something, but you're not about mentioning lymph node. That is more.
Yes.
It is exam for lymph node.
Yes, sir.
Yes, sir.
This is coming later. This is part of the examination. It's not separate slot. When you mentioning the swelling in the thigh, immediately the first thing strikes to me the lymph node. Yes.
A lymph node of size 2 × 1 centimeter present in a vertical group of right ring 1 lymph node group, oval shaped, smooth surface, firm in consistency, mobile, no warmth or non-tender, no perinodal interaction, and normal skin over the swelling. No palpable lymph nodes in the left inguinal region.
Yes.
On systemic examination, normal vascular bed sounds, no added sounds, no focal neurological deficit. No focal neurological deficits.
TNS, NN20, NBEAS, LBDS. How much energy you have saved by doing the abbreviation? So till you pass your exam, don't use the abbreviation. Even after don't use. So our main aim is to please the examiner. The discussion goes around. Please don't use abbreviation. Please the examiner. Please don't use abbreviation.
Yes, sir.
Especially old people like you don't know anything. Forgotten abbreviations. So use only whatever is really what they call continue.
And per abdomen examination, soft, non-tender, not distended, umbilicus averted, no organomegaly.
Skull and spine specifically. Why you mention skull and spine normal? What is special about skull and spine?
So in case
Why have you mentioned it here? Skull and spine specifically, why you have mentioned it here? What do you want to know?
any bony metastasis.
You will get bony metastasis from soft tissue tumors.
Sir,
Again, this is all transient. Then you said soft, non-tender, non-umbilicus averted, no organomegaly, no fluid bust. Yes.
and left supraclavicular fossa normal, rectal examination.
PR. Now, first follow is after the house we have done PR for him. What do you expect to see in PR in this patient?
For completion sake, we did.
Completion sake.
Now, why did you do PR in this patient? Have you done?
Yes, sir.
Why did you do it? Give me a reason why you did a PR for this patient. You have to explain to the patient, now why you have been PR. Can you give me a reason? I am prepared to accept.
So for completion sake, for completion sake, we have to do. Sir.
So here is more relevant than what is the trend. Level swelling in the thigh. Then you've got a node there in the equinal region. So what will be more relevant than your PR examination? If the equinal node is involved, what is the next node which can be involved? Something that is involved node.
Iliac nodes, and pelvic nodes.
Why do you need to look for this patient? One is equinal node is involved. Other thing you only do is by lymphedema is there, no?
Yes.
Both there is edema, pedal edema, and also you said there is swelling of the lymphedema, local lymphedema. So you need to look for this nodes at the iliac region also really important there. How do you look for? How do you look for iliac nodes? In what position? Cardiac artery and which position you look for iliac nodes? Okay, you look for it when you keep extended position. You cannot flex to around the equinal ligament or laterally you look and to palpate for the region. Okay. Yeah.
When examining the external genitalia, penis phimosis was present, bilateral testis palpable, meatus was not visualized, and scrotum was normal. In summarizing the patient, 54-year-old obese male who is a bakery shop owner from Kallakurichi belonging to upper middle class socioeconomic scale came to the OPD with the complaints of swelling in the inner aspect of right thigh for last 8 months, which has a rapid increase in size for the last 1 month. On examination, had a pedunculated variable consistency swelling of size 28 × 24 × 18 centimeter with a smooth surface in the upper middle compartment of right thigh with pudor. Beauty orange appearance and one mobile vertical 2 × 1 centimeters inguinal lymph node with smooth surface, firm in consistency. Probably a case of soft tissue sarcoma in the right medial compartment of thigh with no neurovascular deficit.
No, you would like to change the diagnosis.
Yes, sir.
You said medial compartment of the thigh. What is the medial compartment of the thigh? What do you understand by the medial compartment of the thigh? What are the contents of medial compartment of the thigh?
Yes, sir. But the
We
various
have,
muscles
muscles
include
and
3 layers of muscles. One
Typically, where did you see the plane of the swelling was?
in the subcutaneous planes.
So how can subcutaneous swelling be in the compartment? Compartment is below the fascia. When you say compartment of a particular part, it is below the fascia, it contains muscles and contains vessels. You clearly said it is subcutaneous swelling.
Right.
How can a subcutaneous swelling be part of compartment? Don't you think so?
Yes.
Do you agree or not agree?
Yes, sir.
Yes, sir.
So you should not use the word compartment. It's not like compartment. It's a soft tissue malignancy affecting at what the subcutaneous level.
Right.
That is what. So if it is subcutaneous level soft tissue, what is the most likely histopathological diagnosis? In this situation that you have
Lipoma.
described.
Lipoma, liposarcoma.
Lipomas. This is soft tissue sarcoma. Lipoma is not a sarcoma.
Liposarcoma, sir.
Liposarcoma. How common liposarcoma in this situation?
The
What is
site,
commonest site of liposarcoma?
thigh, sir.
Thigh region.
Upper medial compartment.
What
Upper
is the
me-
commonest site of liposarcoma? Retroperitoneum.
Retroperitoneum.
Here you get more other soft tissue. So it's not necessary to the histopathology. Soft tissue sarcoma is acceptable. It's a plain in the soft tissue. Any other differential diagnosis?
So it might be a pedunculated lipoma. Pedunculated
Lipoma. Okay, accepted this.
and
Pedunculated
arborescence, lipoma
lipoma arborescens.
and pedunculated papilloma.
Papilloma is this is a papilloma. Papilloma is skin tumor. It's not subcutaneous. Papilloma is not subcutaneous. Yes.
And pedunculated hematoma.
Pedunculated hematoma. What is the hematoma? What is the concept of hematoma? What do you mean by hematoma?
Tumor with this indigenous origin.
Hematoma is tumor. And what is the solar age?
Sorry,
How old is it?
54, sir. 54, sir.
Before we get hematomas. Any other possibility?
Plexiform neurofibroma.
Plexiform neurofibroma. Is it you said skin is free? You mentioned in your clinical exam skin is free. Does plexiform skin will be free? The skin problem. But even in a I can accept it, but we can rule it out by saying skin is not involved.
Pachydermatocele. Dermatocele. And soft tissue sarcoma, it might be a pseudosarcoma.
Histopathology is not important clinically. Soft tissue, I am prepared to accept it. So we'll accept your diagnosis of soft tissue sarcoma. Now, how will you proceed to investigate this patient?
The patient comes to our OPD, we proceed with USG of the local region.
Why do you want to do ultrasound in this patient? It's going to give you information.
Yes, sir, to
Why
look for
ultrasound? Everybody, you know, the patient you want ultrasound. Why do you want ultrasound? You must do investigation to make you confirm.
We'll proceed with the MRI, magnetic resonance imaging. We'll proceed with the MRI to see the extent.
MRI is the first thing you should do.
To see the extent of the.
No, MRI, what do you look for MRI?
To see the extent of the tumor, to see if there is any neurovascular involvement, if it is there or not.
Particular case, you are specifically the subcutaneous. So what are you looking for in this patient?
Yes, sir.
In MRI, in this patient, what are you looking for in the report?
Any vital structure involvement, sir.
See, it's a subcutaneous. So you must find out whether it is, even though it's clinical subcutaneous, whether invading any deeper structures. Whether involving any muscle. Clinically, it may be thinking tomorrow it's involving the muscle. Or it's infiltrating the muscle. What vital structures will come here?
Since it's in the middle.
Subcutaneous.
Yes, sir.
It is overlying femoral artery.
No, sir.
No. So then, once femoral artery is separate, question of knowledge, if it is below the fascia, then what is the sounds correct? If it's underneath the deep fascia, then it is subcutaneous swelling. So MRI will confirm the fact that it is subcutaneous. Okay, done. It is subcutaneous, not infiltrating structures. Next, what will you do? What other investigation will you do?
Then we'll proceed with core needle biopsy, sir. Core needle biopsy.
Core needle biopsy, yes. Why not FNAC?
Because FNAC will not tell us the grading of the tumor, sir.
Even this study, it can't tell. What is the difference between FNAC and the core needle biopsy?
For IH,
Information you get core needle biopsy, what is the FNAC?
with core needle biopsy, we can also
What
use for
exactly is FNAC, core needle biopsy? How much this is available? And how is the different FNAC?
So we can come to a histopathological diagnosis with yes, sir.
Yes, sir.
What is it contain? That is cylinder tissue.
Yes, sir.
So it will tell you all about the cells and their relationship with vessels and surrounding membranes, which FNAC will not tell you.
Yes, sir.
So true cut biopsy is important. A true cut biopsy says this is a middle stage tumor. Now what will you do for this person? This patient has FNAC, true cut biopsy has been done, come as spindle tumor, spindle stage tumor. What is the other
Then we
reason for what is because what else is
The main histopathological diagnosis
In cell
and also the grading.
differentiation. Cell differentiation and if there is any
Mitotic count.
mitotic grade or tumor necrosis is present or not. Grading of the tumor.
Grade 1, 2, 3. For grading, they use the mitotic count, necrosis score more than 50% or less than 50%. And the mitotic count will be
From 0 to 9.
0 to 9.
From 0 to 9, 10 to 19 and more than 20, sir. And the cell differentiation, sir.
Our management will depend upon the grade, sir.
Grading.
Why you need to find out
Because for the neoadjuvant radiation, if he requires neoadjuvant radiation or not.
Yeah, because grading is in TNM stage.
Yep.
Like other famous grading is part of TNM
TNM
stage.
stage.
That way, management.
So, like to do for the mainstay of treatment, ideal treatment will be a wide local excision.
Metastatic workup, sir.
Yes, you have
So
X-ray chest and the CT chest has to be done for the patient.
CTA.
which will X-ray you do or CT?
CT chest is more advisable, sir.
CT because why CT is that, why not X-ray?
Because even small amount of metastasis can be identified in CT.
More sensitive
Common
than the
most of the lungs.
Lungs.
CT fixer, metastasis better than. But you know there is a lymph node, right?
Yes, sir.
We didn't want to go into what are the
FNAC of the lymph node has to be done.
Sir.
which
First.
sarcomas goes into lymph node?
So
Synovial cell sarcoma, clear cell sarcoma,
Ewing cells are
epidermal sarcoma,
and
Ewing
epithelial
sarcoma,
sarcoma and malignant histiocytosis.
malignant histiocytosis.
Malignant histiocytosis.
What do you want to do?
We'd like to proceed for the secondary lesion, we can proceed with the FNAC of the lymph nodes.
First is imaging, if there is something, only the invalid node is involved. Or maybe other group
From
of-
the MRI, we can find out the
Suspicious of one. Okay, as part of all seats and all of that.
FNAC of the node.
So it was done.
Yes, sir. In this patient, actually, we couldn't do an FNAC, sir. We on excising the lesion itself, we also took out the lymph node also, sir, along with it. The lymph node was over the swelling.
Treatment to approach. If not is involved, what is the treatment supposed to do FNAC? You can't have to get start much, it has a lot. What is the minimum basic treatment?
Yes, sir. Initially, a course of antibiotic has to be given to rule out reactive lymph node and then significant lymph node. Then proceed. I'm radiotherapy here. Black dissection. Yes.
What was the line of management? They already operated, but before after what plan management was planned?
The wide local excision was planned.
What is meant by wide local excision?
It's a function.
What are the
We
various options
plan for a.
available in patient like this? Soft tissue tumor, what are the various options available? Wide local excision, what do you mean by wide local excision?
Up to 5 centimeter margin, if you are having 10 meters of wide local excision.
5 centimeter depth in this patient? With coronary artery also is blocked. These steps first patient, sir.
It's
T4, sir.
sir.
T4.
So less than 5 centimeters, 5 to 10 centimeters, 10 to 15, and more than 15 centimeters is T4.
Don't say 5 centimeters in a depth. Has to be one anatomical plane underneath. 5 centimeters. So you have to can give 2 dimensions can give 5 centimeters. Then you go to depth, you cannot go 5 centimeters. You must go to one anatomical layer. You must remove it with the underlying deep fascia. That is the answer, not 5 centimeters. And once the defect, how do you cover the defect?
We could do a local advancement flap or a free flap can be done.
Local spring cover you could give.
Yes,
Yes, sir.
Now, viral biopsy, what is viral biopsy? That's already probably you know.
Report is awaited, sir.
Suppose it comes as incomplete marking, what we can do? Suppose they say marking of the tumor shows malignancy or.
Then we have to proceed with post-operative radiotherapy, sir.
The radiotherapy a good what do you call modality for soft tissue sarcoma. Excise the mass, it when reported incomplete excise. The radiotherapy could what will you do? Go back and excise some more.
Yes, sir. Resection.
If possible.
Resurgery.
If possible, the other things are there. Okay.
Local region.
Suppose you cannot suppose that the local skin is not available, what do you do? What local you don't local flap is not possible, what else can be done?
Free flap can be given.
Good free flap is not. Okay, I think it's stop.
Thank you.
Thank you so much. I now request the examiners to upload the presentations certificate. Dr. Sanjay. And Dr. Yojika. I now request Dr. Nandakishore to felicitate Dr. Selvakumar K. Short notice. This is the shortlisted candidates for presentation tomorrow. Original articles and case reports. Please note. This will happen in first floor, same building at 2:40 tomorrow. Please note the names. Thank you.
Can we minimize?
Is there yet?
Last C sheet is remaining. Where is it? This one. Extended. Extend and duplicate, what is the difference?
Name display. Name display.
Okay. Where is it named?
Kindly note down the names of people who are selected for oral presentation, both in case reports category and virtual category. Please be prepared and come tomorrow. Tomorrow after the session, you have oral presentations. The 6 selected participants, 6 selected papers in original article category and case report category. They should be ready with the PPT and they should come for oral presentation tomorrow after the session. Thank you. If the selected participants are not here, the friends of them, please note it down and inform them. Thank you.
But now whoever's presented.
It will be updated in WhatsApp group as well. Thank you.
Next up is the last session for today, a case presentation of varicose veins by Dr. Surya and Dr. Lakshmi Sriram, final year residents, JIPMER. The presentation will be presided over the examiners, Dr. Asayas Bosco, Dr. Ankit Jain, and Dr. Abhinay Reddy. I request them to kindly come onto the dais.
Good evening, sirs. Myself, Dr. Surya, and she is Dr. Lakshmi, final year junior residents in the Department of Surgery, presenting the case. Mr. X, a 28-year-old gentleman, farmer by occupation, resident of Dindigul, belonging to low socioeconomic according to modified Kupuswamy scale, presented with the chief complaints of swelling along the veins in the bilateral lower limb for the past 15 years. History of presenting illness. The patient was apparently asymptomatic 15 years back when he noticed swelling along the veins in both lower limbs, which was insidious in onset. Initially noticed over the feet, later it involved the leg up to the knee, as well as over a period of 4 to 5 years, and which was noted more prominently on standing and reduced while lying down. It was associated with complaints of occasional dull aching pain in the lower leg, more after prolonged activity, predominantly towards the end of the day, and relieved on rest. He has no history of skin pigmentation or ulceration. There was no history of itching. There was no history of claudication type of pain. There was no history of mass per abdomen or pain abdomen. Past history, there is no history of any trauma or surgeries. There is no history of prolonged immobilization or hospitalization. He is not a known case of diabetes, hypertension, heart disease, tuberculosis, or any other long-standing illness. Personal history, he is a non-smoker. He consumes alcohol occasionally, 1 to 2 times per month. He is a consumer of mixed diet. He has normal sleep pattern. And family history, there is no significant family history. Summarizing the history, a 28-year-old gentleman, farmer by occupation, with no known comorbidities, non-smoker, presented with complaints of gradually progressive swelling along the veins in bilateral lower limb over a period of past 15 years, associated with dull aching, pain in the lower limb, with no history of any skin changes or ulceration.
So what is the finally the differential diagnosis based on the summary? Provisional diagnosis?
Provisional diagnosis will be chronic venous insufficiency, probably due to varicose, primary varicose veins.
Why not soft tissue sarcoma?
Sir, the duration of illness, it has been over the period of 15 years, and he tells clearly he has associated complaints of swelling of the leg, which swelling along the veins that is being reduced will spontaneously or lying down. It is more prominent towards the end of the day.
So swelling along the veins makes the soft tissue swelling and the development kind of disease. or the veins are swelling up, it's not clear, no? Swelling along the wrist means what? It's a subcutaneous swelling, it's a skin swelling, it's a muscle swelling, exactly what swelling? Getting my point? Swelling along the veins means like it's something going along the veins, so what are can be implied by this statement actually?
Dilated veins.
So that is the proper term, the prominent veins or dilated veins. If you don't want to go to technical terms, you can still use prominent vein. Along the veins of the leg means which side? Medial side, lateral side, posterior aspect, anterior aspect, which part of the leg?
It was on the medial as well as on the posterior aspect of the
That's
leg.
also all these are significant, no? Because most commonly it's supposed to be which part of the
Medial aspect of the leg.
all this will help you to this professional diagnosis. So from your history, neither I'm sure it's a dilated veins, neither I'm sure about the distribution of the veins. The only thing I'm sure of, something is swelling up and something is reducing on lying down, and it is associated with dilated vein in your leg.
Yes, sir.
It's dilated pain. Can you elaborate more on that?
Sir, pain he tells predominantly towards the end of the day on prolonged standing, and he gets relieved by lying down or elevating his step.
And why are you fixed on vein? It can be any pain, but could be a vascular pain. Have you asked that issue?
I said there is no history of pain on prolonged walking, like he doesn't give like arterial claudication pain.
Yes, so at the history level, you should rule out your arterial problems. The other one, neurological problems, if it's very on a particular position or any joint problems, what you ask. See, you're fixed on vein, day one. That should not be there when you are presenting your history. That's why you have not answered many questions. You are already fixed. Before seeing the patient, your diagnosis is very percent. That's why you are going very tunnel. So you have to rule out any pain, whether it is, how sure it is. Whatever you examine, that protein might be different. So you need to rule out all the other possibilities of a lower leg swelling or which causes the leg. Those should be your negative issues. Okay.
So I'm still like how you know this pain is because of varicose vein. It can be any number of cause of leg pain. How you do those? What questions you ask? What maybe you say to do? That's my question.
Yes, sir.
How are the cause of leg pain?
Sir, pain in the leg, it can be due to arterial claudication pain or venous claudication or neurogenic claudication, sir. Like arterial claudication, we ask
Yes, before going to otherwise three other causes.
osteogenesis,
Could be
musculoskeletal claudication.
How to differentiate them?
Arterial claudication, a patient usually have pain on prolonged walking. Like during ambulation, they'll have pain, and that will cause the patient to take rest initially, which will cause relief of pain. But in venous claudication, pain will be predominantly towards the end of the day because of pooling of blood in the lower limbs. And in neurogenic claudication, predominantly has a radiating type of pain associated with numbness history. And osteogenic claudication, it will be due to different change in the positions of the joints.
Osteogenic claudication is like proper word or just not point? The problem not you diagnose by doing primary varicose vein. How you tell primary?
Sir, considering the age of the patient, he has had history of varicose veins for the past 15 years, which means from 13 years of age, he has had this complaint. So probably, and he has not had any complication till the past 15 years, he has not developed any complication, all this, and there is no other secondary causes like no history of any DVT or any intra-abdominal masses that is causing secondary varicose veins. So that I more likely to be a primary varicose.
Is the common age? Means 13 years is a common age for varicose vein.
Usually it occurs in the middle age.
Can it be congenital varicose vein? What is congenital varicose vein? Is there any term like
Congenital varicose veins are usually noted at birth due to congenital absence of valves or venous ectasia. They are noticed at a much earlier time.
Is it possible this patient comes to you with a gait abnormality and live like this potentially? What will be the TD for that this same starting from 13 years of age? Can you consider that possibility?
If limb length discrepancies there, patient, it may be syndromic, like Klippel-Trenaunay syndrome can be there.
AV malformation.
AV
or
malformation.
Spastic syndrome. Since it is starting from 13 years, progressing on 15 years, possible?
Examination.
Proceeding with examination, the patient was examined after informed consent in the privacy of a well-lit room in the presence of a male chaperone. He was conscious, cooperative, and oriented to time, place, and person at the time of examination. He was moderately built and nourished with a BMI of 26.6. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, any fetal edema or dehydration. All peripheral pulses were palpable. There were no palpable inguinal lymph nodes, and vitals, his pulse rate was 92 per minute. Regular in rhythm and normal volumic. Blood pressure was 138/72 measured in the left arm in sitting position. Respiratory rate was 18 per minute and he was afebrile. Coming to the local examination of the lower limbs, he was initially examined in standing position and later in the supine position while eliciting some tests. On inspection of the right lower limb, varicosities were noted affecting veins of the great and short saphenous system from dorsum of the foot to the knee as well as in the medial aspect of the thigh. A few reticular veins were noted over the dorsum of the foot and lateral aspect of the leg. A few scattered spots of hyperpigmentation were noted. There were no features of any eczema, ulceration, hyperpigmentation, and there were no features of superficial thrombophlebitis. Inspection of the contralateral lower limb, again varicosities were noted affecting veins of both great and short saphenous system with few reticular veins over the dorsum of the foot and few scattered spots of hyperpigmentation. Coming to palpation of the right lower limb, there was no tenderness, there was no evidence of any focal scale thickening or edema, and there was no rise in temperature. Coming to the tests, the Brody-Tenelenburg test, the test 1 was negative, implying that saphenofemoral incompetency was absent, and test 2 was positive, that is perforator incompetency was present. And tourniquet test showed incompetence of multiple below-knee perforators, and Fagan's test was done, which showed depression at multiple points below the knee in the right leg. The Morrissey's cuff impulse was absent, and Schwartz test was negative. Palpation of the left lower limb, there was no tenderness, warmth, or any focal skin thickening or edema. Brody-Tenelenburg test 1 and 2 both were positive, implying saphenofemoral as well as perforator incompetency. And tourniquet test also showed incompetence of multiple below-knee perforators. And Fagan's test showed depression at multiple points below the knee in the left leg. And Morrissey's cuff impulse was there was no cuff impulse at the saphenofemoral junction, and Schwartz test was negative. On auscultation, there was no bruit felt along the heard over the dilated veins. Systemic examination, the central nervous system, there were no focal neurological deficits, and the sensorium was complete. And cardiovascular system, S1, S2 were heard with no murmurs. Respiratory system, bilateral air entry was equal with no adventitious sound. Per abdomen was soft and non-tender with no palpable mass. And summarizing, a 28-year-old gentleman, a farmer by occupation with no known comorbidities, a non-smoker with the complaints of gradually progressive swelling along the veins of bilateral lower limb for the past 15 years, associated with occasional dull aching pain in the lower limb, and no history of skin changes or ulceration. And on examination, varicosities were noted involving great and short saphenous system veins in both lower limbs, with further tests showing incompetence of the left saphenofemoral junction and multiple below-knee perforators bilaterally, and no features of ulceration or lipodermatosclerosis. Provisional diagnosis would be that of bilateral lower limb varicose veins with left saphenofemoral junction incompetence and multiple bilateral below-knee perforator incompetence. CAP score would be C2A, EP, ASP.
The rest of junction is competent or not?
Left side is incompetent, right side.
Oh, you have done quite good. Fine. So this is which side now?
This is right side, sir,
Okay.
and this is left side.
How do you do this? Just one.
Test one would be that we'd make the patient lie down, and then we'd elevate the limb and milk the entire dilated vein, and then we would tie a tourniquet at the level below the saphenofemoral junction in the thigh, and then we'd make the patient stand and release the tourniquet. If there is rapid filling from above the level of the tourniquet, then test one is positive. And without removing the tourniquet, if there is gradual filling from below upwards, then test 2 is positive.
I check for the deepening thrombosis. How do you check?
Clinically, patient had never given a history of any bursting pain or venous claudication. So we had.
So we'll not do this.
What is the incidence of symptoms in DVT? What is the incidence of DVT? The incidence of symptoms of DVT? The DVT all symptomatic?
Chronic DVT with recanalization may not be symptomatic.
With DVT, more than 2 disease. So, patient doesn't have DVT symptoms, go to test for DVT. What test is done?
Modified Perthes test is done for.
What is done?
We again make the patient lie down, elevate the limb and milk the superficial veins, and then we tie a tourniquet at the level of the thigh below the saphenofemoral junction, and then we let the patient ambulate. If the patient complains of bursting pain in the lower limb, then it is positive.
This will not empty the vein. Remember, will empty the vein. What this will not empty the vein, just I get the ligature below the junction. Now the patient will ambulate. How much time? Inspiration, not operation. And after you have 3 to 5 minutes. What is test should be done? It is not like patient is asymptomatic, I will not do test for DVT. Why it is important?
It is a secondary cause for varicose veins, and any surgical intervention would not be advised in a setting of acute DVT. Management.
Major ablations or ligation, essential ligation treatment, what will happen if in of DVT?
Venous gangrene.
Instead of doing one test, you are risking the limb. Okay, practices should be done.
For all the postgraduates, it is a must do of participant. Don't rely on your gadgets if they are ultrasound, if they whatever it is. But clinically, you should have a clue whether it's there or not. So and it has to be there. It's modified on it's a simple test. Nothing great earlier there to cumbersome test. It's a simple test. Make it more. That's all the problem. That's all you have to do.
You said something about the brewing into the vein, no? Why are you looking for that?
Any arteriovenous malformation or AV fistula formation.
So if AV fistula formation will be there, this tendon block test 1 will be positive or negative?
Negative.
Okay, let us be negative. You did the leg and then empty the vein, what will happen? What will happen if it is AV fistula?
It will read.
Okay, refilling on its own. So if it is not refilling on its own, why you are looking for AV fistula? Was there any limb discrepancy or inspection?
No.
What is the difference between what is the name of this test? Modified participant. So what is the modification done now?
In Perthes test, they used to tie an Eschmark bandage and line up.
Okay.
And then we'd make the patient ambulate. We would only assess based on the complaint of pain from the patient. We would not be able to visualize the dilated veins.
What we do in modified Perthes?
We did not tie a bandage. We only apply a tourniquet below the abdomen.
Standing position. And what will you observe?
Dilatation of veins as well as complaint of pain from the patient.
Both have different implications. Okay, and as I said, is it mandatory? It is mandatory to do all this. Okay.
ultrasound and reflex, it may go wrong, but radiologist will not take responsibility to identify the report, it's a clinical correlation. Okay. So what is last stage? Or something?
When a dilated vein is present, we would place our hand over the saphenofemoral junction and tap the dilated vein distally. If transmitted impulse is present, then it is short test. I mean, a positive short test indicates.
What is positive? What negative indicates?
A positive indicates there is a straight column of blood. There is between saphenofemoral junction and the affected. Sir, usually we tap at a place in the lower leg and we feel for an impulse. If there is a impulse we feel at the proximal region, it means there is a straight column of blood filling and there is no evidence of any thrombus or filling defects.
Already we said about test two. Why you did chronic test again?
To identify individual perforator incompetence.
How you do that?
3 perforators are tied. One at the level of one below the SFJ and one at the thigh and one below the knee. And then we would, after milking the veins, and then we'd make the patient stand based on the level of filling. If there is spontaneous filling below the distalmost tourniquet, then it implies perforator incompetence below the level of the distalmost perforator. If on releasing one of the tourniquets, there is filling from above, then it implies a perforator in between the 2 tourniquets at that level.
In what test we tell the perforator incompetence, it doesn't localize. So tourniquets will localize the segment of perforator. Then why you do Pigons test? You already localize now. Why you do Pigons? How you do this?
Pigons test again, we would make the patient stand and with the dilated veins, we would mark possible sites of perforator and then we'd make the patient lie down, elevate the limb and milk the dilated veins and then palpate the deep fascia for defects. Palpate for defects in the deep fascia.
There is one more test given in the manual. What is the test?
Pratt's test. On that, we tie an Eschmark bandage for emptying the superficial venous system. And then while slowly releasing the bandage, we look for blowouts at the site of perforator incompetence.
For this system is very important. So a doctor, this is how they use to identify they open for perfect dilation. Now we are localizing with Doppler. Before Doppler, these 2 tests, localize the perforator and you instantly a Doppler. Can you show the photograph? Okay. The right leg, the direction of veins only below the knee or above the knee? Both above and below.
Both above.
Then right leg, SFJ is patent, no? Then how do you explain that?
Possibly perforator incompetence, Hunterian or
perforator below knee is told, above knee is competent.
Clinical examination wise, above knee is patent.
But dilatation is extended above the knee, pain. Only below knee perforator incompetent is there. It can happen. Right side, only perforator incompetent is there, but this is patent. Can vein dilate above the incompetent segments? Can dilate. You told there are some blue spots are there. What are those?
Scattered hyperpigmentation was there.
One more small spider-like thing out there. What are those?
Telangiectasias. Mentioned as pure reticular veins.
Did you mention?
Reticular Circular veins only you mentioned. No.
Look at a small spider and but black spots are. What are those black spots then?
There was no localized hyperpigmentation in the gaiters area, classical for varicose veins. So we did not attribute it to.
And what are those black spots? What do you attribute it to?
Could be early skin changes.
What is the stage then?
Maybe 4 years.
These are early skin changes. It becomes 3-4 Or can you show the grading? What is C2A?
Asymptomatic, sir.
What is symptoms? What are symptoms of varicose veins?
Patient can have dull aching pain, itching, and swelling. Swelling.
Does it have anything? What is the swelling?
Occasional dull aching pain.
Is that not a symptom then? It is symptomatic. C2.
Yes.
It is P4, sorry, we have read it now. P4A. We also not correct, it should be symptomatic. Even if we do, it is symptomatic. And one more thing we have to mention, both legs separately, right, left separately. See. What is the importance of this grading? Why it is important? Important or not? Why?
Management plan has to be made accordingly, sir. Like
How
C1.
management? How it changes management?
Asymptomatic C1 disease can be managed conservatively with competition.
Now we do this classification also, we can manage comparatively. I want classification. This is basically for communication. To uniform the communication between the surgeons, between you want to present, you can publish for uniform nomenclature, this classification has been developed.
This doesn't suffice. You have your classification, but traditionally what your examiner is looking for is left lower limb, primary varicose veins with SF incompetence, with sovereign dilated incompetence, and no evidence of DVT. That is what I am expecting from you. Later you say CEP, whatever, that's fine. But you can't just like primary, you have findings are different from both the limbs. But you can't just blindly say both lower limb, varicose veins. So primary or secondary, that is the expected, which side and where all the defects are there. And your CEP. Fine.
Should be right side, without incompetence, incorporate incompetence, without DVT, C classification, C incompetence. Right leg again same should be there. Okay? Short surface vein, how we examine? Yeah, didn't mention anyway.
Short surface vein usually dilated veins on inspection will be noted on the posterior aspect of the leg to look for SPJ incompetence due to high variability in the vein position. There are not very much tests to localize, but still we can do a ligation at the just below this SFJ, and then we can after emptying the veins, just a tourniquet just below the saphenofemoral junction and on stand. Mid thigh, we can tie a tourniquet and ask the patient to stand up. And if there is SPJ incompetence, there will be rapid filling of veins due to reflex of veins due to incompetence of popliteal junction. The veins can be filled up. The veins can be filled up through the great saphenous vein because there is we have tied a tourniquet at the SFJ.
So most of the reflex will be there at the location of the saphenopophytic junction.
Why is that it's not in a percentage? So you operate, you decided the patient says the operate. You leave the SPJ. Then you say what operation is it? So at least for documentation and for explaining the patient, this is what we need to do. Okay, so make sure examination is complete. Whatever you have seen, you write. So that communication is there.
We proceed to management.
We'd like to do a duplex ultrasound scan to confirm our diagnosis, sir. Mainly to look for a compressibility to rule out, mainly we have to look for the deep venous system as well as the superficial venous system. Deep venous system, we look for the compressibility to rule out venous thrombosis, and superficial system, we look for the main GSV and the short surface vein diameter, and then we look for the flow velocity, augmentation after reflex, and then we look for the elasticity of the vessels.
Like what is the double communication?
So deep venous system is bilaterally is compressible with no evidence of deep vein thrombosis, and superficial venous system in the right lower limb, GSV measures 6.6 mm below the inguinal ligament with competent right SFJ and high terminating right SPJ, and reticular veins are noted along the entire length of anterior medial lateral aspect and middle third of the posterior aspect of the leg, and varicosities are noted in the upper two thirds of posterior aspect of the leg. And incompetent perforators anterior medially, posteriorly, as well as laterally are present. On the left side, the GSV measures 6.9 millimeters with reflux noted at the SFJ and high terminating SPJ, with reticular veins and varicosities along the entire length of anterior medial aspect, and incompetent perforators are also noted anterior medially and posteriorly in the below the knee.
Something certain here, just measure 6.9, is it normal or normal?
Silent.
What is the cutoff? What is normal diameter?
3 mm is
3 to 5 mm, 5 mm, above 5 mm is dilated. What position you do, doctor? Duplex? Venous duplex?
It is done in both standing as well as lying down position, as well as with limb elevation also, sir. And
To look on to see in these three positions. This is some rationale, no? Why three position?
venous diameter is measured in the standing position. And maneuvers such as the Valsalva to look for reflux are done in the supine position.
Elevation? 2, 3.
Elevation would provide augmentation, sir. Augmentation can be given by either providing distal proximal occlusion or limb elevation.
Normally it is done in standing position. I don't know why they did supine position here. Okay, even also will see for reflex in standing position. Here they have in supine position, I don't know why. Okay. What is it when you say incompetence in the wall reflex?
When there is a reflux for more than 5 milliseconds, then it is incomplete.
5 milliseconds.
500 milliseconds or 5 seconds.
Okay. Why it is cut off like that? Why 5 milliseconds?
Normally, also some degree of reflux can be seen, sir.
Even normal, all have some reflex. In incompetence, there will be more reflex. Okay, even pathological, there will be some reflex. You say pathological reflex, it is reflex is prolonged for more than 5 milliseconds. Okay, next step. After this, what do you want to do? You have done reflex. Then you are after this, what do you want to do?
Management involves both lifestyle modifications, which include not performing any reduction in vigorous physical activity as well as limb elevation, and use of compression stockings. And as this patient is symptomatic, he also warrants intervention, which can be in the form of endovenous therapies for this patient.
Compression. Why you want to compression stockings?
Compression
So the
stock-
treatment or why you are giving compression stockings?
Compression stockings have also been noted to reduce the ambulatory venous hypertension.
Then we can give only compression treatment. Okay, stockings you are giving. After the surgery required or not?
For a minimum of 1 week, they should apply compression stockings after the surgery also.
Why? Why 1 week? Because of the treatment.
Prevent revascularization. Revascularization.
How prior to compression stocking is prevent revascularization?
Post-operatively for 1 week minimum.
Yeah, prior cause.
It basically prevents the peripheral cooling of the blood, sir. Therefore, there is increased augmenting increased.
Okay, I'm the patient and I said, sir, I don't want surgery, I will stocking. I'm the patient. I came to you. I'm telling that you are telling stocking, madam, I'm afraid of surgery. I will not undergo surgery, I will stocking.
In a patient unwilling for surgery up to C2 disease, we can provide up to a 3-month trial of compression stockings, but they eventually warrant an endovenous treatment.
What is the advantage of stockings and disadvantage of stockings? What is the stockings called? Full name of the stockings?
Class 2 compression.
Class 2, there is one more word.
Graded.
What is called graded? What is called graded?
There is more compression distally as compared to proximal.
Okay, there will be more distal compression at the ankle and compared to thigh. What is the grade 2 compression stockings provided at the ankle? What is the pressure?
30 mm.
30, the ankle level, 27,
20
25 at the thigh level. Okay, stockings is symptomatic relief. It is not a treatment. And it will not prevent the progression of the varicose vein. Okay, it is only symptomatic. It will compress the skin and subcutaneous tissue and prevent the edema and because of the pain. Okay, but it will not prevent the progression. The skin discoloration can occur even on compression. It may go into skin ulcer. Okay, it doesn't prevent the progression. It is only symptomatic relief. Okay, ultimate patient actually undergoes surgery. If patient is fit for surgery, based on the incompetence and the symptoms. Surgical procedure told you
If patient is unwilling for
patients willing, so what was your plan, surgical plan?
open surgery would be Trendelenburg procedure, highlight.
What is already endovenous?
Endovenous therapy could be endovenous laser ablation or radiofrequency ablation.
How that will take care of operators? Probably not going to do operation. Now we going to do both legs together or we are going to do separate setting?
We'll do them in a separate settings.
What about assistant? Can we do the same setting?
There is a risk of post procedure heat induced thrombosis. So we would not like to do it bilaterally in the same setting.
Thrombosis?
There is a risk of deep vein thrombosis in the post-operative period, so we would not like to do it bilaterally in the same setting.
So we never do bilateral. But it is not a complete contraindication. Some surgeons do, some surgeons won't do bilateral. It's not a contraindication to operate bilaterally. Okay? Depending on surgeon to surgeon also. This is preference. Some prefer like because we operate bilaterally, patient will not be able to move out of bed because of pain. Okay, complication like bilaterally, go for bilateral amputation. Some surgeons things like that. Some surgeons they say procedure risk of DVT is very less.
And why to call state surgery? Why to call patient again to OT and again to procedure again? Okay, some to bilateral. It's not a contraindication to operate bilateral SFJ incompetent in the same setting. It can be done, but if present certain it requires frequency. Why due to ablation? No, why not ligation stripping? Which is preferred?
Endovenous therapy is preferred over ligation with stripping, sir, because open ligation with stripping is noted, associated with higher recurrence rates due to neovascularization, which is not noted in procedures.
Both long term and short term. Short term, obviously, endovenous ablation has superiority over ligation stripping in terms of pain, ecchymosis, ambulation. Long term, both are, some studies say both are equally effective. Some studies prefer laser ablation over stripping. Okay, with expertise are there, better to undergo ablation. That's what American Venous Forum suggests. Ablation preferred over ligation stripping. Perforators, how you do perforators? Are asking now.
For perforators, either they can either be addressed using sclerotherapy or open perforator ligation.
Okay, what are the indication of perforator therapy? Is there any indication or any incompetence is the indication? Does all perforator need to be ligated? That all perforator incompetence needs to be dealt with.
Isolated perforator incompetence, if patient is symptomatic, then we have to.
Symptomatic means?
As in complaints of pain, we can address.
The subject incompetent perforator will intervene if C4 or more. C2, C3 will not intervene. There is sclerotherapy or ligation. Because there is a risk of skin, risk is more. Okay, we will do sclerotherapy or ligation in perforators only if patients have C4 or more. What is indication in SFJ incompetence treatment? GSP strip, ligation stripping or ablation? What are the indications? Adult perforator should we treat only C4 and above. Similarly, what are the indications of treatment in SFJ incompetence?
Symptomatic C2 and above.
C2 and above, SFJ incompetence should be treated.
Most of the centers you might not have RX. You stick to your center, what is practiced. You can tell whatever is happening in the world, that is different. But at your center, what is done, that is the best answer you need to give. If the examiner asks what else you can do, then you suggest the latest, whatever it is. You can go to a valvular intravascular repair, all those things are there, theoretical, lots of things are there. In your exams, you tell what is practiced in your center. And you should know what are the recent advances in that particular. Yeah, so, thank you.
Thank you, sir.
Thank you, sir. I now request the examiners to hand over the presentation, hand over the certificate to Dr. Surya and Dr. Lakshmi Sriram. Dr. Surya. And Dr. Lakshmi. I now call upon Dr. Balamurugan to come up on the stage and illustrate the examiners. Dr. Asayas Bosco. And Dr. Raghunathan. Thank you, sir. We thank all the faculty and delegates for making today's event successful. I request the delegates to assemble at 8 AM tomorrow at the same venue. Thank you. There's an exciting announcement right now. Tomorrow at 4 p.m. in first floor, we'll have a quiz session. So I request all of you to install cover tab for the exciting session that will happen at 4 p.m. Thank you.
Pointer, someone took me. When the pointer notice for sir, who?
It was here only.
Last case presentation was there, man, where it is.
All are in this.
No, I think they come up live.
This was started.
No, not mail. Same, that same whatever file you sent to me. Hey, you sent me, na, that I sent it to my mail. This only I opened and then I mailed it to me and then I don't.
Exciting prices to be won. They suppose install what is that code? Kahoot. Who made this Kahoot?
What is this for?
Kahoot for this.
This is the one which is tomorrow. The wrong one.
How
wrong?
Whatever they are thinking, like from drive by
It's okay.